Preface and Introduction to War Surgery From Firing Line to Base by Basil HUGHES and H. Stanley Banks. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Reading by Matt Perard. Preface and Introduction. Preface. This work is an attempt to describe as briefly as possible the treatment of wounded men from the time of the infliction of their wounds on the battlefield to the time when they leave the base hospital, either for duty or for treatment at the different institutions set apart for special kinds of infirmity. We have endeavored to describe methods of treatment whereby the stiffness and incapacity which follows wounds may be reduced to a minimum, and which will place severely wounded men under the best possible conditions to benefit from subsequent orthopedic treatment. The work embodies the newer and up-to-date methods of wound treatment, and older methods have not been discussed. The chapter on joints contains photographs of specimens which we have prepared, and which we hope will make clear to the surgeon the nature of the synovial sacs with which he has to deal in the case of infection. Short chapters on burns, amputations, and diseases peculiar to airmen have been included, as little has appeared in the literature on these subjects. The general health of the troops while in trenches has been discussed, as we are convinced that prophylactic measures mean everything to the soldier when his day of misfortune arrives. The treatment of fractures has aimed a rapid sterilization and early secondary suture in order to produce the minimum of stiffness and disability. We have not included the later treatment advocated for chest injuries, partly on account of insufficient experience in these methods, and partly because the treatment we have recommended has given such uniformly good results. A special chapter written by Lieutenant Colonel L.F. Smith, C.M.G., on the part played by malaria and dysentery in complicating wounds has been included, as this complication in the Eastern Theater has been a serious problem. This chapter includes the subject of transfusion of blood, which we have used with success in the case of wounds complicated by gas gangrene infection. The chapter on gunshot injuries of the head will, we hope, make clear the general line of treatment to be adopted. For diagnosis and valuable help in these cases, our thanks go out to Colonel Sir Purvis Stewart, KCMG, AMS. Abdominal work is based on our experience at a busy casualty clearing station in France, and though the opinions we have expressed may differ from those of many as regards the treatment of these cases, yet our statistics show a recovery of 62%. An attempt has been made to illustrate the book so as to show as far as possible all points emphasized in the text. For any bad illustrations, our apology is that getting photographic material in the East was a difficult problem. Our experience is gleaned from 3½ years' work both in the Western and Eastern theaters of war, and comprises 18 months spent with different regiments in the firing line, 8 months with a field ambulance, 4 months with a busy casualty clearing station in France, and a year at a base hospital in the East. We find that the Carroll-Dakin treatment, when properly and systematically applied to war wounds, gives results far superior to those that can be obtained by any other system of treatment. For all shortcomings in this work, and we know they are many, we offer due apologies, but the work has been compiled under active service conditions in the East, where there was no access to any library of reference, and where the climate tends to the lowering of energy and the production of brain fag. The work, then, represents 3½ years of purely personal experience. We owe a large debt of gratitude to the higher authorities who personally interested themselves in the work and gave us every assistance. We should also express our thanks to our commanding officer, Lieutenant Colonel L.F. Smith, CMG, who, under difficult circumstances, has also given us every assistance and encouragement; to Lieutenant F.C. Sprawson, who has undertaken the heavy work of correcting the proofs and of preparing them for the publishers; to Captain J.T. Carson, R.A.M.C., for providing X-ray prints; to Sergeant Major Powell, R.A.M.C., for the colored plates and several drawings; to Mrs. Hughes for other drawings; and to Private Garrett, R.E., and Private Hale, R.A.M.C. Basil Hughes, H. Stanley Banks. London, August, 1918. Introduction. This book will appeal to all keen surgeons, for it is founded on practical experience in every part of the field. The most important part of the experience was gained during 18 months' surgery in the Salonika area. Major Basil Hughes and Captain H. Stanley Banks were working during this time at a hospital which was constantly busy, for it received the majority of the seriously wounded. As consulting surgeon to the British Salonika force, I had the pleasure of seeing the methods adopted and the results. The work is essentially practical, and represents solid, progressive surgery. The many problems arising in connection with the wounded at each stage of their career are clearly discussed, and a definite line of treatment suggested for each. Gunshot fractures are perhaps the greatest test of war surgery, and this subject is dealt with in detail. The principles advocated have produced results favorable beyond all expectation, and have very considerably shortened the period of treatment of wounded men. Two principles are kept to the fore. The first is that an organized plan of treatment for the wounded is essential. The treatment originated in any one unit should be so planned that it can be carried on and completed in the other units to which the patient is transferred later. Standardization and continuity of treatment must be established as far as possible, for end results are again and again vitiated by diversity of methods and discontinuity of treatment. To effect this, Carroll's method was selected as appearing to give the most consistent results, and experience of other methods of wound treatment has not led the authors to modify this opinion. A definite plan of treatment, in which Major Hughes took a chief part, was developed in a certain area. Carrel's method was instituted as the standard treatment in the units at the front, or on the trains and at the base. After the healing of the wounds, treatment was completed at an orthopedic depot. This scheme produced most satisfactory results. The second important principle is that the surgeon and the bacteriologist must work together. Rational wound treatment is impossible without constant bacteriological help, and a large share of recent surgical progress is due to bacteriological research. The success of Major Hughes' work is due to the fact that he has adopted definite lines of treatment, and has utilized all the guidance and assistance which bacteriological cooperation places at the surgeon's disposal. T. Crisp, English. End of Preface and Introduction to War Surgery, From Firing Line to Base, by Basil Hughes and H. Stanley Banks. Chapter 1. Introductory of War Surgery, by Basil Hughes and H. Stanley Banks. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Reading by Matt Perard. Chapter 1. Introductory. The treatment and care of the wounded forms but one branch of the work for which the Army Medical Service is responsible. Few besides those who have had experience in every unit from the firing line downwards will ever realize what a vast machine or organization this service is. the hygiene and care of the troops, the evacuation of wounded men from the field of battle, attention to their wounds on the lines of communication, the provision of transport, the treatment of tropical diseases, and hundreds of other problems which would never occur to the casual observer, have all to be dealt with. There have been, and are still today, many critics. Criticism is useful if it comes from those who are in a position to criticize, that is to say, if it comes from persons who have had actual experience in every unit of the medical services, from a regiment to the base. We speak with feeling on this point, for we have been concerned with all units from the firing line to the base, and have both seen and realized the most insuperable difficulties that have been overcome. Any reasonable suggestions towards the improvement of methods or of details have always been readily received and considered by the higher authorities, and if any suggested scheme has seemed feasible, it has been adopted without delay. It would be absurd for anybody to suggest that an organization like the Army Medical Service, largely augmented by recruits with little knowledge of Army organization and administration, could go straight into a colossal war like the present one, and run like a tuned-up and well-oiled machine. We have all had to learn our job in the present war, and nobody more than the civilian surgeon. War surgery differs in many ways from the surgery of civilian practice. In the civilian hospitals each surgeon has his own operating day, and in some instances his own operating theatre, his own house surgeon, his own anaesthetist, his own particular instruments, and his own wards. He is able to see his cases before operation, and to keep them in hospital a day or two in order that they may be the better prepared. And finally, he sees the progress and end results of his cases. In brief, the patients benefit by being seen and attended throughout their convalescence by the same surgeon, while the surgeon benefits by seeing the end results of his treatment. In wartime, one patient may pass through the hands of many surgeons, each of whom may have different ideas on the treatment of his wound. Thus, one surgeon may prefer to use drainage tubes, another may prefer saline treatment, another fomentations, another pastes, and so on. This state of affairs is bound to militate against good end results. It was on this account that in the Balkans a systematized treatment of wounds was tried at the suggestion of the higher authorities, for it was thought that if a certain definite form of treatment could be started as soon as possible after the man was wounded, and this treatment could be carried on until the wounded man reached the base hospital, where the same treatment would be continued, then quicker and better results would be obtained, which would mean less suffering to the wounded man, economy of man-power, and a saving of expense to the state. The Carrel-Dakin system was accordingly instituted. Wounds were dressed with the hypochlorite antiseptics at the field ambulances, and from these units the wounded were quickly transferred to the clearing stations. Here the wounds were excised and a Carrel-Dakin dressing applied. The patients were sent on to the base hospitals as soon as they were fit to travel, hourly or 2-hourly installations of the antiseptic into their wounds being carried out on the hospital train. At the base hospital, sterilization of the wounds was continued by the Carrel-Dakin method, and when sterile, the wounds were submitted to secondary suture. The transport from the firing line in the East is difficult, but the way in which the difficulties were overcome reflects great credit on those concerned, for wounded men reached the base in what appeared to be an incredibly short space of time. Wounded men had of necessity to be kept in the base hospitals until their wounds were soundly healed. Hence, on this front, medical officers have been able to follow their cases through and witness the end results. An orthopedic depot was established, to which cases of compound fracture of bone, injuries to joints, and the like, could be sent for massage and further treatment, and by visiting this institution the subsequent progress of all wounded men could be seen up to the time when they either returned to duty or were sent on a hospital ship in such a condition that they could look after themselves and jump into a boat if necessary. Such a scheme of continuity in treatment was the nearest approach to keeping a certain number of patients under one man's care, and the whole system worked admirably. Wounds of appalling dimensions and severity have under this treatment been sterilized and sutured within 10 days of their infliction, which has saved the patient much pain, weeks in bed, much incapacity, and the state considerable expense. The whole treatment, if properly carried out, is painless from start to finish, and many limbs and lives have been saved, which would by the older methods have undoubtedly been sacrificed. Severe wounds involving compound fracture of such bones as the femur, tibia, and humerus have been sterilized and sutured within so short a space of time as a fortnight following the injury, and the patients suffering from such injuries to the legs have been about on crutches at the end of the 5th week. It has been argued by some that the Carroll-Dakin treatment cannot be carried out on a large scale without an increased staff. This is absolutely contrary to our experience, for we have found it possible to adopt it universally in a large base hospital in the East, where part of an already diminished staff is constantly laid up with tropical diseases. The equipment required for the carrying out of the treatment is small, and the cost per patient taken over a series of 2,000 severe wounds has worked out at 7 shillings. End of Chapter 1. Introductory, by Basil HUGHES and H. Stanley Banks.
Chapter 2 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Sean Grabosky, Orlando, Florida. War Surgery, From Firing Line to Base, by Basil HUGHES and H. Stanley Banks. Chapter 2, General Classification of Wounds. Non-penetrating wounds. This class of wound includes all cases in which the missile has not penetrated the soft parts, and comprises contusions, slight abrasions of the skin, and fracture of bone. It forms a considerable percentage of all wounds in the present war. Contusions may be either superficial or deep, and may vary from superficial hematoma to most extensive damage of muscle and even viscera. Contusions are most commonly caused in one of two ways. 1. By a spent piece of shell, usually a nose cap, though often by a considerable-sized piece of shell casing. Or 2. By the falling in of a dugout or a piece of the parapet, which usually buries the wounded man. Superficial contusions may occur on any part of the body, and in the case of the upper arm or thigh are quite sufficient to put a man temporarily out of action, the effect being similar to a severe punch with a closed fist. A superficial contused wound of the abdomen or back should always be looked upon with caution, for a number of cases can be recorded in which a contusion in these situations was apparently slight, but severe damage to abdominal viscera had resulted, calling for immediate laparotomy. Contusions in the region of the loins should be carefully watched, as a number of cases have been followed by hematuria, although the contusion itself looked trivial. An apparently simple contusion of the thoracic wall may involve a fracture of one or more ribs, whereas a contusion of the soft parts in the immediate neighborhood of the spinal column may be associated with severe spinal concussion. Deep contusions may involve some or all of the structures down to and including periosteum, and may range from severe bruising to actual tearing and division of muscles and other structures. These wounds are exceedingly painful. There is much swelling and later discoloration of the part, and they incapacitate a man to practically the same extent as a fracture. Frequently, they are associated with the formation of hematoma, either in the torn muscles, the result of injury to vessels, or subperiosteally. Should big nerves be involved, paralysis or paresis of the group of muscles supplied by the nerve, depending on the amount of the damage the nerve has sustained, will result. A deep contusion of the erector spinae is among the most serious of this class of case. It results in stiffness and pain of a most persistent kind. Deep contusions are serious wounds in that they put a man out of action for the same length of time that a fracture would, and they call for as much, if not more, treatment. Yet, owing to their nature, they are liable to be overlooked. Much thickening and fibrosis may result, and convalescence be prolonged. Non-penetrating wounds may result in fracture of bone, simple or compound. These fractures usually result from the blowing in of a dugout, but they can also be caused by a direct hit with a spent piece of shell, and this is most frequent in the case of the ribs. Compound fractures from such causes may be of an extremely extensive character, especially if the roof of the dugout contain heavy timber. Examples. 1. A private, name omitted, 7th West Riding Regiment, while asleep, sustained a fracture of both tibiae and fibulae, owing to a direct hit on the roof of his dugout. The fracture in the case of the right leg was compound and extensive. In the case of the left leg, it was simple. On digging him out, it was found that a beam in the roof of the dugout had fallen across both his legs. Example 2. 2 privates, names omitted, 5th West York's Regiment, were asleep in their dugout which just admitted 2 men, leaving a space of no more than 7 or 8 inches at the most between them. A 5.9-inch high-explosive shell entered the wall of this dugout, and burrowed itself into the earth in the small space of ground that lay between the 2 men. The shell failed to explode, and finally stopped in the ground beneath one of the privates, fracturing his scapula. The skin covering the scapula was unbroken. Example 3. A captain, Royal Army Medical Corps, was struck in the back by the shell nose of a whiz-bang, resulting in the fracture of 3 ribs. The skin over the site of the fracture was unbroken. Penetrating wounds. Penetrating wounds form a large and important fraction of the total wounds of the present war. They comprise every case in which the missile has entered the soft parts of the body but has not emerged. The wound of entry may vary from an excessively small opening, indeed in some cases scarcely visible, to a ragged tear of the most extensive dimensions, the so-called penetrating lacerated wound. As an example of a penetrating wound of imperceptible dimensions may be quoted the case of a gunner. A shell burst within 50 yards of this man, and he was perceived to fall. On examination 3 minutes later, he was found to be dead. A most careful search of his body revealed no trace of a wound. Autopsy revealed a wound of the heart and aorta, the missile having entered the thorax from behind through a valve-like opening in the skin which was so small as to escape a very careful and thorough examination. Penetrating wounds present considerable difficulties in treatment, as one cannot be sure, without the aid of a skiogram, which direction the missile has taken, or at what depth from the surface it is lying in the tissues. Certain important points may, however, be found out by observation and palpation. Not infrequently, the missile can be felt under the skin at some distance from the wound. If this be so, important information is afforded the surgeon, as not only is the extraction of such a missile easy and rapid, but the surgeon now knows its path, and the surface anatomy of such a track will give him some idea of what important vessels, nerves, etc., are likely to have been damaged. The wounded man will often say that he feels pain in a certain area at a distance from the wound, and can direct the palpating fingers to a spot of maximum tenderness. Careful palpation of such an area will, in 9 cases out of 10, reveal the missile, which can be detected to a depth of from 2 to 2.5 inches below the skin surface. Examples. Example 1. Private, name omitted, wounded July 1st, 1916, presented a penetrating wound about the size of a 2-shilling piece just above the right clavicle. He complained of pain at the bend of the elbow. Palpation revealed a circular piece of metal, which was removed. This was a piece of the mechanism of a trench mortar bomb, and was the size of a 5-shilling piece. Example 2. Private, name omitted, wounded July 1st, 1916, presented a penetrating wound just over his right shoulder blade. He complained of pain and a small swelling in his right groin. Palpation showed a shrapnel ball to be present, and this was removed. Similar cases are very numerous, but they show what important help the patient can give to the surgeon. Again, in the case of a small penetrating wound of the thigh, it is common to see the thigh very distended and tense, and though pulsation may be felt in both anterior and posterior tibial vessels, it is obvious that a vessel of considerable size has been ruptured. This gives the information that the missile lies deep in the limb, and its immediate removal, with arrest of the hemorrhage and turning out of the blood clot, is necessary. It is always worthwhile to find out from the patient, whenever possible, the posture he was in when he received his wound. For example, whether he was sitting, lying flat, kneeling, or whether he was walking or running. This is especially important in regard to penetrating wounds of the joints, in particular the knee joint, for such foreign bodies are more easily extracted with the joint and the degree of flexion or extension that obtained when the missile entered it. Penetrating wounds of the head, spine, abdomen, and thorax form the most serious cases, as there is often little outside indication of the internal damage done. Symptoms in these cases must be the surgeon's first guide. Penetrating wounds may involve fracture of bone, ranging from a groove or gutter fracture, or perforation, not destroying continuity, to the most extensive comminution. An important point to remember is that the size of the wound of entry is no guide to the size of the missile. The skin is a very elastic structure and stretches before the ingoing missile, recovering itself afterwards. Consequently, in most cases, the skin wound is smaller than the missile which caused it, and it gives absolutely no indication at all of the extent of damage done to tissues within. In the case of penetrating wounds of the chest, the skin wound is not an indication of the actual point of entry into the thoracic cavity, as the chest wall is a movable structure. Consequently, the skin wound is often at a higher or lower level than the actual point of entry into the pleural cavity. The track of entry is thus valve-like, and this aids in the formation of surgical emphysema. With the missile, there is frequently associated a piece of clothing, or occasionally foreign bodies of a different nature, such as articles which may have been carried in the soldier's pockets. Such have been found most often in the thigh, having been in the trousers pocket at the time of being hit. Thus coins, buttons, pencils, pieces of string, and in one case a large piece of a miniature New Testament, have been extracted from wounds in the upper thigh, and the presence of such foreign bodies should always be borne in mind when dealing with wounds in this situation. Penetrating wounds may be the result of rifle or machine gun bullets, shrapnel bullets, or high explosive of some kind, whether shells, trench mortars, or grenades. Unless the missile will be stopped in its course by bone, these wounds are mostly caused by bullets fired at long range, or by spent pieces of shell. One exception is the case of wounds caused by certain types of hand grenades, where the velocity of the fragments is not great compared with other types of high explosive, and the fragments lodge and remain in the tissues. Such grenade wounds are extremely serious, as they are multiple. The fragments carry in much dirt and clothing, and the skin is frequently burnt, thereby giving rise to shock of severe intensity. Septicemia is very likely to occur in this class of wound. Penetrating wounds, especially those resulting from pieces of shell or grenades, are associated with a disruptive effect in the soft tissues which are involved. The explanation of this is a matter of dispute, but it is suggested, and very reasonably, that any missile, whatever its nature, carries in front of it a cartridge, so to speak, of compressed air, and this on entry into soft tissues produces a disruptive effect. The result is that the muscle bundles are forced apart, cut off from their blood supply, and open planes are formed, along which aerobic and anaerobic infection can spread. In addition to this, the soft parts get a knockout blow which renders them, especially muscle, for the time being lifeless, and therefore very prone to infection. This condition of muscle is the so-called, quote, muscle stupor, end quote, of the French. Such tissue looks dry, and the muscle seen soon after injury gives the appearance of butcher's meat. It does not bleed when cut, and it does not contract when stimulated. Infection spreads with alarming rapidity in this damaged tissue, and in a few hours a whole limb may be gangrenous. This disruptive effect extends into the tissues for some distance from the wound of entry, a point of the highest importance to be borne in mind by the surgeon, as this damaged muscle forms excellent pabulum for the virulent bacteria of the present war wounds. Penetrating wounds may be single or multiple. In the latter case, shock is an important factor to consider, although no vital part has been involved. Bomb grenade wounds are almost always multiple, and above all others give rise to very severe shock. One example of this class of case may be cited. Lieutenant, name omitted, while standing at crossroads after dark, was suddenly riddled with 8 machine gun bullets. Not one of these bullets struck a vital part, yet he died 20 minutes after injury with symptoms of shock. In all cases of penetrating wounds, it must be remembered that the missile with concomitant foreign bodies are still in the tissues, and their early removal is of primary importance, as they are dangerous foci of sepsis. The methods of removal will be referred to in another chapter. Perforating wounds. Perforating wounds entail a wound of entry and a wound of exit. They possess an important advantage over penetrating wounds in that the missile has emerged and no longer remains in the tissues. The actual damage to tissue varies, but on the whole, perforating wounds have a better prognosis than penetrating wounds. Perforating wounds are most often the result of missiles fired at close range, and may comprise A. a small hole of entry and a small hole of exit, B. a small hole of entry and a large hole of exit, or C. a large hole of entry and a large hole of exit. Class A, for the most part, comprises wounds caused by rifle and machine gun bullets, shrapnel bullets, or small pieces of high explosive. This type of wound is known as the Seton wound, and the damage involved may vary. Thus, a bullet may traverse the thigh, damaging no important structures, both entry and exit wounds healing and leaving no incapacity. Again, a similar bullet may traverse the thigh in a direction almost identical with the preceding, and after an hour or two, the thigh will be acutely swollen and tender, denoting damage to an artery of considerable size. A Seton wound gives an observer some idea what damage to expect, since the course of the missile is approximately known. Surface anatomy, though useful, is not always a true guide to damage done, because many cases have been seen where the track, judged by the inlet and exit wounds, passed right across the course of such structures as the femoral artery, the sciatic nerve, the brachial artery, etc., without damaging them. Here, again, there are 2 important points to consider on which the wounded man can usually give information. 1. Was he running or walking when wounded? Or 2. Was he laying down or standing still? If the condition 1 obtained, then the wound in the skin does not correspond in position with the wound in the deep fascia and muscles at the site of either entry or exit. The skin wound may be separated from the deeper wound by as much as an inch, but usually a little less. The reason for this is obvious, because when the body is in motion, the skin is stretched in some parts and relaxed in others. The same phenomenon occurs to a more marked degree if the bullet strikes the part obliquely. The difference in level between the perforation of the skin and that of the deep fascia and muscles by the same missile is very noticeable when operating upon these wounds. If condition 2 is obtained, then the entry wounds in the skin and fascia approach practically the same level, and the inlet and exit wounds give a fairly accurate estimate of the course of the missile. A Seton wound may involve bone in its course, simply perforating it, this being seen most frequently in the epiphysis of the long bones. Clean perforation of the bone, however, is comparatively rare. Seton wounds may involve joint cavities, their valve-like nature in such situations being of great value in preventing escape of synovial fluid and blocking the road to infection, for small Seton wounds of joints are mostly sterile. A Seton wound involving the abdomen or thorax may either give rise to insignificant symptoms, though from surface anatomy it would appear that serious damage had occurred, or they may involve the viscera, causing many perforations in the case of the intestines and serious damage in the case of the lung, liver, or other solid abdominal viscera. Seton wounds in the neighborhood of large arteries are the commonest cause of traumatic aneurysm. Swollen thighs, the result of hemorrhage, if watched and kept at rest, provided there be good circulation in the foot, slowly resume their normal size, and as the swelling and bruising subside, a pulsing swelling with a bruit over it makes its appearance. This has happened in quite a number of cases, not only in the thigh, but in the neck, upper arm, the forearm, and elsewhere. When once the aneurysm is established and the part has assumed its normal size, operative treatment is simpler and safer than if carried out at once through swollen tissues. Seton wounds situated in the forearm or leg and traversing the interosseous membrane, especially if the part be swollen, should always be looked upon with caution, and if possible, left alone, provided the circulation in the hand and foot are good. Because these wounds, if opened up, often give rise to most intractable hemorrhage, which is very difficult to control, and once controlled, is very prone to recur. Wounds in these situations frequently involve the anterior tibial or posterior interosseous nerves, giving rise to foot and wrist drop. This type of wound, involving a large trunk such as the sciatic, musculospiral, the median, or the trunks of the brachial plexus, may either transfix the nerve or partially divide it. Severe pain, not immediate, but following a few days after the injury, with trophic symptoms, later both in skin and muscle, are the result. Seton wounds about the spine may involve the spinal cord or the large intra-abdominal or intrathoracic vessels. Death in these cases is rapid and painless, and many have been seen in the line. Class B. This kind of wound is almost invariably the result of a missile fired at close quarters striking a bone. A rifle bullet in the beginning of its course develops heat to such an extent that the thinly encased lead, though not molten, is soft. Consequently, when a hard structure like bone is struck, the bullet is readily flattened out. Sometimes the lead escapes from its thin nickel casing, portions of it being left behind in the tissues, as shown by the X-ray. In other cases, the bullet casing only is found, the lead having gone on. When the bone is struck, it is fractured, and not only does the flattened bullet, or its components, continue its course, but broken fragments of bone are pushed on before it. The result is a large lacerated wound of exit. The same result obtains, only to a more extensive degree, when the missile is a piece of shell. The damage to tissue in this type of wound is often most extensive, owing to severe comminution of the bone entailed. The exit wound, when first seen in the line directly after injury, looks fresh, but very soon the damaged muscle and other soft parts become swollen and edematous, and by the time the casualty clearing station is reached, swollen and apparently lifeless muscle is seen in the wound. Fragments of bone may be protruding into the wound, and in extreme cases, a limb may be hanging on by only a few tendons, skin, and other mutilated structures. Again, the continuity of the bone may not be destroyed, but the bone only chipped. Here the missile, if it be a bullet, has turned in its course by slight impact with the bone, and as such has caused a large exit wound with much damage to the soft structures. Perforating wounds of the head, and often of the thorax, come under Class B. In the case of the head, the missile traverses the bony cranium twice. The exit wound is large, and a quantity of brain matter is usually protruding. A great number of these cases die in the line. Unconsciousness is instantaneous, the pulse rate becomes rapid, and death soon follows. A few cases reach the casualty clearing stations and the base hospitals, but recovery is extremely rare. Wounds of the thorax belonging to Class B have, with few exceptions, died in the line. In a large number of cases, the wound of exit has passed all description, and death has fortunately been instantaneous. In 2 cases, seen in the line, who were still living, the greater part of the lung, which was extrathoracic and had been soiled with trench mud, was washed and put back. The large hole in the thoracic wall was plugged with an ordinary boiled towel, and these cases reached a casualty clearing station. One of them lived for 3 days, and the other for 4 days after the day of the wound. This class of wound is met with in the abdominal area, and it is not uncommon to see a large piece of omentum or a loop of intestine protruding from the exit wound. This type of abdominal wound is often conspicuous by the absence of shock. A number of men so wounded have walked from where they were hit to the regimental aid post, and in some cases to the advanced dressing station. They have arrived at the casualty clearing stations little the worse for the journey, and after the operation have done well. The extruded omentum or gut is usually soiled, but so long as there is no gross damage to viscera, the prognosis is good. One example from many in the line may be quoted. Sergeant Name Omitted was wounded by a rifle bullet on the night of November 20, 1915. The bullet had entered the right lower abdominal quadrant, had turned in its course, and emerged in the left lower quadrant. A large piece of the omentum and small intestine were protruding from the exit wound. He walked to the regimental aid post, a distance of 150 yards. There was no shock, and the man was cheery. He reached the casualty clearing station and made a good recovery, being heard of later in England. Class C. These wounds comprise a large hole of entry and a larger hole of exit connected by a ragged and torn track, which is overhung by a bridge of tissue consisting of skin and deeper structures. This bridge, which may or may not contain such important structures as the femoral artery, the sciatic nerve, etc., are usually in a very torn and bruised condition, and is exceptionally prone to become gangrenous. The disruptive effect produced in these wounds is great, and if a bone be involved in the case of an extremity, complete dismemberment may occur. These wounds are of a very serious nature, owing to the amount of damage done, and to the rapid onset in them of virulent infection. They need early and thorough handling in order to save life and limb. This class of wound is usually the result of a direct hit with a piece of shell of considerable size or a ricochet bullet, and it is surprising what damage a ricochet bullet can inflict. One instance may be quoted of Private Name Omitted who was walking at night along a road 500 yards in front of the German trenches. He was hit on the right side of the head by a ricochet bullet, which took away the whole of the calvarium and scattered most of his brain over a comrade who was with him, but who escaped without injury. In Class C is included the type of wound caused by large pieces of high-explosive shell, where the entry and exit wounds no longer exist as such, the overlying bridge of tissue having been destroyed by the missile. The pieces of shell causing these wounds vary in size and shape, but pieces can at any time be found on the battlefield a foot or more in length, with an edge as sharp as a knife, or smaller pieces bearing one sharp edge and irregularly rough along the other edges. In fact, an endless variety, all equally deadly but too numerous to mention, may be met with. Some of these wounds are of an appalling nature, and almost indescribable. Instances are 1. A sentry completely cut in half at the level of the second lumbar vertebra by a long, sharp piece of shell. 2. Decapitation of a sentry by a similar piece of shell. 3. Anterior abdominal wall carried away, with complete exposure of viscera. Or 4. Both buttocks carried away. Many similar instances could be quoted. The majority of men with such wounds usually die before they can be got out of the line, and very few, if any, reach the casualty clearing stations. Fortunately, there seems to be little or no pain following the infliction of these ghastly wounds, and the end has invariably been a painless one, at any rate in the case of those dying in the line. Disruptive wounds. The disruptive effect produced in tissues by different missiles after penetration has already been referred to. Disruptive phenomena also occur where there has been absolutely no evidence of tissue penetration and appears to be the result of the burst of a large high-explosive projectile in the close proximity of the individual affected. Disruptive wounds have been observed most frequently to follow the explosion of large trench mortar projectiles, the so-called oil cans. The explosion caused by one of these projectiles is terrific, though the effect is very local. It has happened on more than one occasion that one of these bombs has exploded in a certain traverse, and men in the next traverse have escaped without injury. Should, however, the trench be one without traverses, the force of the explosion travels along it and can be unpleasantly felt at a distance of 200 yards. A Minenwerfer consists of a thin casing of steel, not more than 1/8 to 1/4 of an inch in thickness, and is tightly packed with high explosive. Only a small fraction of the bursting force is spent in splintering the thin envelope, leaving the greater part free for destructive purposes. It would appear that within a certain radius of such a burst, an extremely powerful centrifugal force is produced, perhaps better designated a rending force, which is highly destructive in its effect on the individual. Similar phenomena are observed when an explosion takes place within a confined space. For instance, if an ordinary Mills bomb, popularly known as the Newtown Pippin, explodes in the open, its effect is local, and not much is felt of the explosive force at a distance of 30 yards. Should it burst in a trench, the explosive effect is far greater, but should it burst in a confined space like a dugout, the effect is most destructive. Within a German dugout, which was entered after being bombed, all that could be found in the way of human remains were pieces of flesh, hair, and brain plastered on the dugout wall, while pieces of bone with thoracic and abdominal contents were strewn about the floor. This example will give some idea of the rending force of these small weapons when exploded in a confined space. 2 signalers were in undisclosed location, Salient. A Minenwerfer exploded close to the signal dugout. Nothing more was seen of either of these men except one of their lower extremities, which was hanging in the German wire about 150 yards away. It was recovered by a patrol in the evening and was found to be completely disarticulated at the hip joint. It is a rather significant point that in this case of wound disarticulation, or, more correctly speaking, avulsion of the limb at the shoulder or hip joint, has been more common than avulsion at any other joint, and further instances could be quoted to support this statement. The Minenwerfer is responsible for a large number of the cases diagnosed as shell concussion. One fortunate point about these oil cans is that during the daytime they can both be seen and heard, and so men have time to move along the trench and get to a safe traverse. An interesting case worth recording is that of Major, name omitted, who received a fraction of the explosive force of one of these missiles. It shook him badly and left him rather deaf, but he decided to carry on. 5 days later, he had a copious clear discharge from his right ear, evidently cerebrospinal fluid. He was sent down to the base hospital, where it was found that he had sustained a fracture of the basis cranii. He made a good recovery. Incised wounds. Under this heading come a miscellaneous collection of wounds inflicted with different weapons of war, but all falling within the category of incised wounds. At the field ambulances and casualty clearing stations, it was remarkable how very few of these wounds were seen. During a period of 3 months, at a busy casualty clearing station, when active fighting was in progress, not more than half a dozen cases came through. On another front, out of 1,000 wounded men reaching a base hospital, only 8 presented wounds that had been inflicted with sharp instruments. These wounds usually result from hand-to-hand fighting and bayonet charges, and, with the exception of a few cases, are very fatal, the wounded usually dying where they fall. The commonest weapons used for inflicting these wounds are the bayonet, dagger, knobkerrie, and the butt end of a rifle. A bayonet wound may range from a stab of variable depth to a cut of 3 or 4 inches in length. The thrust is usually directed at either the throat or the loins. One instance may be recorded of a wounded German who had been lying out nearly 24 hours. When he reached the casualty clearing station, it was found that his throat was cut across and his trachea was severed, yet no artery of any size had been damaged. The wound was extremely foul, and maggots were coming out of the trachea. He died 3 hours after admission. A few of our own soldiers have been accidentally wounded with a bayonet through hurriedly getting back into the trenches from no man's land, some part of their body, most often the thigh, coming in contact with the point of an upturned bayonet. The authors, however, cannot recall a single case of a wound caused by a German bayonet, though such a wound would probably be severe, seeing that a number of German bayonets are serrated. There is rarely, if ever, any external bleeding from a bayonet stab, and once it is thrust home, the skin and muscles close tightly on the steel so that a considerable effort is required to extract it. This difficulty is overcome by giving the rifle a half twist to the left when extraction becomes easy. Dagger wounds are short incised wounds of variable length and depth, and of those seen only one was of a serious nature, the blade having entered the peritoneal cavity. This particular case recovered. They differ in no way from stabs and cuts in civil life. Knobkerrie wounds are very fatal, and death is usually instantaneous. 2 Germans reached a casualty clearing station, but died shortly after admission. One had the greater part of his scalp hanging down and a most extensive fracture of the calvarium. The other had a large clean-cut wound on the right side of his head and an extensive fracture of the basis cranii. Strictly speaking, these wounds are not true incised wounds, being inflicted with a blunt instrument, but for convenience they are included here. Wounds inflicted with the butt end of a rifle may be as cleanly cut as if a knife had been used. They are usually associated with fracture of the bones of the skull and face and are very fatal, few surviving to leave the battlefield. Bites are not uncommon wounds in close hand-to-hand fighting, and wounds of this nature are frequently inflicted by the Germans. These wounds are not of much importance, and no harm has come of them. Burns. Burns inflicted by the enemy may result from the bursting of a shell, especially the incendiary type, or from the bursting of a bomb in the immediate neighborhood of the individual. The extent of these burns varies greatly and may range from a superficial erythema to most extensive charring. Superficial erythema is usual in bomb wounds, and with it the skin is peppered in many places with minute fragments of dirt and grit which have been carried into the tissues. The uniform, to a large extent, protects the body. Consequently, it is the face and hands that usually suffer, and many of these cases are seen at the casualty clearing station. The eyebrows, mustache, and part of the hair are singed, and in not a few cases the eye itself is involved. The whole face and neck are very much swollen, and the eyelids cannot be voluntarily opened. The back, arms, and thighs are sometimes involved, but not so frequently as the hands and face. This type of wound occasions considerable shock, but on the whole the prognosis is good if the eyes are not too badly damaged by heat or particles of grit. Where extensive charring has occurred, death rapidly follows, if it is not instantaneous. The following is an instance. A battery, whose name has been omitted, Royal Garrison Artillery, was being heavily shelled one Sunday afternoon. Close to this site were some transport lines, and at the time a number of the personnel were sleeping in their bivouacs. A number of the shells fell on these lines, and as soon as the shelling ceased, it was found that 4 men were charred as they lay asleep. Death must have been instantaneous, as they were lying just as they would do when asleep, and from what could be ascertained they had not moved. A most careful search of their bodies failed to show any sign of a penetrating wound. They were all terribly charred, and the boots that one man was wearing might just have been pulled out of a fire. Another device, first used by the Germans for inflicting burns, is the Flammenwerfer. This is an apparatus consisting of a receiver carrying inflammable oil, to which a pipe with a nozzle is attached, and a chamber for storing a compressed inert gas. The oil is projected from the nozzle by the compressed gas, the pressure being kept up by means of a hand pump. 2 men are required to work the apparatus, one operating the pump, whilst the other carries the rest of the apparatus on his back and directs the flame, which can be projected to a distance from 30 to 40 feet. Asphyxiating gas. Asphyxiating gas was first introduced into modern warfare by the Germans at the Second Battle of Ypres in 1915. In order for a gas to be effective, it must possess the following properties. 1. It must be heavier than air. 2. It must be non-inflammable. 3. It must be poisonous and asphyxiating in considerable dilution. And 4. It should be as insoluble as possible in moisture. For the propagation of a gas through the air, the following weather conditions are required. 1. The air should be as dry as possible. And 2. A favorable wind is required, a wind blowing from 4 to 8 miles per hour being the most favorable. The gas is stored under pressure in large iron cylinders, and in this form is carried up to the trenches. 4 to 6 such cylinders are connected together, built into the parapet, and one large delivery tube is attached to the combination. This delivery tube is thrown well out into no man's land prior to turning on the gas. In an organized attack, several sets of cylinders are used. Chlorine was the first gas used, but at a later attack, in which one of us was present, a mixture of chlorine and phosgene formed the gas cloud. The gas in this latter attack was at a preconcerted signal turned on between 4 a.m. and 5 a.m. on a dark winter's morning. The gas could be heard issuing from the delivery pipes in no man's land, the noise resembling that made by a motor bicycle, but it could not be seen. Later, as the darkness lifted, dense greenish-white clouds, partly broken up by our own artillery, could be seen slowly traveling with a slight northeasterly wind. Before the arrival of dawn, the country was lighted up for some distance round by the bursting of a ceaseless hurricane of shells, which was kept up all that day and well into the next night. The gas from a distance gave the appearance of great masses of cotton wool, and although the cloud was broken up, yet it was a striking sight to see how closely it hugged the ground. The phosgene-chlorine mixture is exceedingly poisonous, not only when inhaled, but also when ingested with food which has been exposed to it. This contamination of food is an important point to be remembered when dealing with the wounded men, both during and after the attack. The symptoms and treatment of the condition will be dealt with in another chapter. Gases are also used in shells. One type is a yellowish gas, which causes intense irritation of mucous membranes, especially the conjunctivae, the so-called lacrimatory or tear gas. This gas also, in certain individuals, produces a gastritis accompanied by persistent vomiting. It was used by the Germans for shelling our own batteries. When the thickest part of the gas has dispersed, a pleasant smell resembling geraniums persists for 3 or 4 days, and the ground where these shells have burst is stained a greenish-yellow color. Other gas shells used by the enemy are extremely poisonous. These shells make very little disturbance on bursting, and the gas is nearly invisible. It possesses a curious odor, somewhat resembling burning India rubber. Gases of a highly irritating kind are used in bombs, the so-called stink bombs. These bombs are used for clearing enemy dugouts and subterranean passages. They are of the ordinary jam pot variety, provided with a detonator and charged with a fluid which rapidly turns into gas after explosion of the bomb. Today, every soldier is provided with an anti-gas respirator, which affords complete protection against any gas that the enemy may use. Accidental wounds. Accidental wounds form a heterogeneous group ranging from wounds of trivial nature to wounds of the most fatal kind. They may be divided into wounds inflicted in the fighting zone and those inflicted on the lines of communication. Accidental wounds in the fighting zone comprise wounds inflicted while in trenches or while out at rest. Of those seen in the trenches, the commonest are tears caused by barbed wire and rifle and revolver wounds, whether self-inflicted or otherwise. Tears caused by barbed wire may be anything from a scratch to a considerable-sized rent, sufficient to lay the man up for 2 or 3 weeks. All such scratches mean a temporary departure from the line in order to receive the prophylactic dose of anti-tetanic serum. Self-inflicted bullet wounds are usually situated on the dorsum of the foot or in the palm of the hand, and can be recognized from the scorching of the skin around the wound of entry. Accidental wounds are usually the result of forgetting to close the cutoff after cleaning the rifle. Wounds inflicted when resting are usually bomb wounds contracted during bomb practice, and are generally of a very extensive and serious kind. They are also occasionally seen as the result of accidents at trench mortar schools and the like. Wounds inflicted on the lines of communication are for the most part due to transport, and are the result of mule kicks, runaway horses, machinery accidents, and occasionally rifle bullets. Though not coming under the head of accidental wounds, yet occurring most frequently on the lines of communication, are wounds due to air raids. Wounds caused by bombs dropped from aircraft are notoriously serious. Not only in these raids have we the wounds caused by the bombs to consider, but wounds caused by pieces of shell from the anti-aircraft guns, which have on several occasions proved both serious and fatal. End of Chapter 2. Recorded for your listening pleasure by Sean Grabosky, Orlando, Florida.
Chapter 3 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Wanda White. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 3. General Nature of Wounds. Wounds of War and Wounds of Civilian Practice. It must by now have struck all observers how great a gulf separates the present war wounds from wounds seen hitherto in civilian practice. Prior to the war, casualty surgery formed a considerable part of the surgery done in all the big civil hospitals. Yet owing to the irregular times of arrival of these cases at the hospital, and to the fact that all such cases need immediate treatment, it frequently fell to the lot of the house surgeon or the resident surgical officer to deal with them. For the most part, civilian casualty surgery dealt with fracture of bone, simple or compound, usually the result of street accidents, machinery crushes, dock and railway accidents, together with wounds of all classes resulting from street brawls and the like. In addition, incised and lacerated wounds of varying dimensions, burns, septic infections, both of the localized and cellulitic type, formed quite a high percentage of the daily casualty surgery. Yet how rarely did cases of gunshot wounds occur! During 10 years' experience both in London and provincial hospitals, the authors can only record 8, these being cases of attempted suicide and malicious wounding. Malicious stab wounds are almost as infrequent. Amongst the very worst wounds seen in civil life, one never saw a case which followed the course seen in the more severe cases of gunshot wounds of the present day. The explanation of this is not far to seek, for gunshot wounds differ most widely from civil wounds both in the quality and the quantity of damage done to the tissues involved. It was the failure to recognize these two important points that led to bewilderment and disappointment in the treatment of wounds during the earlier months of the war, when infection of a most virulent and fatal kind flourished, despite active treatment, which in civil cases had proved itself adequate to cope with infection and wounds as we then knew them. The nature of the wounds that reached England during the latter months of 1914 and the early part of 1915 calls for no comment here, but readers will remember, despite the treatment meted out to them, the septic state which persisted in these wounds, especially in fractures, often resulting later in septicemia and death. It was evident that there were more extensive changes in the wounded parts than first met the eye, and it became necessary to look in new directions and adopt new methods of investigation and treatment. History of a wound. Much may be learned from the general history of a wound, from the time of its infliction up to the time at which the wounded man reaches the field ambulance or the casualty clearing station. Let us take, for example, a penetrating wound of the soft parts of the thigh, where the missile is a piece of high explosive about 3/4 of an inch square, and study the clinical picture of such a wound up to the time that the casualty clearing station is reached. When first seen in the trenches or on the battlefield, there is the usual wound of entry with a small amount of blood exuding. Hemorrhage in any considerable quantity from these wounds is a rare incident in the period immediately following their infliction. There is little pain, the whole thigh appears to be stunned, but there is considerable shock, the wounded man looking very blanched, and the pulse rate often being 110 or more. There is at first little or no swelling of the wounded part. It is at this stage that the first field dressing or shell dressing is applied, and the wounded man is carried down to the advanced dressing station or the regimental aid post. Edema of tissues of wounded part. It has often been necessary to detain him at one of these two stations. When this has been the case, we have observed that within the next hour or two the limb presents a different aspect. In fact, on several occasions the following change has occurred within half an hour of injury. The limb commences to swell, and the swelling develops with extraordinary rapidity, necessitating the cutting of the bandage securing the dressing. The swelling is not only confined to the tissues in the region of the wound itself, but it involves tissues in the limb at a considerable distance from the wound. At this stage the limb becomes acutely painful, owing to the severe stretching of the fascia lata. and at the same time swollen edematous muscle herniates from the wound of entry and completely occludes it. What, then, is the nature of the swelling? In the majority of cases, it is not due to hemorrhage, for, as before stated, hemorrhage is not always an early complication, even though vessels of considerable size have been divided, because the blood pressure falls immediately owing to the shock occasioned by the wound. It is not due to gas formation, as these limbs are not tympanitic, and it is as yet too early for the formation of gas. It is due to an acute reactionary edema occurring in the damaged tissues, and this edema constitutes the first change. Interference with circulation. This edema is a potent cause of early gangrene through the direct interference it exerts upon the circulation. The swollen tissues, prevented on all sides from expanding by the tense fascia lata, bring about an ever-increasing compression on the vessels of the limb. The circulation in the edematous muscles is poor, and in addition to their edematous condition, other striking changes are present by the time the casualty clearing station is reached. Infection of the swollen tissues. Some 12 hours or less after the infliction of the wound, the patient arrives at a casualty clearing station, where every convenience exists for surgical intervention. His limb is very swollen. It may or may not be at this time acutely tender, and it may or may not be tympanitic and discolored. After excision of the wound of entry and opening up the track of the missile, there exudes a dirty brownish-black discharge with an offensive fecal odor. On enlarging the wound in the direction of the long axis of the limb and cutting through the fascia lata, edematous muscle at some distance from the wound herniates out, and probably by this time some gas escapes also. This herniated muscle is characteristic in appearance. It resembles butcher's meat, having a dry, lifeless look. It does not bleed when cut, and it does not contract when stimulated. Though it is still living, it is exceedingly apt to die, and while in this edematous condition, it is very prone to infection. Indeed, infection is often present in it by the time the casualty clearing station is reached. That part of the muscle which helps to form the track of the missile is irregularly divided and immediately contracts after infliction of the wound. By the irregular contraction of the divided muscle fibers, diverticula are formed. The divided surfaces of the muscle soon become covered with a grayish-green stinking membrane. Hence a potential space containing diverticula lined throughout with an evil-smelling infected membrane results, and from this focus infection spreads. Muscle in this state is neither able to keep up its affluent lymph flow, nor to empty itself of stagnating venous blood. Soon the stagnating blood coagulates in the veins within the muscle substance, and death of the muscle results. How are these changes in the muscle tissue brought about? Disruption and stunning of affected tissues. Here there are some diversities of opinion, but it seems very probable that there are two factors at work. Firstly, a disruptive effect, already alluded to in Chapter 2, and secondly, a knockout blow on the muscles in the immediate vicinity of the wound. That such paralysis of muscle is immediate cannot be denied by anybody who has seen these wounds directly after their infliction in the line, for there is immediate paralysis of both motor and sensory functions. There is no fibrillary twitching of the muscle to be seen, and the damaged muscle, when cut or stimulated, does not contract or bleed, and the whole surroundings of the wound are painless. This is borne out by the fact that we have on more than one occasion performed a painless amputation of the guillotine variety immediately after infliction of the wound through proximal tissue. What is the extent of the damage to muscle in a penetrating wound? Damage to tissues distant from the wound. Here again there is diversity of opinion, but the salient fact is that the damage sustained by the tissues is confined not only to the wound itself, but involves the tissues at some considerable distance from the wound. It was failure to recognize this important point that led to failure in the treatment of earlier cases, and it is to Colonel Gray that credit is due for first pointing this out. He practiced, and urged most strongly, the importance of free incision and excision of wounds until the limits of damaged tissue had been reached. It is a common phenomenon, and many instances have occurred to demonstrate it, that a bone may be struck and fractured, not at the actual point of impact with the missile, but at another point some distance away. Similarly, many cases have been met with which demonstrate that a limb struck at any one point may show little apparent damage in the immediate vicinity of the wound, but at a point a considerable distance away there is a large hematoma in the soft parts, though the missile itself is nowhere near the latter situation. Here again there is a diversity of opinion, for some have pointed out that microscopically there are no gross changes to be seen in tissues distant from the wound, whereas other microscopists have held the reverse view. Amongst such conflicting opinions, it is difficult for a surgeon whose experience in the early treatment of gunshot wounds has been limited to know which view to accept. But all surgeons who have had experience at busy casualty clearing stations will agree that clinically Colonel Gray's view is correct. Those who have had experience in the line and have had the opportunity of seeing wounds which never leave the line cannot but be impressed with the truth of this salient feature. Does edematous and stunned muscle ever recover? The answer to this question will depend upon the length of time that elapses between the reception of the wound and efficient surgical treatment. If early incisions be made through the skin and deep fascia into the substance of the muscle, which will allow the muscle to expand freely, and at the same time remove the constricting influence of the fascia lata with the concomitant inhibitory effect on the circulation, then it is quite possible that the affected muscles may recover. If, on the other hand, the constriction of the deep fascia be not relieved, the muscle rapidly dies and forms suitable pabulum for the growth of microorganisms, especially B. perfringens and the more virulent streptococci. Latent and manifest damage of tissues. The nature of the damage inflicted on the tissues will, for the most part, depend upon the distribution of the force of the missile, and it is important to recognize that, ceteris paribus, the more extensive the superficial injury, the less the probability of damage to deep structures, and consequently the better the prognosis. A traveling missile has a definite and fixed amount of kinetic energy, represented by the formula half mv². It is obvious that if the greater part of this energy be expended in damaging superficial tissues, there is but little remaining to produce deeper and consequently more important damage. Again, in the case of a penetrating wound, where all the kinetic energy of the missile is expended in damaging the tissues, there is likely to be far more destruction than in the case of a perforating wound, where part only of the energy is so expended. If, on the other hand, the missile impinges on a structure more resistant, such as bone, its kinetic energy may be suddenly reduced to zero, and what might have proved a perforating wound of the soft parts only now becomes penetrating, with a consequent excess of tissue destruction. Where we have to deal with extensive external wounds, we can be sure that the force of the missile has expended itself in producing visible external damage. But where the wound happens to be of the penetrating variety, involving or not fracture of bone, we must reasonably infer that the damage to tissues, though for the most part latent, has nevertheless occurred, and that the force of the missile has almost entirely expended itself in producing internal damage. Wounds of the abdominal and thoracic viscera are interesting in this connection. Here we sometimes see extensive wounds where a large piece of the abdominal wall has been carried away right down to the peritoneum, sometimes tearing this latter structure, and yet the abdominal viscera have escaped injury, the force of the missile in this case being wholly expended in producing external visible damage. On the other hand, a contusion of the abdominal wall caused by a nose cap may be associated with extensive tearing of the liver, kidneys, or even of a hollow viscus, the force in this case being spent in causing latent or invisible internal damage. Again, a small penetrating wound of the abdominal cavity, showing but little external damage, may hide extensive laceration of the hollow or solid viscera. Solid viscera, such as the liver, spleen, or kidneys, show when wounded exactly the same disruptive effect and swelling as has already been described in connection with the soft parts of the thigh. Penetrating wounds of the brain illustrate important and interesting phenomena. Here the kinetic energy of the missile is expended in penetrating the outer and inner tables of the skull. The inner table is splintered, thus further reducing the kinetic energy, and the splintered fragments are further pushed on by the missile and penetrate the dura mater, finally coming to rest in the brain substance. A similar effect is produced in the brain substance as was produced in the thigh muscles already alluded to. There is a traumatic edema. On trephining these cases there is at first no pulsation of the dura to be seen. Soon, however, the tension relieves itself, and blood clot with fragments of bone, and sometimes the missile, are vomited out of the hole in the dura mater, and pulsation returns. Should the missile have lodged near the motor centers or in the occipital lobe, temporary monoplegias may be present or restriction of the fields of vision. We have treated a large number of cases where the monoplegias vanish in from 7 to 10 days after trephining. Transient monoplegias are merely symptoms of a traumatic edema produced in the cerebral cortex, and disappear as the edema subsides. The head illustrates well the effect of traumatic edema occurring within a closed unyielding space, and trephining is just as urgent here as free incision of the deep fascia for the relief of traumatic edema of the thigh structures already referred to. Multiplicity of wounds. War wounds, again, differ from wounds seen in civil life in that they are in a large percentage of cases multiple. Multiplicity of wounds is associated with shock of a severe type, and patients suffering from shock, with the consequent fall of blood pressure, are far less able to resist infection in the first day or two following their wounds, which is the important and critical period. Bomb wounds and air raid wounds are notoriously malignant in this respect. Multiple wounds inflicted with hand grenades may cause such intense shock that a man so wounded may die before he can be brought back to receive attention. This has frequently happened to men on patrol. Severe cases that recovered sufficiently to reach a casualty clearing station have in the majority of instances died from a combination of shock and infection. The German hand grenade is a truly pernicious weapon, being charged with screw heads, nails, and every kind of roughened small missile, all of which cause incalculable damage to the tissues, besides carrying in clothing and trench mud. Statistics. Multiplicity of wounds makes the compilation of statistics a very difficult problem. Such a combination of wounds may exist in the same individual that he may succumb to any one of them, yet had not the other wounds been present he might well have recovered. For example, Private Blank, wounded July 5, 1916, had a penetrating wound of the skull and a penetrating wound of the abdomen. The wound of the abdomen involved 6 perforations of the small intestine. These were stitched up, and the abdomen was closed. Simultaneously he was trephined by another surgeon, and 10 days later died of meningoencephalitis. His bowels had moved, he had recovered from the vomiting caused by the post-operative intestinal inertia, and the abdominal condition at the time of death was in every way satisfactory, yet this case must be classed as a death in which the abdomen was involved. Again, Private Blank, wounded July 10, 1915, had a perforating wound of the left knee joint, a compound comminuted fracture of his right femur, and a compound comminuted fracture of his mandible, with a laceration of the soft parts of the face. Both face and knee joint wounds were doing excellently, but he died as the result of gas gangrene which had supervened in the right thigh. It is almost certain that this soldier would have recovered from the wounds of the knee joint and face, had not gas gangrene toxemia from the wound in his right thigh supervened and caused his death, yet this case must rank as a death in which the knee joint had been penetrated. It is multiplicity of wounds that makes statistics of the results of treatment of any one kind of wound, such as penetrating wounds of the knee joint, penetrating wounds of the head, etc., unreliable. For strictly speaking, a fair estimate of the results of treatment of any one class of wound can only be arrived at when this particular class of wound exists uncomplicated. Transport. In civilian practice, a wounded man is able to receive early and adequate surgical treatment, either at his own home or at a hospital. In warfare, all he can receive on the battlefield is first aid treatment, and not until he reaches the field ambulance or the casualty clearing station can adequate surgical measures be carried out. The time that elapses between his being hit and arrival at one of these units varies with conditions. He may reach the unit in as short a space of time as 2 to 6 hours after being wounded, or it may be as late as 36 or even 72 hours. Part of the journey from the battlefield is either along communication trenches or over the open, and whichever route be taken, this part of the journey is bound to be rough. From the advanced dressing station, the remainder of the journey is completed by motor ambulance, often over rough roads. Hence, if the wound be one involving bone, such as a compound fracture of the thigh or leg, or if it be one involving the thoracic cavity, the abdominal cavity, or the head, such a journey has an unfavorable influence on the wounded parts and the man's general condition. Transport between the battlefield and the casualty clearing station is then another complication which can alter for the worse the nature of any extensive wound. Traumatic anesthesia. The immediate anesthesia or stunning of the tissues which follows penetrating or perforating wounds in the case of extremities has proved beneficial in the class of wound in which the limb is hopelessly shattered. Where this condition exists, and it is not immediately possible to move the wounded man out of the trenches, most extensive shock results from leaving such a limb attached to the body, and this is further increased by transport. We have on more than one occasion found it necessary to perform immediate amputation in the trenches, and such a procedure has proved itself to be absolutely painless, even when the amputation has been carried out through tissues immediately above the wound. The immediate improvement in the condition of the patient consequent on such a procedure has been most striking. The cases did well and were heard of later in England. Injury of bone. Wounds involving bone differ very materially from those seen in civil practice, for although in the latter fractures are either simple or compound, the fractures as they exist involve but little comminution, and there is usually a minimum of damage to the soft parts. On the other hand, in the case of gunshot wounds, bone comminution of the gravest kind is usually the rule, and associated with it there is extensive damage of the soft structures. Often, indeed, there is considerable loss of continuity in the bone, amounting in some instances to 3 inches or more, and this comminution may involve an important joint. For instance, a gunshot wound fracturing the femur at the junction of its middle and lower thirds may easily involve the knee joint. Anatomy of wounded part. The anatomy of a part, especially of a limb, may be profoundly modified as the result of an extensive gunshot injury. Thus, structures like the sciatic nerve, the posterior tibial nerve, etc., and arteries of considerable size, together with the tissues which surround and support them, may be so involved and displaced as to render their identification impossible except to those who have had considerable experience. Thus, when a wound is explored, hemorrhage may occur from a large vessel which has been hopelessly displaced from its normal anatomical position. When dealing with these wounds, therefore, a thorough knowledge of the more refined anatomy of the part is absolutely essential, both from the point of view of speed in operating and avoidance of inflicting further damage on important structures that have been displaced from their normal positions. A surgeon who undertakes the treatment of war wounds must know his anatomy intimately, as almost every fresh case that he meets differs from any that he has already seen, and it is this feature that makes war surgery so fascinating a study and so much more difficult than the ordinary clean surgery of civilian practice. End of Chapter 3.
Chapter 4, Part 1 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 4, The Bacteria of Wounds, Part 1. In broad general terms, the 3 great complications of wounds are shock, hemorrhage, and sepsis. Of these, the first two play their most important part in the wounds which kill almost outright or within a very short time. Such wounds can be of little interest to the surgeon. He must concern himself solely with the potential survivors among the wounded, and in this great class, while the conditions of shock and hemorrhage still require a considerable measure of attention, yet by far the greatest complication to be dealt with and mastered is that due to sepsis. It is with just pride that the war surgeon can now say that thanks to the discoveries of the past 2 years, sepsis in wounds is rapidly assuming a position of much diminished importance, and shows signs of being conquered in the near future, as absolutely as it has been overcome in the operative work of civil surgery. The difficulties of destroying war wound sepsis have given rise to problems infinitely greater than those which Lister set himself to solve in civil surgery. But at last the reward of much difficult and painstaking work is at hand, and a mortality and disablement rate from wounds which steadily and even rapidly decreases with every month that passes. Every layman is familiar with the fact that sepsis in wounds is due to the action of certain minute forms of vegetable life called germs, bacteria, or microorganisms. He understands that were it not for the introduction of these microorganisms into a wound, the latter would gradually heal without the unpleasant and dangerous consequences associated with the various forms of inflammation. Such matters have long been common knowledge and need not detain us here. Our purpose in this chapter is to give a brief account of the various groups of bacteria which may be found in wounds, and of the characteristics and mode of action of such bacteria. These matters will, in the first place, be dealt with in a general way, prior to a consideration of each particular group seriatim. General characters of microorganisms. A. Function in nature. They are the great destructive agents of all organic material. They purify the earth by resolving effete organic products into harmless simple chemical substances, gases, and elements. This is done in many stages, most of them offensive. There is liquefaction and production of many foul gases and poisons in the process, but it is nature's way of removing dead and inert organic matter, and the net result is the disappearance of the tissue and yielding up of its ultimate constituents, carbon, hydrogen, oxygen, nitrogen, sulfur, and phosphorus, to enrich air and soil. So far, their function is beneficent. B. Function in wounds. Unfortunately for us, however, some of these organisms have acquired the habit and power of breaking down living tissue as well as, or instead of, dead matter. Among these are classed those organisms which invade wounds and give rise to all the phenomena of sepsis. In wounds, the barrier of an unbroken skin is removed, and there is direct access of microorganisms to tissue in which many of them can live and exert a destructive action similar to that which obtains in the realm of dead and effete organic matter. The result of such action is what we know as sepsis, gangrene, etc., and it is our business to resist such action most strenuously. Hence, the whole art and science of the treatment of sepsis in wounds is concerned with the exclusion, destruction, and elimination of microorganisms. C. Classification. The microorganisms associated with wounds are minute plants, which almost all belong to the order of lower bacteria. D. Size. They are so minute as to require a special unit for their measurement, namely the micron, mu, which is equal to 1/1000th part of a millimeter. The known organisms found in wounds vary in size from about 0.7 microns, for example Staphylococcus, to 15 or 20 microns, for example Spirillum vincenti. They are commonly examined at a magnification of 1,000 diameters, and their measurement in microns is then the same as their apparent size in millimeters. E. Morphology. They consist of little masses of protoplasm surrounded by a capsule of the same substance, somewhat modified. In some varieties, the capsule is unusually thick and can be easily demonstrated, for example, Pneumococcus and B. perfringens. They exist in 3 main forms. 1. Cocci or micrococci. Cells globular. Division occurs in 1, 2, or 3 directions of space. 2. Bacilli. Cells rod-shaped. Division in 1 direction only, transverse to long axis. 3. Spirilla. Cells twisted spirally like a corkscrew. Division only transverse to long axis. 1. Cocci. These are divided into certain subgroups. A. Streptococci. Divide in one plane and the individuals adhere, forming a chain. The chains are roughly classified as long, when the number of members is more than 6 or 8, and short, when the number of members is less. B. Tetracocci or tetrads divide in 2 directions and commonly form tetrads or bundles of 4 cocci. For example, Micrococcus tetragonus. C. Sarcinae divide in 3 directions and form bales or packages of cocci. D. Staphylococci divide irregularly to produce masses resembling a bunch of grapes. They are of small size, 0.7 micron. 2. Bacilli. These may be short or long, 1 to 9 microns, slender or thick, and have rounded or square ends. They may be motile or non-motile, and sporing or non-sporing. Many bacilli, when viewed suspended in fluid in a hanging drop preparation under the microscope, are motile. Others are quite still. The motility is due to whip-like processes called flagellae, attached to the sides or ends of the bacilli. The lashing of the flagellae in a fluid medium gives rise to the movements of the bacilli. The movements may be active or slow and of various types, such as rolling, twisting, whirling, darting, or slow progression. Motility is made use of in the classification of organisms, for example, to distinguish members of certain groups of bacteria, such as the coliform group. Spores are little rounded or oval masses surrounded with a tough, resistant capsule. They become formed in the substance of certain kinds of bacilli, for example, B. perfringens and B. tetani, when conditions are unfavorable for growth and reproduction. In this form, the bacilli can outlive adverse conditions such as lack of food material and moisture or submission to extremes of temperature. Spores can successfully resist the temperature of boiling water, 100 degrees centigrade, for a short time. They are killed by steam under pressure and by dry heat at a temperature of 135 degrees centigrade or above. 3. Spirilla are easily distinguished by their characteristic curved or spiral shape. There are not very many varieties found in wounds, the commonest being the Spirillum vincenti, which may be found in association with a long fusiform bacillus, B. fusiformis. These are the organisms of Vincent's angina, which is a form of sore throat associated with a necrotic condition in the fauces. In wounds, these organisms are also associated with necrotic or gangrenous tissue. F. Reproduction. Microorganisms reproduce themselves by fission or sporulation. The former method consists of simple division of each individual into 2. Under favorable conditions, fission may take place twice or thrice within an hour, and this property gives them an enormous potential rate of increase. When organisms are sown upon a suitable solid culture medium, which is incubated at 37 degrees centigrade for 12 to 24 hours, colonies are formed on the medium, and each of these colonies consists of millions of individuals aggregated together, all of which have been formed by fission from one individual during this period. Sporulation is an alternative method of reproduction practiced in addition to fission by certain bacilli. Sporulation is observed typically when the bacilli are placed under unfavorable conditions for growth. For example, in unsuitable surroundings as regards food supply, moisture, temperature, etc. Under such conditions, reproduction by fission stops, and there appears within the body of the bacillus a little refractile speck which enlarges to form the typical round or oval spores. When these are completely formed, the remainder of the body of the bacillus shrinks and disappears. Spores may remain in this dormant condition for a prolonged period, and at any time when the conditions become again favorable for growth, they develop again into the full bacillus vegetative form, and fission proceeds as before. Spores are surrounded by a tough envelope which is extremely resistant to heat, drying, and antiseptics. This makes their destruction a somewhat difficult process. The chief spore-bearing bacilli in wounds are the anaerobes associated with gas gangrene production. The direct destruction of such spores in wounds would be a most difficult problem. Their destruction is commonly indirectly achieved, however, by taking advantage of the fact that they tend to anchor themselves to dead tissue in wounds. Such dead tissue or slough containing spores is readily acted upon by the hypochlorite antiseptics, for example, Usol or Dakin solution. These, with the help of the phagocytes, rapidly dissolve sloughs and cause the spores to be swept away from the wound surfaces. By this means, the most foul, gangrenous wounds are often rapidly freed from spores within a few days. Spore formation is the source of much difficulty in regard to the sterilization of material such as culture media and apparatus, surgical instruments, dressings, etc. Owing to the resistant nature of the spores, sterilization must be performed by the use of high temperatures or of very strong antiseptics. With regard to high temperatures, moist heat is the most useful. Sterilization may be carried out by a single exposure of the material to a temperature of 120 degrees centigrade for 20 minutes in a steam sterilizer or autoclave. In the case of glass apparatus, it is usually more convenient to employ dry heat in a hot air sterilizer. The temperature employed in this method should reach 140 degrees centigrade if applied for 45 minutes or 150 degrees centigrade if applied for 30 minutes. Where such high temperatures injure the material, sterilization may be effected by the intermittent method, namely by applying steam at 100 degrees centigrade for 20 minutes on each of 3 successive days. This is conveniently performed in Koch's steam sterilizer. In this way, the vegetative forms are first killed off, leaving only the spores. The latter tend to develop into vegetative forms during the first period of 24 hours and are killed off by the second sterilization. The third sterilization is for the sake of safety, in order to kill off, after development into the vegetative form, the few spores which may have escaped the second sterilization. Biology of the bacteria of wounds. A. Oxygen. Certain of these bacteria require uncombined oxygen for their growth and development, aerobes. Others will grow only in the absence of uncombined oxygen, anaerobes. A third group are more or less indifferent to oxygen and are able to grow either in its presence or absence, aerobes and optional or facultative anaerobes. Examples of the aerobic bacteria are B. subtilis and most varieties of diphtheroid bacilli, of the anaerobes B. perfringens and B. tetani, and of the aerobes and facultative anaerobes streptococci, staphylococci, and B. coli. Certain members of the latter group are sometimes isolated more readily by anaerobic culture. B. Food. For their nourishment, these bacteria absorb, by a process of osmosis, diffusible albumins through their capsules. In artificial culture media, the aim is to provide suitable and convenient albumins for their consumption. For this purpose, it is preferable to select, if possible, albumins of a type to which the particular organism under cultivation has been accustomed in its parasite growth in wounds. For example, blood serum in the case of B. influenzae, which invariably utilizes that protein when growing in the body tissues. Many of the more delicate organisms found in wounds, such as pneumococcus, B. influenzae, etc., require a much richer protein medium than others. For such cases, the additional protein may be added to the ordinary media in the form of whole blood, blood serum, acidic fluid, legumin, tryptonized brain tissue, meat, and egg. Such enriched media are also most useful for general cultivation of organisms where a vigorous growth is required, for example, in the preparation of autogenous vaccines. In some cases, it is preferable to make culture media specially rich in carbohydrates, such as glucose or lactose, or in glycerin, etc. This particularly applies to those organisms which ferment carbohydrates vigorously, for example, B. perfringens, which forms large quantities of acid and gas from muscle and other sugars. In such cases, the addition of glucose to the ordinary culture media is a distinct advantage. Carbohydrates are added to media to assist also in differentiating the members of certain groups of bacteria. Thus, lactose is added to special media used for differentiating the coliform group, some of which are lactose fermenters and others non-lactose fermenters. The purpose here is simply to indicate how varied are the food requirements of bacteria in artificial culture. Fuller notes upon cultural media and methods will be found in the appendix. C. Fermentation, putrefaction, and gas production. These processes, worldwide in nature, are due to the agency of microorganisms. They demand consideration here because they occur, to a greater or lesser extent, in all wounds and in all artificial cultures of organisms. Moreover, they afford a key in particular to the action of the great and important group of anaerobic bacteria in wounds, and as such are entitled to the most scrupulous attention. In nature, these are the phenomena by which bacteria destroy and break down organic matters, and finally resolve them into their elements. The changes are brought about by means of enzymes or ferments, which become elaborated by the bacteria during the course of their growth. It is in this way that dead or effete animal and vegetable products and remains disappear from the earth and liberate their elemental constituents, carbon, hydrogen, oxygen, nitrogen, sulfur, and phosphorus, to enrich soil and air. Such destruction necessarily takes place in various successive stages, the chemical compounds formed at each stage becoming simpler and simpler until the end products, gases and elements, are reached. It is thus, for example, that sewage becomes purified by the septic tank system, and that polluted rivers regain in time their purity. Fermentation is the splitting up of carbon compounds, such as starches, sugars, and fats, into simpler products through the agency of microorganisms. The brewery provides us with a popular example in the fermentation of the maltose of the grain. The yeast plant is employed, and the enzymes formed during its growth break down the maltose to form, among other products, the simpler sugar glucose, from which again, by the same action, is produced alcohol and carbon dioxide gas. In the brewery, fermentation is checked at this stage. If, however, no check be applied, fermentation may proceed considerably further, for example, to the stage of producing acetic acid from alcohols. At the acid production stage, fermentation tends to stop naturally owing to the inhibitory action of the acid produced on the growth of the organisms. These reactions may be represented chemically as follows. Glucose equals alcohol plus carbon dioxide. Alcohol plus oxygen equals aldehyde plus water. Aldehyde plus oxygen equals acetic acid. In wounds and in artificial culture media, fermentation of carbohydrates and fats by the organisms commonly proceeds until acids and gases are produced. Thus, in wounds, the action of B. perfringens, which is associated with practically all cases of gas gangrene, is primarily one of splitting up of the muscle and other sugars into acids and gases, and only in the late stages does it exert any destructive action on proteins or albuminous substances. The gases associated with fermentation are inodorous, such as carbon dioxide, carbon monoxide, hydrogen, methane, and many other gaseous hydrocarbons. In gas gangrenous wounds, which especially in the latter stages are associated with the most foul odors, the odor is due not to the gases of fermentation, but to the sulfurous gases of putrefaction. In culture media, fermentation of various sugars and carbon compounds is commonly employed as a bacteriological method of differentiating the various members of groups of organisms which may be morphologically and otherwise exactly similar. The most common and useful of the sugars and carbon compounds employed for the organisms of wounds are glucose, maltose, saccharose, mannite, dulcite, arabinose, raffinose, glycerin, inulin, and salicin. These are added to peptone water, or better, to sugar-free broth, in a strength of 0.5%. Various methods are used for demonstrating gas production from these sugars. For example, 1. Durham's tube method, 2. Hiss's serum water method, and 3. Stab or shake culture media. See Appendix. Acid production is shown by using litmus solution in the medium as an indicator. It is observed that certain degrees of fermentation are constantly produced by particular organisms, and these become recognized as standard characteristics of the organisms concerned. Such characteristics provide one means of differentiating the members of groups. For example, the various streptococci, coliform bacilli, and anaerobic bacteria found in wounds all lend themselves in particular to differentiation by this method. Putrefaction is the splitting up of proteins or albuminous substances into simpler bodies through the agency of microorganisms. Its action in nature is well known and widespread, and as in the case of fermentation, it is a common phenomenon also in wounds and in artificial culture media. The putrefaction process takes place in several stages. The proteins are successively broken down into proteoses, peptones, amino acids, aromatic bodies such as indole, scatol, and phenol, and finally gases and elements. The first stages which result in peptone production are often referred to as digestion, and in the latter stages as putrefaction proper. The process is exactly the same as that which occurs in the animal intestine when the proteins of the food are digested and later completely broken down. Among the gases produced are nitrogen, N, ammonia, NH3, hydrogen sulfide, H2S, sulfur dioxide, SO2, and various oxides and hydrides of nitrogen and phosphorus. Of these, the sulfur compounds, which are invariably present, are extremely offensive, and hence the process of putrefaction is always malodorous. Many of these products of putrefaction have a high degree of toxicity to the body, and it is not quite certain which of them are the worst offenders in this respect. It is certain that there is produced somewhere about the peptone stage or below it a highly complex and highly poisonous group of bodies, which have been variously denominated toxins and ptomaines. It is possible that some of these may be of a simpler chemical nature, such as ammonium salts, a fact pointed out by Barger and Dale in connection with artificial culture of B. edematous maligni, but our knowledge of the exact nature of these bodies is scanty. The proteolysis is due to the action of enzymes or ferments, which are formed in the secretion of certain intestinal glands in the case of food digestion, or formed by the action of certain proteolytic organisms on tissue in the case of most putrefactive processes. In wounds, putrefaction is produced both by aerobic and by anaerobic bacteria. It is seen in its most alarming form in cases of gas gangrene, where large masses of tissue die and become black and decomposed with the evolution of vile odors and spread of gas under pressure upwards in the tissue planes. This condition is always associated with the action of anaerobes. The anaerobic bacteria of wounds fall into two main groups: 1. Saccharolytic or sugar-splitting group, and 2. Proteolytic or protein-splitting group. The second group, of which B. sporogenes Mechnikov is the most prominent example, is, of course, particularly responsible for putrefaction, although most members of the first group are able to putrefy proteins also to some slight extent. Of the aerobic bacteria of wounds, the coliform group, especially B. coli of Ehrlich, is the most prone to produce putrefaction, but this is never of the extreme type produced by the gas bacilli. In artificial culture media, the putrefactive properties of certain bacteria are employed in their culture and differentiation. For example, egg media and meat media are blackened and decomposed by the proteolytic group of anaerobes, and these form suitable culture media for the growth of these organisms. Again, the action of certain coliform bacilli in producing indole from peptone in artificial culture is used in the group differentiation. In most of these protein-enriched media, the gases of putrefaction are also produced in very considerable degree by proteolytic organisms. Gas production by microorganisms has been already dealt with in the remarks on fermentation and putrefaction. It is a phenomenon present, like the others, universally in nature, and also occurs in wounds in an artificial culture media. The gases produced may be divided into two groups according to the mode of their production. 1. Those associated with fermentation, and 2. Those associated with putrefaction. Class 1 are mainly carbon, hydrogen, and oxygen compounds, and are inodorous. For example, carbon dioxide, methane, etc. Class 2 are mainly nitrogen, hydrogen, sulfur, and oxygen compounds, for example, ammonia, nitrogen dioxide, etc. In connection with wounds, the gases produced may be evolved locally, as in circumscribed putrid inflammatory areas, or may spread upwards in the tissues from the site of manufacture, as in spreading gas gangrene. In artificial culture media, the gas produced in certain media is of the greatest assistance in determining the type and individuality of the organism concerned. This will be dealt with more fully in the remarks which follow on the various groups of organisms contained in wounds. Other biological reactions. These constitute an ever-growing list as our knowledge of bacteriology increases. It is sufficient merely to mention here such examples as liquefaction of gelatin, peptonization of milk, acid and alkali production, and pigment production. These actions are due to the formation of enzymes by the bacteria during their growth. Disease production or pathogenicity is one of the greatest practical importance. It gives us the broad preliminary classification of all microorganisms into two great divisions according to their action on man. 1. Pathogenic organisms. 2. Non-pathogenic organisms. Class 1 alone is the concern of medical and surgical science. Of all the known microorganisms, fortunately, only a very limited number are pathogenic. There is no very well-defined boundary between the two divisions. An organism which is ordinarily pathogenic may become non-pathogenic under certain conditions, such as prolonged growth at an unfavorable temperature or in a culture medium containing unsuitable food, degree of moisture, or noxious substances, for example, antiseptics. A streptococcus or staphylococcus can be reduced from a powerful pathogenic agent to impotence by such means. The reverse condition is also occasionally seen when a feebly or non-pathogenic organism, such as Sarcini or B. mesentericus, can, by growth along with other strongly pathogenic agents, symbiosis, or by other means such as successive injection from animal to animal, passage, assume a distinctly pathogenic character. These, however, are boundary line cases and are somewhat exceptional. It is usually possible to assign an organism in its ordinary or habitual condition definitely to the pathogenic or non-pathogenic group. A special type of pathogenicity which must be mentioned here occurs in the case of certain anaerobic bacteria, and particularly B. perfringens. These organisms are very severely pathogenic, but only under strictly limited conditions. Before the present war, B. perfringens was looked upon as practically a harmless saprophyte which could invade the body at or just before death, so few were the cases in which it was known to have produced definite pathogenic action during life, and this in spite of a very wide distribution in nature. In present war wounds, however, the necessary conditions of its growth and development, restricted though they are, have only too frequently occurred, and in these wounds it has become, owing to the gas gangrene which it may produce, perhaps the most deadly pathogenic organism with which the war surgeon has to deal. It is generally found that the pathogenic group grow best at a temperature above 25 degrees centigrade and at an optimum temperature of 37 degrees centigrade. Pathogenicity depends upon the production by the organisms of toxins or poisons. These are of two kinds: 1. Intracellular or insoluble toxins, and 2. Extracellular or soluble toxins. The first are contained within the bodies of the bacilli and do not diffuse out into the surrounding fluids. The extracellular toxins, on the other hand, are set free in such fluids during the growth of the organisms, and in the case of fluid culture media, can be obtained in solution by filtering the culture through porcelain, by which means the bodies of the bacilli are retained in the filter and toxins pass into the filtrates. In addition to these two classes of true bacterial toxins which appear to be direct products of the bacteria, there is another type of poisonous substance which is associated with the action of proteolytic bacteria. These are poisonous bodies derived from the actual proteins of the tissues as the latter become broken down by such bacteria. The best example is that of spreading gas gangrene in wounds, where great masses of tissue are destroyed, not only vitally, but also chemically. Here a great variety of products of disintegrated tissue protein are formed, and to some extent are absorbed into the general circulation. The toxemia in such cases is a very profound one, and quite unlike that produced by the true bacterial exotoxins of the anaerobes. See chapter on gas gangrene. This class of poisonous substances appears to be a particularly deadly one. The chemical nature of all these toxins is obscure, but most of them are known to be products of protein disintegration, toxalbumins and the like. They act by attaching themselves to the body cells, either locally or generally, or, as in the case of tetanus, to some special tissue cells, such as nerve cells, at a distance from the point of entry of the organisms. Saprophytism and parasitism. These biological reactions constitute another broad line of cleavage in the world of microorganisms, and they are of great importance from the human point of view. The distinction, again, is not a sharp one, for there is a very considerable intermediate zone of organisms which show both reactions in some degree. A saprophyte is an organism which lives in nature apart from other living organisms. A parasite is an organism which lives in or upon other living organisms. A saprophyte is supposed to live upon the albumins of dead or inert tissue. The most outstanding example associated with war surgery has already been referred to, B. perfringens. This organism, which is derived from feces, is habitually present in manure and manured soil, and may occur in any feces-contaminated material. Under ordinary circumstances, it invades the human tissues only after death. It has no power of growing upon healthy living tissue. If a pure culture be injected into the body of an animal, no result is usually produced, the bacilli being rapidly phagocyted and removed. In wounds, however, there are often produced masses of dead or greatly devitalized tissue, and on these the organism, by exerting its saprophytic function, also, in a sense, becomes parasitic upon the living body. It is most rare to find this action of B. perfringens exerted under any other circumstances than those occurring in war wounds. A parasite may or may not exert a harmful action upon its host. A virulent streptococcus growing and spreading in the tissues or bloodstream is, of course, a most deadly parasite. There are, however, many organisms, such as skin cocci and intestinal cocci, bacilli, and spirilla, which live in habitual association with the body without producing, under ordinary circumstances, any harmful result. Such organisms, in reality, live upon the dead products of the living body, and not at the expense of living tissue, although the association is a close one. They are also capable of leading a wholly saprophytic existence in nature upon various organic materials apart from the living body. There are, however, true parasites, such as B. influenzae, meningococcus, etc., which die almost immediately after removal from the body, unless the conditions of their growth be artificially reproduced, as, for example, in cultures on a blood serum medium kept at body temperature. This is, however, artificial saprophytism and is not a phenomenon found in nature. Enough may have been said to point out the general distinction between saprophytes and the parasites, and to indicate also that the difference, like that between the pathogenic and the non-pathogenic, is often merely relative. Specific bacteria of wounds. The following list of bacteria and bacterial groups of organisms found in wounds is not complete, but comprises most of those which have been commonly found in all classes of wounds investigated both on the western and eastern areas of war. There is perhaps an infinite variety in the flora of wounds, comparable only to that of the human and animal intestine, from which the vast majority of wound bacteria are derived. In a series of cultures from wounds, there often appear organisms which are difficult to assign even to a group, and in the various groups there occur individuals and subgroups which are atypical and sometimes of a new and undescribed type. This applies especially, perhaps, to coliform organisms, diphtheroids, and diplococci. The following, however, includes the more common groups and individuals, and those whose specific action has been most completely worked out. Aerobes, Staphylococcus, several varieties, Streptococcus, several varieties, Enterococcus, Pneumonococcus, Micrococcus tetragonus, Moraxilla catarrhalis, Sarcinae, Diplococci, various. Bacilli, B. coli communis, coliform bacilli, many varieties, including B. proteus and B. friedlander. Diphtheroid bacilli, B. piocyaneus, B. influenzae. Subtilis mesentericus group. Anaerobes, saccharolytic group, B. perfringens, B. von Hibbler 9, B. phalanx of Weinberg, B. aerophytitis of Weinberg, B. edematians of Weinberg. Proteolytic group, B. sporogenes of Metchnikoff, B. histolyticus of Weinberg, B. putrificus coli of Beinstock, B. cadaverous sporogenes of Klein, B. titani of Nicolaer, B. fusiformis, Spirillum vicente, etc. It will be recognized from this list what a large majority are fecal in origin, especially in the case of the anaerobes, which are practically all derived from the animal intestine. The conditions of life in the trenches, which are dealt with fully elsewhere, afford an all-sufficient explanation of this unfortunate fact, and from what has been said it will be seen that infection with fecal organisms can hardly fail to accompany nearly all wounds of this war. Cocci, Staphylococcus. This group of cocci has representatives normally present in the healthy skin, as well as others which have a great tendency to adhere to the skin, and are found very commonly there in even the most cleanly persons. It is safe to say, therefore, that a staphylococcus of one kind or another invades every wound. A considerable number of varieties have been differentiated by various writers, but for practical purposes of pathogenicity, these may be reduced to two: 1. Staphylococcus pyogenes, and 2. Staphylococcus epidermidis albus. The first of these is derived mainly from fecal contamination, but also from the skin. The second is an habitual tenet of the normal skin. 1. Staphylococcus pyogenes, when typical, produces a golden-colored pigment on agar, and is then called Staphylococcus pyogenes aureus. When atypical, it produces a white or merely a lemon-yellow pigment, and is then called Staphylococcus pyogenes albus and Staphylococcus pyogenes citreus, respectively. These various types of Staphylococcus pyogenes are all morphologically indistinguishable. They are minute round cocci, commonly 0.7 micron in diameter, and they divide in several planes, forming masses of individuals which resemble clusters of grapes. They grow very readily on all common media. On agar they form large opaque colonies 1/2 to 2 millimeters in size. These colonies, according to the type producing them, are golden white or lemon-colored. Relation to wounds. The action of Staphylococcus pyogenes in wounds is usually that of causing localized suppuration. It is seldom associated with spreading infection into neighboring tissues and is practically unknown to invade the bloodstream. Its virulence varies much, being generally highest in the aureus type. This type, which is also the most common, is at times a highly virulent organism and produces a toxin which may be very powerful, but it remains localized and does not spread beyond the wound. The albus type is generally of intermediate virulence and is also a very common occurrence, and very often is present together with its near relative, the Staphylococcus aureus. Staphylococcus pyogenes citreus is a very rare occurrence and an organism of low virulence. 2. Staphylococcus epidermidis albus is an habitual parasite of the skin and is able to produce a mild local suppuration. It is of very feeble virulence. Its morphological and cultural characters are almost identical with those of Staphylococcus pyogenes albus. The staphylococci are among the most resistant organisms in wounds and usually persist in the wound during the course of sterilization until surgical sterility has almost been attained. That is, until the number of organisms seen in film preparations made from the wounds is reduced to 1 or less per field. Any of the staphylococci may be associated with local suppurating foci or boils in the neighborhood of wounds or on the skin generally. In the case of an army on active service, a great deal of disablement and loss of time is brought about by these suppurative skin conditions: boils, carbuncles, acne, furunculosis, folliculitis, impetigo, dermatitis, and the like, which in the RAMC are grouped under the general heading of ICT, inflammation of connective tissue. The causes are lack of facilities for cleanliness, unsuitable food, and debility from any cause, including, in the case of an army in the East, malaria and other tropical diseases. These conditions are almost always of staphylococcal origin, and they yield rapidly and completely to treatment by vaccines. Stock vaccines in large doses are sometimes useful in these conditions, but uncertain in their action, and never so strikingly successful as autogenous vaccines. The remarkable success attending the use of the latter in particular would suggest that there are a large variety of strains of the staphylococci which, though morphologically and culturally indistinguishable, yet produce slightly dissimilar toxins, and therefore require a specific and dissimilar antitoxin for their neutralization. Streptococcus. This is perhaps the most important aerobic organism found in wounds. There are many varieties which show a wide range of pathogenicity, as well as morphological and cultural differences. Different classifications of the streptococci have been proposed according to the different behavior of the strains in certain cultural reactions. Schottmuller's classification is based on hemolytic or non-hemolytic action on blood agar plates. The Streptococcus pyogenes, for example, when growing on such plates, produces colonies which hemolyze the blood in the immediate neighborhood, forming a distinct translucent halo around each colony. Certain other varieties produce no change in this respect. Andrews and Horder, on the other hand, have used fermentation tests with certain sugars as a standard of differentiation, and by this means have been able to describe 6 different varieties. For practical purposes in connection with the surgery of wounds, we may regard streptococci as being present in 2 main varieties, 1. Streptococcus pyogenes, and 2. Streptococcus faecalis. 1. Streptococcus pyogenes is usually by far the more virulent. It is a parasitic microorganism whose habitat is the surface of the body, the natural orifices, and the intestine. It is commonly present in feces and gains access to wounds mainly from the skin and feces-contaminated clothing. Morphologically, the cocci are usually rather more ovoid in shape and rather larger than staphylococci, and they occur typically in longish chains, 20 to 50 members. A diplococcal arrangement is also very frequently seen both in films from wounds and in cultures. Culturally, growth occurs on all the ordinary media, but much more delicately than that of the staphylococcus. On agar, the colonies are pinpoint in size, translucent, with very slight central opacity, convex and shining by transmitted light, and grayish-white by reflected light. To obtain a copious growth of streptococcus, which is often desirable, for example in the preparation of vaccines, it is well to use a medium specially enriched in protein, such as serum agar, blood agar, or trip agar. We have found brain agar to be equally good for this purpose, or even superior to those mentioned, and it has the additional advantage that it can be sterilized in the autoclave without deterioration. In the non-dust-proof laboratories employed on active service, where it is difficult to keep serum and blood media sterile, this advantage is one of very great importance. Milk is a very suitable liquid culture medium for streptococcus and is particularly suitable for culture of the organism from the blood or from inflammatory exudates such as infected knee joint synovial fluid. Streptococcus is a facultative anaerobe, and it often appears in anaerobic milk cultures in connection with the cultural investigation of the conditions just mentioned. Relation to wounds. Streptococcus pyogenes is present in almost all wounds and varies greatly in virulence. It is responsible for all degrees of inflammatory lesions, from indolent local suppuration to the most acute and fatal septicemia. It is highly resistant to antiseptic measures when in situ in wounds and is a difficult organism to eradicate. Indeed, in the course of the sterilization of a wound by the Carroll-Dakin method, it usually persists to the last, although its virulence becomes more and more diminished as the sterilization progresses. In localized or chronic suppuration, it is usually associated with other organisms, but it appears to exercise a more potent influence than most of the others. In preparing autogenous vaccines from wounds in order to raise the patient's immunity to his infection and to aid the healing process, whatever other organisms are found, a special effort should always be made to isolate streptococci and make them the basis of the vaccine. The good results that follow the use of autogenous streptococcal vaccines bear out the truth of the well-known bacteriological findings that Streptococcus is perhaps the most harmful of all the pyogenic organisms in wounds or any other suppurative foci. Streptococcus pyogenes is, however, most typically associated with the more acute and spreading inflammations and with septicemia. Such acute spreading conditions as acute cellulitis, osteomyelitis, and arthritis in connection with wounds are almost always due to the action of Streptococcus pyogenes. A considerable number of cases can be recalled in which acute, rapidly spreading osteomyelitis or cellulitis has supervened on a wound infection and has led to amputation. In such cases, this organism can usually be isolated from the affected bone or edematous and congested subcutaneous tissue at some inches above the position of the wound. Delayed infection of the knee joint, which is a very serious inflammatory condition, has been found to be due in every case to Streptococcus pyogenes, and the usual path of infection in these cases has been a fissured fracture of femur or tibia from the site of the wound to the joint. A very fatal form of septicemia following wounds, especially compound fractures or penetrating knee joint wounds, is due to the Streptococcus pyogenes invading the bloodstream. It is always severe and usually fatal, and may run an acute or chronic course. The only effective treatment of such cases is by means of heroic doses of an autogenous Streptococcus vaccine. In a fair proportion of wound infections terminating fatally, whether as a result of secondary hemorrhage or other condition, the blood appears to become invaded with Streptococci alone or occasionally in combination with other organisms as a terminal antemortem event. 2. Streptococcus faecalis is a short-chain streptococcus occurring typically in pairs and in chains of 4 to 8 members. In cultures, its growth is not quite so delicate as Streptococcus pyogenes, the colonies on agar being rather larger and slightly more opaque. The sugar reactions of the two organisms are practically similar, acid production without gas being produced in saccharose, lactose, salicin, and mannite. In addition, Streptococcus faecalis produces clot in litmus milk and liquefies gelatin, while the pyogenes variety produces simply acid in litmus milk and has no action on gelatin. Streptococcus faecalis is a constant inhabitant of the small intestine and is very commonly isolated from feces and feces-contaminated material such as sewage-polluted water. Relation to wounds. In wounds, the virulence of the organism varies, but is usually much less than that of Streptococcus pyogenes. It is a very common inhabitant of wounds, and is probably always present in connection with circumscribed putrid wounds, where it is associated with anaerobes and gas gangrenous processes. It is much less frequently associated with acute spreading septic infection or with septicemia than the Streptococcus pyogenes, but it undoubtedly does occasionally cause such acute infection. But of 8 cases of streptococcal septicemia complicating wounds which the authors investigated bacteriologically, 6 proved to be due to Streptococcus pyogenes and 2 to Streptococcus faecalis. These 2 latter cases were of quite as severe a type as those due to the pyogenes variety. This may, however, be unusual, as other writers have more commonly found the septicemia produced by it to be of moderate rather than of extreme severity. End of Part 1 of Chapter 4. Chapter 4, Part 2 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 4, The Bacteria of Wounds, Part 2. Enterococcus. This organism is conveniently considered along with the Streptococci, as it is really a variant of the Streptococcus faecalis group. It is still doubtful whether it deserves a separate designation, and until recently has not received it in English textbooks, although it has had for some years a literature of its own in French and German publications. Its very frequent occurrence in wounds has brought it into prominence during this war. Tissier found from his experience in Flanders that it was the most common organism found in wounds. Its morphological and cultural characters are very similar to those of Streptococcus faecalis. The chief points of difference culturally are that the Enterococcus does not liquefy gelatin and does not clot milk, both of which are constant reactions of Streptococcus faecalis. On the other hand, it causes acid production and raffinose, a reaction which Streptococcus faecalis fails to give. Otherwise, the organisms appear to be identical. Relation to wounds. The Enterococcus is definitely pathogenic, but its virulence varies much with different strains. It is usually much less virulent than Streptococcus pyogenes. It is a pyogenic organism with a marked tendency to a local rather than a general inflammatory action. Its most typical and harmful effect in wounds is perhaps produced by enhancing organisms such as B. coli and B. perfringens, in other words, by means of symbiosis with other bacteria. It is convenient to consider this question of symbiosis here, although it should be understood that it applies almost as much to the Streptococci and other bacteria of wounds as it does to the Enterococcus. Symbiosis. By symbiosis of bacteria, we mean growth of two or more bacteria in close association in such a way that the growth of each is stimulated by the other. It is a widespread phenomenon in nature, well known to agriculturalists by the example of nitrifying bacteria. These bacteria commonly attach themselves to the roots of leguminous plants, from which they draw their sustenance. In return, they fix the nitrogen of the air, which becomes available to the plants as an essential and nourishing food constituent. In this way, an active and progressive partnership is set up between plant and bacteria, which results in mutual advantage. A similar phenomenon occurs when different varieties of bacteria grow together in wounds. In combination, they are often able to produce a much greater effect than the sum of all the singly produced effects. This can be readily proved by cultural experiments and by animal injection. If we take a pure culture of an organism, such as B. influenzae, and another of an organism, such as Streptococcus, and make subcultures from each of these in two parallel strokes upon the surface of a sloped blood auger tube, it is found that, by the association of the two organisms in the same tube, an unusually vigorous growth of each is obtained. When cultures of two organisms are injected together into laboratory animals, the reaction is enormously greater than that obtained by injection of the same dose of each of them separately. Thus, a culture of the Enterococcus injected into a guinea pig produces varying effects according to its virulence, from a slight local inflammatory reaction to septicemia within 7 to 14 days. Further, B. perfringens injected alone into a guinea pig usually produces no effect unless the tissue at the site of injection be damaged. Even then, it may be inert. But in some cases it produces a spreading gaseous edema which may or may not be fatal. Now, on the other hand, when the Enterococcus and B. perfringens are injected together under the same conditions, the fatal issue is practically certain to be produced within 3 days. Similarly, in wounds, by analogy and by observations on films and cultures made from a large series of wounded men, we can be sure that the combination or symbiosis of certain organisms, ceteris paribus, produces a much more severe or persistent inflammatory disturbance than that produced by the same organisms singly. Enterococcus and symbiosis. The association of the Enterococcus or Streptococci and the gas-producing anaerobes is particularly deadly, in that thereby the anaerobes have a greatly increased chance of establishing their growth in the tissues. Whether the aerobes produce this stimulating effect on the growth of the anaerobes by means of toxin formation or of oxygen absorption is imperfectly understood. But it is now well established that, given dead or badly devitalized tissue, such as is found in shell wounds, especially in fatigued subjects, and given infection with the Enterococcus and B. perfringens or other set of pathogenic aerobes and anaerobes, and given also absence of oxygen in the depths of the wound, the conditions are ideal for the onset and rapid spread of gas gangrene. These conditions are so important because they are exactly those that obtain so commonly in war wounds, especially during rushes when the men are fatigued, and it is for this reason that gas gangrene has been so common in this war. Similarly, in the case of tetanus, it has been found repeatedly that tetanus is more likely to supervene in connection with badly septic wounds than in connection with clean wounds, although the chances of contamination with B. tetani are equal in the two cases. And the reason for this is again that the presence of aerobes makes it more easy for B. tetani to grow and produce its toxins than when it has to rely upon its own powers of overcoming the resistance of the tissues and establishing its growth. In referring thus to tetanus, we are aware that in civil life, tetanus may follow upon a mere abrasion of the skin, so slight as to be almost unobserved. But this is most unusual in connection with wounds, and may be regarded as the exception which proves the rule. The enterococcus is one of the most common organisms of wounds, and moreover, one which exerts its effect largely by symbiosis with other aerobes and with anaerobes. The latter action especially has been so deadly that it may be said that the chief pathogenic role of the enterococcus in this war has been as an adjuvant to B. perfringens in producing gas infection, and what has been said in regard to the enterococcus applies in greater or lesser degree also to other anaerobes, for example, Streptococcus, Staphylococcus, B. coli, and the like. Pneumococcus. Morphology. The pneumococcus is well known as a capsulated lanceolate diplococcus. It is rather larger than a streptococcus, measuring as a rule 1 to 1.2 microns in its greatest diameter. It occurs in this form in films from wounds, but in cultures it may form short chains of 4 and 6 members, and capsulation is indistinct. It then closely resembles morphologically a short-chained streptococcus. It is gram-positive. Isolation. Its isolation from wounds is somewhat difficult. It can sometimes be isolated by washing the mucus or tissue or wound discharge in sterile water and plating out upon blood agar, brain agar, or trip agar. It is essential to use one of the protein-enriched culture media, and trip agar is especially suitable, as a neutral or slightly alkaline reaction in the culture medium is most favorable. The colonies are minute, transparent, and colorless, like drops of dew. They are scarcely visible to the naked eye. Under the microscope they appear distinctly granular and have a darker center. The most certain method of isolation is to inoculate a white mouse with the material containing the organism. White mice are exceedingly susceptible to the pneumococcus, a virulent septicemia being rapidly produced. The organisms can thus be readily obtained in pure culture from the heart's blood of the animal. Relation to wounds. The pneumococcus is a normal inhabitant of the upper air passages. It becomes a highly pathogenic organism when it invades certain mucous and serous surfaces, for example, the bronchioles, the peritoneum, the meninges, and the pleurae. It causes local suppuration and severe toxemia. The pus has often a characteristic flaky and mucoid appearance. In wounds, the organism is of most common occurrence where the chest and air passages are involved. Hemothorax and jaw cases being the two most frequent types of wounds which harbor it. It may be present, more rarely, however, in wounds in any situation. In one case, for example, it was recovered by the authors from a wound of the hand, and in this wound the characteristic flaky mucoid pus was present. Fortunately, it appears very rarely to invade in wounds those structures, such as peritoneum and meninges, which are especially susceptible to its action. In a very large experience, we cannot recall a single case of this. The general action of pneumococcus in wounds is to assist the suppurative process, particularly in wounds of the respiratory passages. Streptococcus mucosus is an organism closely allied to the pneumococcus and occasionally found in wounds. It is a large, capsulated, rounded cocobacillus, occurring in pairs, short chains, and occasionally in long chains. It is rather larger than the pneumococcus, measuring 1.25 to 1.75 microns in length, and 0.5 to 0.75 microns in breadth. Each is surrounded by a relatively broad halo or capsule, 1 to 3 microns in width. Like the pneumococcus, it is gram-positive. Its cultural characters resemble those of Streptococcus pyogenes, but the colonies are larger and have a bluish cast. They are thus easily distinguished from those of the pneumococcus. It grows most readily on the protein-enriched agar media, but is quite vigorous on ordinary agar. The organism is a normal inhabitant of the human mouth. It is pathogenic to animals, and in man occurs in a variety of suppurative conditions. In wounds, it is especially common where air passages are involved, and occasionally is found also in wounds of other situations. It is a pathogenic organism, and its action in wounds is a localized suppurative one, without any tendency to cause spreading or generalized infection. Micrococcus tetragonus. Morphology. This is a large encapsulated coccus, grouped in fours, forming tetrads. The cocci measure 1 micron or slightly more in diameter, and are round, oval, or more typically kidney-shaped. The tetrad arrangement is very constant in wounds, although pairs are also often seen. It is gram-positive. Isolation. This is easily accomplished by the ordinary plate method or by successive strokes on agar tubes. The organism grows very readily on all the ordinary media and at room temperature. On agar it forms spheric, moist white colonies, which have a viscid and tenacious character, owing to the gelatinous nature of the sheaths of the cocci. The growth on agar is often confluent, forming a moist white layer. Relation to wounds. Micrococcus tetragonus is a frequent tenant of the respiratory passages in health and disease, especially tubercular disease. It occurs most frequently in wounds of the respiratory passages, but it also occurs with a fair degree of regularity in wounds of other parts of the body, whither it may have been conveyed in droplets of saliva or saliva-contaminated material, such as clothing. It would seem that the knees of the trousers in soldiers are particularly liable to become infected, for the M. tetragonus is of not infrequent occurrence in penetrating wounds of the knee joint. It is possible that the way in which food is eaten in the trenches may have some bearing on this fact. For food, part of which has been in the mouth, is often placed upon the knees of the trousers. Out of the 50 cases of penetrating wounds of the knee joint investigated bacteriologically, the authors isolated it from 8. This gives a percentage of 16 and appears to be a relatively high proportion in comparison with the rate of frequency of its occurrence in wounds generally. Micrococcus tetragonus is pathogenic to laboratory animals, especially to white mice, in which it causes a rapid septicemia. In man, it is one of the pathogenic organisms. In wounds, it assists the suppurative process and is not associated with spreading or general infection. Micrococcus catarrhalis. Morphology. This is a relatively large, ovoid, gram-negative diplococcus. It measures 1 to 2 microns in diameter. The gram-negative staining differentiates it from most of the other common diplococci which occur in wounds. Cultural characters. It grows very readily upon most media and at room temperature. On agar it forms large white colonies resembling those of Staphylococcus albus. Relation to wounds. Micrococcus catarrhalis is an organism of the respiratory tract and conjunctiva, and occurs not infrequently in wounds of these structures. It is very slightly pathogenic to animals, and in man is typically associated with superficial inflammations of mucous membrane. Its action in wounds appears to be, in most cases, but a feeble suppurative one. Sarcinae. Morphology. These are large, rounded cocci which, in cultures, are grouped in little cubes or packages of 8 or more members. They are closely allied to staphylococci, but morphologically they are larger and show the characteristic bale or package arrangement. Culturally, they are of more coarse and vigorous growth. They are gram-positive. They appear in films from wound exudate as large gram-positive cocci in pairs or cubes. Cultural characters. They grow readily on culture media at room temperature, forming large pigmented colonies, which after a day or two become umbilicated in the center. The colonies are rather larger than those of Staphylococcus. Some varieties produce a golden pigment, some a white, and some a lemon-yellow pigment. These varieties are called respectively Sarcina aurea, Sarcina alba, and Sarcina lutea. Relation to wounds. Sarcinae have their habitat in the gastrointestinal tract. They are isolated very frequently from stomach contents, especially in a pathological dilated condition of the stomach associated with much fermentation. They are also a very common occurrence in feces. They can be found frequently in superficial inflammations of the skin, impetigo, and the like. They are slightly pathogenic, having very little action on the tissues when alone, but their action is much enhanced by the presence of other organisms. In wounds, their chief action is to aid local suppurative and gangrenous processes by symbiosis with other aerobes and anaerobes. Their action is strictly localized. General review of the pathogenic cocci. 1. Symbiosis with anaerobes. Certain recent researches of Tissier, 1916, throw considerable light upon the effect of the pyogenic cocci and other aerobes in influencing anaerobic activity. He showed both in wounds and by animal experimentation that the aerobes whose chief action is localized, such as the Enterococcus, Staphylococcus epidermidis albus, and Sarcinae, when associated with anaerobes are jointly responsible for circumscribed putrid wounds. The spreading gangrenes, on the other hand, contain in addition true pyogenic organisms, such as Staphylococcus pyogenes aureus and albus, and in the most rapidly spreading, Streptococcus pyogenes is the associated aerobe. When mixed cultures of aerobes and anaerobes are injected into the damaged tissues of experimental animals, the result depends largely upon the nature of the aerobes injected. The greater the tendency for the aerobe to spread in the general circulation, the more rapid is the onset of the anaerobic septicemia. Thus, B. perfringens mixed with the Enterococcus kills the guinea pig in 3 days, mixed with Staphylococcus pyogenes albus in 24 hours, and with Streptococcus pyogenes in 15 hours. These findings are in complete agreement with our own observations on the organisms isolated by culture from a large series of wounds. The usual effects of mixed aerobe and anaerobe infections are those outlined above, the severity being dependent mainly upon the aerobe present. Considering the extreme importance of the gangrenes, localized and spreading, in the wounds of this war, it is hardly too much to say that the relative importance of the various pyogenic cocci is mainly determined by the effect of their association with anaerobes. Further, the spreading gas gangrenes have been so much more dangerous to life and limb than the more localized that one might venture to place the associated aerobic pyogenic cocci in the following order with regard to their harmful action in wounds. 1. Streptococcus pyogenes. 2. Streptococcus faecalis. 3. Staphylococcus pyogenes aureus. 4. Staphylococcus pyogenes albus. 5. Enterococcus. 6. Staphylococcus epidermidis albus. And 7. Sarcinae. 2. Individual or independent pathogenic action. Apart from the question of anaerobes, this order also roughly corresponds to their degree of pathogenic action when they exert their effect alone in ordinary inflammation suppuration. The most virulent inflammations are associated with Streptococcus pyogenes. A notable example is found in penetrating wounds of the knee joint. If the aspirated synovial fluid from a series of infected knee joints be examined, it will be found most constantly that, out of all those which contain aerobes only, the joints infected with Streptococcus pyogenes are by far the worst. The authors found that in this type of case it was usually hopeless to treat the joint by rest alone, but that it was necessary to open the joint early and apply vigorous active antiseptic measures. Even then, the condition was very liable to progress to septicemia. Similarly, with the more chronic suppurations, it is here again the streptococci which are responsible for most of the damage. Cultures made from such wounds reveal their presence in practically every case, and the fact that autogenous streptococcal vaccines in these cases yield such good results indicates that the streptococcal toxin is the principal harmful agent. The staphylococci, Enterococcus, and Sarcinae have on the whole been found to be more localized in their suppurative effects. The pneumococcus, Streptococcus mucosus, micrococci tetragenous, and catarrhalis are in a class by themselves, as they are chiefly confined in their action to certain regions and have affinities for mucus and serous surfaces. 3. Diplococci. In smears made from wound exudate at various times during the course of sterilization of the wound, gram-positive diplococci are perhaps seen more commonly than any other type of organism. In the majority of cases, these are really streptococci, which very frequently assume the diplococcal arrangement when growing in wounds. Others are staphylococci, pneumococci, enterococci, or sarcinae. When these have all been excluded, however, there appears to remain a group about which we have little knowledge. They occur every now and then in cultures from wounds, usually as large gram-positive diplococci, growing readily on the ordinary media. They sometimes exhibit polymorphism and resemble diphtheroid bacilli. Occasionally very small, delicate growths are obtained, resembling those of Streptococcus, and the cocci themselves in such cases are smaller and more delicate. The arrangement of the cocci, however, is constantly diplococcal, and no appearance of chain formation can be made out. This group has not been sufficiently investigated, but it is very probable, judging by their cultural characteristics and by clinical considerations, that the first mentioned especially are of doubtful or low pathogenicity. At most, they probably aid feebly the suppurative process. Aerobic bacilli. B. coli communis. This bacillus, as the typical representative of fecal contamination, must be expected to be a fairly frequent tenant of wounds. It has been thoroughly proved that B. coli is much more frequently present in wounds of the buttock and lower limbs than in any other situation. It seems to gain entrance to wounds mainly in the pieces of feces-contaminated shirt, pants, and trousers which are carried in with the missile. It can also be very easily introduced subsequently through lack of cleanliness or care in dressing wounds aseptically. Morphology. It is a short gram-negative motile rod measuring 1 to 3 microns in length. Its motility is due to a number of whip-like processes or flagella which are attached to its substance, and which, by their lashing in a fluid medium, cause movement of the bacillus. Cultural characteristics. It is readily cultivated on all the ordinary media. On a 24 hours auger slope, the colonies are large, grayish-white, and semi-translucent. As they grow older, they enlarge and become more opaque. They are often confluent. Litmus milk is rapidly acidified and coagulated. The litmus is first reddened and later decolorized. Sugar reaction. It has very active fermentative powers upon various sugars, and in particular produces acid and gas in lactose, glucose, galactose, livulose, and mannite, while some varieties also produce acid and gas in saccharose. Gelatin is not liquefied. Indole is formed from peptone in peptone water media. Relation to wounds. B. coli occurs as a saprophyte in great numbers in the human intestine, particularly in the colon, where it is concerned with fermentation and putrefaction of the intestinal contents. It often assumes a pathogenic role, particularly in suppurations connected with the intestine, for example in appendicitis. It is also found occasionally in the blood, especially in cases where the wall of the gut has been injured, as in the dysenteries, and also in wounds of the intestine. Occasionally it invades the bloodstream from infected wounds involving bone, causing a severe septicemia. In wounds, its action depends upon the conditions present and the stage of the inflammatory process. In gangrenous wounds, where the sugar-splitting anaerobes have broken down the fermentable carbohydrates of the dead tissue, and where the putrefactive anaerobes are at work converting proteins into simpler products, B. coli is able to intervene at the peptone stage of proteolysis, forming indole and other aromatic compounds from these substances. It can therefore act in these wounds as one of the subsidiary proteolytic bacteria. In ordinary suppurative wounds, where there is no dead tissue to be destroyed and the interaction is between the bacteria and living tissue, neither its fermentative nor its putrefactive properties are called into play. But there, by its severe toxic action and by symbiosis with other organisms, it becomes intensely pyogenic. In suppurations in bone, where venous channels are opened up, it occasionally gains access to the blood and gives rise to a septicemia of moderate or considerable severity. It is at times found in the blood also as a terminal antemortem event in cases of septicemia due to other organisms, for example, streptococcal septicemia. B. coli is not very resistant to hypochlorite treatment of wounds when thorough surgical exposure of the wound has been made and dead tissue eliminated. When the Carroll-Dakin treatment is used and properly carried out, it disappears rapidly, within a few days in most cases, preceded or accompanied by the disappearance of the anaerobic bacteria. When gangrenous tissue and sloughs, macroscopic and microscopic, have been dissolved away, and the sterilization process is actively continued, it seldom persists long in the wound. If it does, there is certain to be something wrong, either with the preliminary excision of the wound or with the mode of application of the dressings. It is never one of the terminal organisms which remain in the wound when sterilization is nearly complete. For example, when the bacterial count is less than 3 or 4 organisms per field. Its resistance in wounds approaching sterilization appears, therefore, to be very much lower than that of the pyogenic cocci. On the other hand, when flavine is the antiseptic used, the resistance of B. coli in wounds is relatively much greater, and during flavine treatment it may be cultivated readily at a stage when no growth of the pyogenic cocci can be obtained. Coliform bacilli. This is a large and interesting group of the bacterial flora of wounds. It includes several subgroups, such as the Proteus group, the Friedlander group, and many varieties of bacilli resembling more or less closely B. coli at one end of the scale and B. typhosis at the other. The variety of organisms of this class found in wounds is perhaps as great as the variety of such organisms found in feces. In making a series of cultures from wounds, one constantly finds organisms of this class which do not fall into any of the well-known subdivisions. Moreover, it frequently happens that, in a series of wounded men coming at the same time from the same part of the line and treated with the same conditions, similar strains of coliform bacilli are found with great regularity in the wounds. Whether these have been introduced at the time of the infliction of the wound or at a subsequent period, it is impossible to say. The example may be quoted of a series of about 50 bomb wounds inflicted at one time and in one quarter during an air raid, and admitted to a base hospital. 8 of these wounds, of which 6 were wounds of the lower extremities, yielded on culture a coliform organism having the following salient characteristics. The organism was a small, slowly motile, gram-negative bacillus. It grew readily in large, whitish, semi-translucent colonies on agar. Gelatin was not liquefied. It formed slight acid in glucose and in litmus milk, but did not ferment lactose, mannite, saccharose, maltose, or dulcite, nor did it produce indole. The reactions resembled those of HUGHES bacillus of dysentery, but the growth on agar was much more profuse, resembling indeed that of B. proteus, the acid production less, and no agglutination with anti-HUGHES serum took place. Unfortunately, means were not available at the time for testing pathogenicity. A similar organism to this has been found with considerable regularity in a large series of wounds of all kinds, the lower extremities being the site of most frequent occurrence. On several occasions it was also found in the blood of wounded men, where it appeared to be the cause of a remittent fever of 7 to 9 days' duration. Vide septicemia. B. Proteus vulgaris is found occasionally in wounds, particularly in the same class and stage of wound that harbors B. coli. These 2 organisms are often present together in the same wound. Morphologically, it is an actively motile, gram-negative bacillus of length 1.2 to 4 microns. Cultural characteristics. It grows readily upon the ordinary media. Upon agar, it forms a moist, thin, grayish, semi-transparent, rapidly extending layer. Single colonies are irregular in shape owing to numerous offshoots from the periphery of the colony. So marked is this feature in some cases that the colony can be said to be in a condition of amoeboid movement. Gelatin is rapidly liquefied, and this feature readily distinguishes the organism from most of the other coliform bacilli. Milk is coagulated. Sugar reactions. Glucose and saccharose are fermented with acid and gas production. It is a non-lactose fermenter. In most culture media it produces a characteristic and very disagreeable odor, and this is most marked in media not containing sugar. In such media, its putrefactive properties come into full play, and it produces the aromatic compounds scatol, indole, and phenol, as well as gases of putrefaction from breaking down of the peptones. Relation to wounds. These reactions, which are produced in culture media, provide a clue to the action of the organism in nature and in wounds. It is an organism of the large intestine, where it exerts a fermentative and putrefactive action on the intestinal contents. In any series of bacteriological examinations of feces, B. proteus is very frequently found to be present. Both in the animal intestine and in wounds, its action is very similar to that of B. coli communis, except that its putrefactive activity is somewhat greater. In gangrenous sloughing wounds, it assists tissue lysis, and in all wounds it aids the suppurative process. Its duration in wounds and degree of resistance to hypochlorites and to the antiseptic dyes, such as brilliant green, is practically the same as that of B. coli, which in most of these reactions is the type organism of the whole of this group of bacilli. There is a subgroup of motile bacilli found in wounds which resemble B. proteus in type, but which show minor variations, for example, in cultural and especially in fermentative reactions. These are classed conveniently as the proteus subgroup of bacilli. For practical purposes, in wounds, their reactions and effects may be considered to be identical. B. pneumoniae friedlander, or the pneumobacillus, is another aerobic intestinal coliform organism which not uncommonly appears in wounds, particularly in those involving any part of the respiratory tract. Morphology. It is a small, capsulated, non-motile, stout, gram-negative bacillus. It is somewhat more elongated than the pneumococcus, and the capsule is of a similar breadth. Cultural characteristics. It grows readily upon all the common media. On agar it produces a luxuriant whitish or slightly yellowish and very viscid layer of growth. This type of growth is common to a large number of the coliform organisms. A gelatin stab culture is, however, characteristic. A rounded white mass is formed on the top of the gelatin, and a confluent growth along the needle track. The result is the typical nail-head appearance. The organism has great fermentative activity. It acidifies milk and produces acid and gas in nearly all the sugars, but does not form indole. Its putrefactive activity is therefore low or absent. Pathogenicity. It plays a part in suppuration of various kinds, particularly about the mouth, and is the cause of acute lobular and lobar pneumonia in a relatively low percentage of cases. Relation to wounds. The organism is found normally as a parasite in the respiratory and upper digestive tracts, and it also leads a saprophytic existence upon organic matter apart from the living body. The types of wound in which it most commonly occurs are those involving the respiratory apparatus, particularly hemothorax and jaw cases. It appears to have a special selective inflammatory action on lung tissue. The authors have recovered it from pyemic abscesses in the lung in most of the cases investigated. It occurs also occasionally in wounds of other parts of the body, particularly where there have been gross fecal contamination and opportunities for the rapid multiplication of the organisms which have gained access to the wounds. Thus it is found occasionally in severe gangrenes or sloughing wounds. Its general action in wounds is fermentative, pyogenic, and toxic. Other coliform bacilli. A great variety of such organisms occur in wounds, and in making any large series of cultures from septic wounds, one not infrequently comes upon new types. One of these, which the authors isolated from a certain group of wounds, has been already described. Another one presenting slight differences from the latter organism may be referred to here. This organism was isolated from 15 out of 200 open septic wounds from which cultivations were made. Every case from which it was isolated was a wound of the lower limb, and these wounds included penetrating knee joint wounds, compound fractures, and flesh wounds. The organism was a small, motile, gram-negative bacillus, growing readily on agar in large, whitish, moist, shining colonies. Gelatin was not liquefied. Litmus milk was first acidified and later decolorized. Acid was produced in glucose and mannite, but not in maltose, lactose, saccharose, or dulcite. Peptone water. General turbidity was produced. No indole was formed. We had no opportunity of submitting the organism to all the standard fermentative tests, but so far as we were able to judge, the organism appeared to be identical with that described by Castellani under the name of B. candiensis. The coliform bacilli of wounds approach more or less closely the type of B. pneumoniae, Friedlander, or the type of B. proteus, that is, they are either mainly fermentative or mainly putrefactive. In our experience, the former group is by far the commoner. Some, like B. coli communis, perform both saccharolytic and proteolytic functions in almost equal degree. In general, they are also pyogenic and toxic, and they exert these functions best in the presence of necrotic tissue in the wound. Their resistance in wounds to which the Carroll-Dakin method of treatment is applied is low, but under Flavine treatment is relatively higher. On rare occasions they are capable of finding their way into the bloodstream and giving rise to a generalized infection or septicemia of mild or moderate severity. Diphtheroid bacilli. The occurrence of B. diphtheriae, Klebs-Loeffler, has been definitely observed, though rarely, in certain wounds resulting from injuries in civil life. We are not aware, however, of any published case in which this true diphtheria bacillus has been isolated from wounds of this war. It is possible that in the primary excision of wounds, which is now carried out within 24 to 36 hours of their infliction, the true diphtheria bacillus is removed or is so diminished in numbers that, in the face of the active antiseptic treatment which follows, it is unable to establish the typical recognizable form of the disease. That the disease is really present and unrecognized in any considerable number of cases is unlikely, since in that case the paralytic and pruritic complications which are so characteristic and relatively common would be certain to give rise to comment. There is, however, a group of bacilli, morphologically somewhat similar to the B. diphtheriae, which commonly attack war wounds, and are found both before and after excision of the wound. The primary infection of wounds in a large proportion of cases results in the growth of a grayish membranous exudation lining the tract. One of the organisms which often occurs in large numbers in this membrane is Vincent's bacillus, B. fusiformis. It is probable, however, that it is a mere saprophyte, living upon and breaking down the necrotic tissue. The other organisms found in the membrane are equally or more important, for they are often more toxic and provide the starting point for the anaerobic activity. Among these extraneous organisms is the group of diphtheroid bacilli, which indeed, by local toxic action, assist in forming the membrane itself. Further, after excision of the wound with its membranous lining, and while the reinfected surfaces are undergoing sterilization, diphtheroid bacilli may still be found in the discharge, and indeed they are at times so persistent in the wound that they are still found along with the pyogenic cocci when the total number of organisms seen in films is low enough to admit of secondary suture being safely performed. The latter condition particularly applies to wounds which have parts difficult for the antiseptic solution to penetrate. Diphtheroid bacilli are much less luxuriant in wounds treated by the Carroll-Dakin technique than in those treated by the older methods. It is this group of aerobes, perhaps more than any other, whose numbers and virulence in wounds appear to be so much diminished by the efficient application of the Carroll-Dakin treatment. Thus, in a large series of wounds undergoing this treatment, the diphtheroids have been found to be of relatively uncommon occurrence, and have been in most cases confined to wounds of chest and jaw. Wounds of these regions are readily accessible to the diphtheroid bacilli, whose natural habitat is the buccal and respiratory mucous membranes. Such wounds, moreover, are often unsuitable for the application of the Carroll-Dakin technique, which appears to be particularly inimical to them. Morphology. The type of organism is B. diphtheriae, Klebs-Loeffler. This is a relatively small 1 to 6.5 micron, non-motile, gram-positive bacillus. It has distinct granules in its protoplasm, which show different staining reactions from the body of the bacillus with certain stains, for example, Loeffler's methylene blue and Neisser's stains. These are known as metachromatic granules. Another and most characteristic feature is its pleomorphism, or variety in size and shape of the individuals in cultures. Thus, in a 24 hours culture, many of the organisms are larger than normal. Some are spindle-shaped, some lancet-shaped, and many have large clubbed ends. Cultural characteristics. It grows fairly well upon the ordinary media, but prefers blood serum. Growth is never profuse. It is purely aerobic. Litmus milk is acidified. Sugar reactions. Acid is produced in glucose and maltose and certain of the rarer sugars. Indole is not formed from peptone. Its fermentative action is therefore limited, and it has no putrefactive action at all. Pathogenesis. It produces several very powerful toxins, one of which is a powerful general poison, and another, neurotoxin, has a selective poisonous action on certain motor nerves, such as those of the heart, the palate, and ocular muscles. A condition of neuritis is produced in these nerves, with consequent paresis and paralysis of the muscles which they supply. The organism is powerfully pathogenic to the lower animals. Relation to wounds. Its natural habitat is the human mouth, where it is parasitic in certain individuals, carriers. It occurs rarely in civil wounds, and when it does, renders the subject liable to all the complications of the disease diphtheria, with the exception, of course, of the usual respiratory complications. The wound is often a shallow one, and the granulations become covered with a typical diphtheritic pseudomembrane consisting of necrosed tissue cells and leukocytes embedded in a coagulated fibrinous matrix which has undergone hyaline degeneration. The process is therefore one of coagulation necrosis. The bacilli are found in great numbers in the membrane. They remain localized, producing their toxins and causing a profound general toxemia. True septicemia seldom, if ever, occurs. In the wound, the diphtheria bacillus is usually associated with pyogenic cocci, which gradually transform the membrane into a sloughy, discharging mass. In war wounds, its presence has not, so far as we are aware, been noted. This is probably on account of the primary excision of wounds, which reduces the number of infecting organisms so considerably, and also because of the vigorous and continuous antiseptic measures which are applied to war wounds. The diphtheria bacillus is a pure aerobe, and establishes itself only where there is a free supply of oxygen. In wounds it is, therefore, always associated with the superficial parts, and these are the parts which in all systems of war wound treatment receive adequate supplies of antiseptic. The effect of such treatment appears to be completely inhibitory on the organism's growth and activity. End of Chapter 4, Part 2. Chapter 4, Part 3 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 4, The Bacteria of Wounds, Part 3. Diphtheroids. The group of diphtheroid bacilli found in wounds are mostly unnamed and show considerable variation in their reactions, but morphologically show a resemblance to the true diphtheria or pseudo-diphtheria bacilli. In some cases, very small bacillary forms, closely resembling streptococci, are met with. They grow readily on the ordinary media, but seldom profusely. The colonies on agar are in most forms slightly larger and flatter than those of streptococci, and show a tendency to umbilication. Their fermentative reactions vary, but are seldom marked. Some do not produce acid at all in any of the commoner sugars, and others ferment a variety of them, with acid production only. They do not form indole. Their chief action in wounds appears to be locally toxic and symbiotic. In combination with other organisms, the growth of each is stimulated. Very rarely do they enter the bloodstream, but a few cases have been observed in which this has occurred, and the septicemia produced has been of a very severe kind. One such case, which is described elsewhere, showed every sign of an imminent fatal result, but was treated in time with an autogenous vaccine, the result being entirely successful. B. Pyocyanesis. This organism has long been recognized as a tenet of suppurating wounds, whether of civil or military origin, and the appearance of the bluish-green pus which it produces is familiar to every surgeon. Its presence in wounds, unless due to direct infection from another pyocyanesis-containing wound, as frequently happens in a surgical ward if the greatest precautions be not taken, is one more example of the fecal origin of wound infections. B. pyocyanesis is a common saprophyte in feces, manure, and feces-contaminated water, and thence it is very easily transferred to the skin and mucous membranes, on which it may become parasitic. This process should hardly occur anywhere more readily than in the trenches in which our frontline troops live. Morphology. It is a short, slender, actively motile, gram-negative bacillus from 1 to 3 microns. It closely resembles microscopically a coliform organism, but is easily differentiated by its characteristic growth on culture media. Cultural characteristics. It grows readily upon all the ordinary media. On agar, a bright green growth develops along the line of inoculation, and in 2 or 3 days this green pigment, fluorescin, diffuses out into the culture media, giving it its characteristic fluorescent appearance. If the culture be kept some days longer, this green pigment is replaced by a second blue one, pyocyanin, and the medium changes from bright green to deep blue, and later to dark blue, and in some cases to a deep reddish-brown color. Gelatin is liquefied, and the growth on the medium is green. Relation to wounds. In wounds, its action is not generally apparent until suppuration is well advanced, and then the characteristic bluish-green pus may appear. It is more usually associated with chronic suppurations and wounds in which sterilization is delayed, as, for example, by the presence of necrotic bone or a foreign body. Its action is typically a local pyogenic one, although invasion of the bloodstream and general infection have, in rare cases, been reported. This organism has, in the past, been a great bugbear in connection with sepsis of all kinds. When once it appeared in a discharging wound, it proved most difficult to eradicate by the older methods, and it tended to spread from case to case in a ward. No such trouble is experienced with this organism under the Carroll-Dakin system of treatment, efficiently carried out. Out of nearly 2,000 wounds observed from almost the start to the finish at a base hospital, and all except a few treated by the latter method, clinical evidence of infection by B. pyocyanesis has been observed in little more than a score of cases. Out of a series of cultures made at all stages of the suppurative process from 200 of the above wounds, all of which were severe and septic, B. pyocyanesis was grown not more than 6 times. Most surgeons will agree that an incidence rate of B. pyocyanesis of 2 or 3% is something quite new in the history of grossly septic wounds. If the absence of B. pyocyanesis can be regarded as an index of rapid and efficient sterilization of wounds in any large series, a point which will, we think, be generally conceded, the evidence brought forward in connection with this series of cases is overwhelmingly in favor of the Carroll-Dakin method as compared with drainage tube, salt pack, and other older methods. B. Influenzae. This small bacillus is found usually only in connection with wounds of the respiratory tract, and in particular in hemothorax fluids. It is not an organism of common occurrence in wounds. Morphology. It is a very minute, 0.5 micron in length, non-motile, gram-negative, aerobic, pathogenic bacillus, and is one of the class of hemophilic bacteria, or one which requires a medium containing blood for its artificial cultivation. Cultural characteristics. It grows best upon glycerin blood agar or any of the protein-enriched media to which blood has been added. The colonies are minute, transparent, and colorless, like drops of dew. In culture media, its symbiotic action is well demonstrated by growing it in the same tube with other organisms when the growth becomes more copious. Relation to wounds. In smears made from wound discharge containing the organism, the latter can be demonstrated by staining with weak carbol fuchsin for half an hour. The bacillus can also be obtained in culture by plate methods with the above-mentioned media. Its action in wounds is not well understood. It has probably a symbiotic action with the pyogenic organisms, by which it indirectly aids the suppurative process. In addition, it is well known to produce a powerful intracellular toxin which acts in particular upon nervous tissue, and thus in wounds it is doubtless able to increase the general toxemia resulting from the wound infection. Subtilis mesentericus group. This group of bacilli is not usually credited with any pathogenic action, but some of the members are frequently found in certain types of wound, and the group calls for some attention here. In morphological and cultural characters they bear some resemblance to B. anthracis, and they are usually included with the anthracoid group of organisms. They are purely saprophytic, and are commonly found on dead organic matter in soil, hay, etc. They are sporing bacilli, and their spores are liable to be disseminated into the air. Thus they are very widespread and may be considered to be present in the air universally, except where the most scrupulous precautions are taken to render a place dust-proof. In laboratory work, especially in improvised laboratories, constant measures of protection have to be taken to prevent contamination of culture media by these and other organisms gaining entrance from the air. Morphology. They are large, stout, spore-bearing bacilli which usually retain gram stain. Their morphology presents some points of difference. They are seldom less than 5 microns in length and 1 micron in breadth, but they may be as long as 10 or 12 microns. The ends are usually slightly rounded, but may be square or quite pointed, as often happens in the sporing individuals. They spore readily, the spore being usually central or slightly eccentric, but never terminal. They are often in long chains, but may be single or paired. Filamentous forms are common. In young cultures, they are gram-positive, but as the culture ages, many of the individuals may lose the power of retaining gram stain. The smaller forms may resemble morphologically the group of diphtheroid bacilli. They are, however, usually stouter, and some at least of the individuals in a film are usually spore-bearing. The other group for which they may be mistaken are the anaerobic gas-producing bacilli, but there they can be differentiated by their peculiar and profuse aerobic growth, by their comparative absence of fermentative activity as tested by the sugar reactions, and by their failure to clot litmus milk. No mistakes are likely to be made if these points are borne in mind. Cultural characteristics. These organisms nearly all grow very readily and at room temperature on the ordinary media. On agar, profuse growths are obtained. Some of these, for example B. mesentericus, resemble the colonies of B. anthracis, large grayish-white, dull wrinkled colonies with irregular auriculate edges and tending to become confluent. Others form a moist, dirty white, shiny layer on the surface of the medium. They are all aerobes and are able to grow also to some slight extent under anaerobic or partially anaerobic conditions. Pathogenicity. This is very slight or absent. When pure cultures are injected into animals, the only effect produced is a slight local reaction at the site of injection. The bacilli injected are rapidly phagocyted. Relation to wounds. In wounds, these organisms appear to be present in a variety of conditions. In a large series of cultures from wounds, we have found them in the following types of wound. 1. Where there is gross necrotic or gangrenous tissue. For example, in the wound in limbs amputated for massive and spreading gas gangrene. In these cases they are, of course, always associated with B. perfringens and other anaerobic gas-producing bacilli. Their occurrence in these wounds is frequent. 2. Hemothorax cases. They may be frequently isolated from samples of infected hemothorax fluid, especially where the gas bacilli are also present. They are rarely present in such cases without accompanying anaerobes. 3. Ordinary septic wounds treated by gauze dressings and not by the Carroll-Dakin method. This was frequently observed in certain of our early cases, which were treated in a base hospital before the Carroll-Dakin method of treatment could be instituted in every ward. These wounds included a variety of septic wounds, such as compound fractures, severe flesh wounds, amputation stumps, etc. They were all treated by Usol dressings. Another series of cases in which these organisms were found by culture were septic wounds which had been kept for some time at the casualty clearing station and treated by a variety of the older methods. On admission to the base hospital, before the Carroll-Dakin procedure was commenced, it was not unusual to find this group of organisms in aerobic culture. From a consideration of these findings, it would appear that the subtilis mesentericus group of bacilli have a very restricted growth in wounds, especially where there is healthy living tissue, and where active and efficient antiseptic methods are carried out, as in the efficient application of the Carroll-Dakin method. On the other hand, the organisms appear to be able to establish themselves 1. Where there is gross necrotic tissue and the presence of anaerobes. 2. In types of wounds which do not admit of active antiseptic treatment, such as wounds involving the pleurae. And 3. In wounds which have received the less efficient antiseptic applications associated with older methods. These findings would appear to suggest, among other points, a correlation between these organisms and the anaerobic gas bacilli as regards pathogenic action in wounds. This is in accordance with the available evidence derived from animal experiments. The point is more fully discussed in the chapter on gas gangrene, where it is pointed out that injection of a culture of B. mesentericus, along with B. perfringens, into an animal is much more likely to be followed by a gaseous edema than infection of the pure anaerobe. This seems to be due in part to the aerobe taking up the attention of the phagocytes, and in part, perhaps, to oxygen absorption or some other factor which causes an increased growth of the anaerobe when the aerobe is in proximity. The latter is a fact which can be verified by growing anaerobe and aerobe side by side in the same tube of culture medium. The evidence therefore goes to show that symbiosis with other bacteria, and with the anaerobic gas bacilli in particular, is the keynote of the pathogenic action of this group in wounds. Further, this pathogenic action, if any, appears to be easily disturbed, and tends to be exerted only in the absence of a healthy resistance on the part of the tissues, or of those aids to the vital tissue resistance which are applied by efficient modern methods of surgical and antiseptic treatment. Anaerobic bacilli. The anaerobic bacilli have been long known to exist in the wounds of civil life and in the wounds of war, but until this war began they were, except in a very small minority of cases, regarded as harmless saprophytes, incapable of producing any serious disturbance in the living body. Malignant edema was a condition which had been met with in a few scattered cases, and it was very imperfectly understood, while any pathogenic action of B. aerogenes capsulatus in the healthy living tissue was a rarity which few had had the opportunity of observing. The great surprise came in 1914 when the awful results of spreading gas gangrene were seen on a large scale for the first time. Surgeons then gradually became aware that the conditions under which anaerobic gas-producing bacilli live and multiply were being regularly reproduced for the first time in the history of wounds, and that this new and terrible complication of wounds had to be investigated and mastered. Those various conditions found in wounds and wounded men which make the growth of the gas bacilli possible are described fully in the chapter on gas gangrene and need not be elaborated here. It is sufficient to say that within the past 3 years or so, the anaerobic gas-producing bacilli have assumed a position of importance as pathogenic agents which is altogether new in their history. It is therefore highly important for the surgeon to understand the nature and reactions of these organisms. The identity and reactions of the various anaerobes found in wounds have not yet been fully worked out, and there is still a considerable degree of confusion on the subject. This is partly due to the erroneous and contradictory statements which were made in the pre-war literature on the anaerobes, a literature which was based on an experience infinitesimally small compared with that which has recently been gained. It was of course known that these organisms were of fecal origin, and the reactions of a considerable number of them had been investigated. But the whole question was academic, and no practical classification was then possible. It has long been recognized, however, that 2 principal anaerobes were concerned in the occasional gangrenous inflammations which were seen in civil life. These were B. aerogenes capsulatus, Welch and Nuttall, and B. edematous maligni, Koch. An important biological distinction between these 2 organisms had, moreover, been noted, namely, that while the former was chiefly a carbohydrate fermenter and had little action on protein, the latter was, on the other hand, principally a protein digester, and had a very restricted range of action on carbohydrates. Other anaerobes had been described as gangrene-producing agents in a few scattered cases. The subject, however, was confused, and the mode of action and interrelation of the various organisms responsible for gangrene production was very imperfectly understood. With a much fuller knowledge of the reactions of the various anaerobes which have been isolated from wounds, it was possible for Henry and others in France to suggest a practical classification of these organisms. This classification divides them into 2 main groups: 1, the saccharolytic or sugar-splitting group, and 2, the proteolytic or protein-splitting group. the saccharolytic group. The members of this group vigorously ferment carbohydrates with production of acid and gas, and they have only a relatively slight action on protein. B. Perfringens. The chief member of the group is one which has been described under a variety of names, and which is now almost universally known by the general name of B. perfringens. It is the same organism as the B. aerogenus capsulatus of English textbooks, and has also been described under a variety of other names, namely B. welchii, B. perfringens of Wallonenzuber, and B. phlegmonis emphysematose of Frankel. Morphology. The organism is well known as a large, stout, gram-positive, non-motile, capsulated bacillus. In most media it does not form spores, at least in young cultures, but in media containing a relatively small amount of carbohydrate, for example blood serum, it appears to find the conditions unfavorable and spores are formed. In films made directly from wounds, the organism has the morphology described, occurs singly and in pairs, and does not show spores. In films made from cultures, however, the appearances vary according to the culture media employed and the age of the culture. Thus, in films made from a 48 hours anaerobic culture on glucose agar, some of the forms are short and broad, almost square in outline, but longer forms predominate. The bacilli occur singly and in pairs or in very short chains of 4 and 6 bacilli. They are capsulated and gram-positive, but gram-negative and in different forms occur, some of the latter giving the appearance of gram-positive granules on a gram-negative background. No spores are formed on this medium. Cultural characteristics. The organism is purely anaerobic. It grows readily upon the ordinary media with the evolution of gas, and especially so when the medium is enriched by the addition of 0.5% of a sugar, such as glucose. If a shake culture in glucose agar be made and incubated anaerobically, the gas production is often so violent as to expel the cotton wool plug and part of the medium from the tube. The colonies on agar or glucose agar, after some days, grow to a large size, 1 to 3 millimeters. They are convex, glistening, moist, semi-translucent, gelatinous-looking, and viscid. Some of them show a central bubble of gas. The margins become flattened and slightly wavy, showing a sort of ringed appearance. When they are picked off from the surface of the medium, they are observed to be adhesive and viscid, owing to the thickness of the capsule with which the individual bacilli are surrounded. Litmus milk. In this medium, a characteristic phenomenon is produced, which is so useful in determining the presence of B. perfringens in wounds that it may be called the perfringens reaction. It is very similar to the well-known reaction which used to be associated with B. enteriditis sporogenes Klein, an organism which is possibly a mixed culture, for the reaction is given by B. perfringens in pure culture, and no spores are formed by the latter organism in this medium. Further, B. perfringens can be recovered in pure culture by appropriate methods of subculture from the milk medium. An attempt has been made to represent the reaction in color. When material containing B. perfringens is inoculated into a freshly sterilized litmus milk tube, and sterile paraffin wax or Vaseline run on the top of the medium, the characteristic reaction is produced after from 12 to 24 hours incubation. Fermentation of the milk sugar takes place with the production of a large amount of acid and gas. The milk becomes coagulated, and the clot is torn and contorted by the pressure of the gas. The paraffin wax is forced up the tube until it partially ejects the cotton wool plug. This honeycombed clot, at first decolorized, becomes tinged pink as air gains access to it. After a day or two, it separates from the clear translucent acid fluid or whey. An odor of butyric acid is produced. The casein clot does not become digested unless one of the proteolytic group of organisms be also present. No spores are produced in this milk culture, and the culture dies out in some days owing to the excessive acidity. Films made from such a culture show the typical large capsulated single or paired bacilli in great abundance, and they are gram-positive. A reaction of this vigor and with these characteristics may be taken as absolutely diagnostic of B. perfringens, as no other known organism reproduces it. Henry. If we consider B. perfringens as a group of closely allied organisms, all of which produce the above described reaction, the reaction becomes definitive of the group. From the milk culture, it cannot be isolated directly in pure culture owing to the excessive acidity. If 1 or 2 subcultures be made, however, in an alkaline meat-glucose broth medium, a growth of the organism can be readily obtained by plating out from the subculture onto glucose agar. From such a plate, the typical gelatinous-looking colonies can be picked off and transferred to another medium until an absolutely pure culture is obtained. Meat medium. This is a very suitable culture medium for such a strongly fermentative organism as B. perfringens. A good plan is to place the meat in an alkaline broth with 0.5% glucose added. In such a medium, gas is formed vigorously, and the acid which is also produced turns the meat red, owing to hemolysis of the contained hemoglobin. Spores are produced after several days' incubation. 4 types of B. perfringens were differentiated by Simmons and later confirmed by Henry. These differ in their reactions to glycerin and inulin. Pathogenicity. B. perfringens is a saprophyte in nature, and it becomes pathogenic only under a very strictly limited set of conditions. When a pure culture is injected into animals, no effect is usually produced, and the bacilli are rapidly phagocyted unless the tissue at the site of injection be first damaged by some irritant. This can be done either by mechanical means or by the injection of a culture of an aerobe along with the anaerobe. Even such a harmless aerobe as B. prodigiosus may be sufficient for that purpose, and in this case, presumably the action of the aerobe is that of diverting the attention of the phagocytes to itself, and so allowing the anaerobe to establish itself. In a relatively small number of such cases, gaseous edema is thus produced, either localized to the site of injection or spreading throughout the body of the animal. Again, in artificial culture, B. perfringens has no power of growing in normal serum, but if the serum be trypsinized, it will grow vigorously. Similarly, it has the power of growing vigorously on serum removed from the body after death. This serves to explain why the organism so frequently invades the bloodstream after death, with production of gas throughout the organs. It appears also to be possible for B. perfringens to invade the bloodstream during life under certain conditions of diminution in bodily resistance. The relatively numerous recorded cases of metastatic gas gangrene are cases in point. Further, one remarkable case which we have observed seems to demonstrate that the presence of other organisms in the bloodstream may on rare occasions produce such a devitalization of the blood that it becomes possible for B. perfringens to enter the bloodstream. In this particular case, the active septicemia agent was Streptococcus pyogenes, and all the symptoms were those of a lasting streptococcal septicemia. The remarkable fact was that B. perfringens was present in the blood in association with the streptococcus for several weeks before death, and without producing any characteristic symptoms. It was isolated by blood culture on 2 occasions during life and at 2 weeks interval, and was also isolated after death. In this case, the antitryptic power of the serum seems to have been so lowered by the presence of the streptococcus in the bloodstream that it became possible for the anaerobe to invade the circulation, where, however, it remained in a latent or non-active form. Enough has been said here to indicate how feeble are the pathogenic powers of this bacillus in active living tissue. Exactly the same can be said of all the other gangrene-producing anaerobes. The reactions of other organisms of the saccharolytic group of anaerobes are also shown in the accompanying table. It is seen that they ferment carbohydrates vigorously but in varying degree. Their proteolytic action is relatively feeble and varies in type and degree also. Some types of B. perfringens produce small quantities of amino acids from peptone, while B. aerophetidus, on the other hand, is able to break down proteins as far as the aromatic stage, and there is consequently a disagreeable odor in cultures. Table showing fermentation reactions of saccharolytic group of anaerobes. Henry, British Medical Journal, June 16, 1917. B. welchii type 1, positive for dextrose, levulose, maltose, saccharose, and lactose. Negative for mannite, glycerin, inulin, salicin, and amygdalin, positive for glycogen. B. welchii type 2, positive for dextrose, levulose, maltose, saccharose, lactose, negative for mannite, glycerin, positive for inulin, negative for salicin and amygdalin, positive for glycogen. B. welchii type 3, positive for dextrose, levulose, maltose, saccharose, and lactose, negative for mannite, positive for glycerin, negative for inulin, salicin, and amygdalin, positive for glycogen. B. welchii type 4, positive for dextrose, levulose, maltose, saccharose, and lactose, negative for mannite, positive for glycerin and inulin, negative for salicin and amygdalin, positive for glycogen. B. tertius, positive for dextrose, levulose, maltose, saccharose, lactose, and mannite, negative for glycerin, inulin, positive for salicin, amygdalin, and glycogen. B. phallax, positive for dextrose, levulose, maltose, saccharose, negative for lactose, mannite, glycerin, positive for inulin, salicin, negative for amygdalin, positive for glycogen. B. aerophytidus, positive for dextrose, levulose, maltose, negative for saccharose, positive for lactose, negative for mannite, glycerin, inulin, positive for salicin, negative for amygdalin, positive for glycogen. B. edamatians, positive for dextrose, levulose, maltose, negative for saccharose, lactose, mannite, glycerin, inulin, salicin, amygdalin, and glycerin. These various anaerobes are of much less frequent occurrence in wounds than is B. perfringens, and their chief activity appears to be displayed as powerful but subsidiary fermentative agents. They supplement the action of B. perfringens in fermenting the glycogen of dead or devitalized muscle and in initiating the process of gas gangrene formation with the production of a gaseous edema. The pathology of gas gangrene and the action of anaerobes in wounds is discussed in some detail in another chapter. 2. The proteolytic group. These organisms digest protein vigorously and have but feeble action on carbohydrates. B. sporogenes. The type of organism and chief member of the group is B. sporogenes of Metchnikoff. This is now believed to be the same organism as B. edematous maligni of Koch, and the former name is today most generally adopted. Morphology. B. sporogenes is a fairly large bacillus, 2 to 10 microns, rather more slender than B. perfringens, motile, gram-negative, and contains a central oval spore of larger diameter than that of the bacillus, and giving a barrel shape to the organism as a whole. Cultural characteristics. It is a strict anaerobe. It grows readily on ordinary media with a limited amount of gas formation and a foul odor. Litmus milk is clotted and casein digested. Carbohydrate reactions. Acid and gas are produced in glucose, maltose, and levulose only. Its fermentative powers are slight. Protein reactions. Its most vigorous action is seen in media rich in protein. In a meat medium, it blackens the meat by putrefaction after several days. On Dorset's egg medium, perhaps its most characteristic reaction is produced, as pointed out by Dean and Moat. It produces complete digestion, liquefaction, and blackening of this medium within 3 or 4 days. An offensive odor is produced, somewhat suggestive of gorgonzola cheese. The digestion of protein is carried by this organism right to the ammonia stage. Most of the other organisms of the proteolytic group have a similar but less vigorous action on protein. B. histolyticus of Weinberg, however, does not carry the putrefactive process beyond the amino acid stage. Thus, in wounds, just as in the fecal contents of the colon, a considerable variety of fermentative and putrefactive organisms are provided by which dead and devitalized tissue or organic matter can be thoroughly and completely decomposed. The conditions under which this decomposition in wounds is brought about are dealt with elsewhere. Incidence of anaerobes in wounds. The most common anaerobe found in wounds is B. perfringens, and the next B. sporogenes. They are very frequently found to be present together. These organisms are found not only in gangrenous wounds, but also in a very large proportion of non-gangrenous wounds, where presumably they have been unable to exert their characteristic action. Thus Henry, in France, found in 100 open septic wounds of all grades of severity that B. perfringens was present in 2/3 of the cases and B. sporogenes in half of them. In the vast majority of these wounds the anaerobic infection was mixed, the commonest combination being that of B. perfringens and B. sporogenes. The authors obtained substantially similar results in a series of nearly 100 severe wounds investigated for anaerobes in Salonika. About 75% were found to contain B. perfringens and 25% B. sporogenes. Of these wounds, clinical evidence of gas gangrene was obtained in only 35%. It is evident, therefore, that gangrene-producing anaerobes are present at some stage in the vast majority of severe wounds. Fortunately, only in a relatively small proportion of them are they able to establish themselves and produce gas gangrene. B. Tetani of Nicolare. This most important organism belongs to the proteolytic group of anaerobes. It is found in wounds in a considerable proportion of cases in association with other anaerobes. It is not, however, a gas gangrene producer, and its specialized function in causing tetanus is well known. The consideration of the whole of this important subject is relegated to another chapter. End of Chapter 4, Part 3. Appendix to Chapter 4 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Appendix to Chapter 4. Notes on culture media employed in bacteriology of wounds. Liquid media. 1. Broth. Bouillon. Extract of beef, 2 grams. Peptone albumin, 10 grams. Sodium chloride, 5 grams. Distilled water, 1000 cc. Boil till dissolved, titrate, add sufficient 1 normal potassium hydroxide to give a +10 reaction, and filter when cold. Sterilize in the autoclave. Broth may also be made from fresh minced meat, 1 pound to the liter of distilled water in place of extract of beef. 2. Trypsin broth, Douglas. Take some fresh bullock's or horse's hearts, free from fat and vessels, mince the meat very finely, and weigh. To each 1/2 kilo add 1 liter of water, and make faintly alkaline to litmus with 20% potassium hydroxide solution. Heat this slowly to 75 to 80 degrees centigrade for 5 minutes. Cool to 37 degrees centigrade and add 1% of liquid trypsinic CO, alum and hanberries, or of liquid pancreatis, and keep it at 37 degrees centigrade for 2.5 to 3 hours. When trypsinizing is finished, test for peptone with cupric sulfate and potassium hydroxide as below, then render slightly acid with glacial acetic acid and bring slowly to the boil for 1/4 hour. Leave overnight in a cool place and siphon off the clear liquid in the morning. Make faintly alkaline to litmus and sterilize in the autoclave at 118 degrees centigrade for 1 hour on each of 2 days, if not to be used at once. Biuret reaction for peptone. Take 5 cc of broth, add 0.1 cc of 5% solution cupric sulfate, mix, and then add 5 cc 1 normal potassium hydroxide. A true pink color indicates that trypsinization is sufficient, a bluish-purple shade that it is incomplete. Liquor pancreatis. Mince a pancreas and weigh. Add an equal amount of absolute alcohol and shake. Add to this alcoholic suspension 3 times its weight of distilled water. Allow the mixture to stand for 3 days, shaking continuously. Filter, and add to the filtrate 1 cc strong HCl per liter. The acid preserves the strength of the solution for a very long time. 3. Pea extract trypsin broth, Gordon. Take 100 grams of pea flour, ordinary pear stuffs, and add 1 liter of distilled water with 100 grams of salt. Mix and steam for half an hour, stirring occasionally. Allow to settle and filter, then sterilize and label saline pea extract. Filtration is slow, and it is best to leave the extract filtering overnight. This pea flour extract should preferably be freshly made for each batch of agar. Add to trypsin broth 5% of the saline pea extract, and sterilize in autoclave at 118 degrees centigrade for 1 hour. Trypsin broth is a more delicate medium than plain broth, and is well adapted for the pathogenic streptococci and diphtheroids, and other organisms whose power of growth in artificial media is somewhat feeble. Pea extract trypsin broth is a still richer medium used for the same purpose. Both of these broths are suitable fluid medium for hemoculture. They also form the basis of trip agar. 4. Egg broth, Dean and Moat. The white and yolk of one egg are thoroughly beaten up by vigorous shaking in a stout glass bottle containing a liberal supply of glass beads. 300 cc of distilled water are then added and the mixture thoroughly shaken. The bottle containing the mixture is placed in a water bath, which is slowly brought to the boil. This temperature is maintained for half an hour. During the whole period of heating, the bottle is constantly and violently shaken. The result is a loose, porridge-like mass consisting of finely divided particles of egg suspended in fluid. The medium is distributed in quantities of 50 to 100 cc in wide-mouthed bottles, which are plugged and sterilized in the autoclave. This medium is useful for growing anaerobes in primary fluid culture. A fluid medium containing suspended particles of animal matter is more suitable for most anaerobes than a clear solution, probably because natural saprolytic conditions are thus more closely simulated. 5. Brain broth. Obtain digest of brain tissue as in brain agar below. Mix equal parts of digested brain pulp and of ordinary broth. Filter until filtrate shows only a slight turbidity. Filtration is a slow process. Sterilize in the autoclave at 118 degrees centigrade for 1 hour. This medium is an enriched broth suitable for the more delicately growing organisms. An unfiltered brain broth containing particles of digested brain tissue in fine suspension may be used for the same purposes as egg broth. 6. Glucose meat broth, Tarozzi. To 1% glucose broth, pieces of sterile fresh meat are added as follows. Kill a guinea pig or other small animal. Immerse the carcass in boiling Lysol for 5 minutes. Sear the skin with searing irons and make incisions through the seared areas with sterile instruments. Remove pieces of muscle aseptically and place in tubes or flasks of glucose broth. This is an excellent medium for anaerobes and suits bee tetani well. Growth of anaerobes occurs in this medium even when it is in contact with ordinary air. When the meat is sterilized by prolonged exposure to a temperature of 100 degrees centigrade or over, the medium loses this property. If sterilized meat is used, the culture must be put up under anaerobic conditions. The saccharolytic anaerobes redden the meat and the proteolytic blacken it. 7. Sugar media for fermentation tests. A. Peptone water. Peptone albumin 10 grams, sodium chloride 5 grams, distilled water 1000 cc. Boil until dissolved, filter, tube, and sterilize. Use 3 parts peptone water and 1 part glucose-free broth. Add 0.5% or 1% of the sugar to be tested and litmus solution as an indicator. Neutralize with potassium hydroxide solution. Insert a Durham's fermentation tube in each culture tube of the solution and sterilize by steaming for 1 hour on each of 3 successive days in the Koch sterilizer. Media containing sugars must not be sterilized at high temperatures, owing to the liability of the sugar to decompose. B. HUGHES serum water. Ox serum 1 part, distilled water 3 parts, litmus solution 1%. Collect the serum as aseptically as possible and add the sterile distilled water and litmus solution. Sterilize in a Koch sterilizer at 100 degrees centigrade on each of 3 successive days. C. Solid media. Sugars are sometimes added in the proportion of 0.5% or 1% to solid media, such as agar or Loeffler's blood serum medium. The characters of the colonies produced on the medium as well as the reaction to the sugar can thus be observed. An indicator such as litmus or neutral red, 1 in 10,000 solution, is added. For fermentation tests, the peptone water sugar media with Durham's fermentation tube are the most generally useful. In the case of anaerobes, growth is often more satisfactory in the serum water media, and in addition, the coagulation of the albumin in the medium by acid and the rupture of a clot by gas can be readily observed. This medium is also well adapted for fermentation tests with the more delicate anaerobes. 8. Litmus milk. Use fresh cow's milk. Boil and siphon off the milk from below the cream. Reject the cream. Add litmus solution and acid or alkali sufficient to give the medium a neutral tint. distribute in tubes, and sterilize as for sugar media. Litmus solution, Kubel-Tiemann. Solid commercial litmus is digested with pure spirit at 30 degrees centigrade till, on adding fresh alcohol, the latter becomes only of a light violet color. A saturated solution of the residue is then made in distilled water and filtered. When this is diluted with a little distilled water, it is of a violet color, which further dilution turns to a pure blue. To such a blue solution, very weak sulfuric acid, made by adding 10 drops of dilute sulfuric acid to 200 cc water, is added until the blue color changes to a wine red. Then the saturated solution of the dye is added till the blue color returns. Milk is a most useful medium for both aerobic and anaerobic cultures. The Streptococcus grows well in it, sometimes even when it fails to grow in primary culture on the solid media. It is a valuable fluid media for hemoculture. When covered with a layer of sterile paraffin, hard or soft, it forms a useful medium for anaerobes, particularly B. perfringens, the reaction of which in milk is characteristic, Perfringens reaction. Solid media. 1. Agar. Add 3% powdered agar-agar to plain broth. Autoclave, titrate, and filter as with trip agar below. 2. Trip agar, Gordon. This medium was described by Gordon as suitable for the growth of the meningococcus. Take a measured quantity of trypsin broth, add 3% of agar powder or 2% of agar fiber, and 0.125 gram of calcium chloride per liter. Autoclave at 118 degrees centigrade for 3/4 of an hour to dissolve the agar. Mix together in an iron saucepan, titrate with 1 normal potassium hydroxide while boiling, using phenolphthalein as the indicator, and add the necessary amount of 1 normal potassium hydroxide to give an absolutely neutral reaction, Gordon. We prefer a +10 reaction when using this medium for the cultivation of the bacteria of wounds. Cool to 60 degrees, add white of egg, 2 to a liter, beaten up with the crushed shells. Autoclave again at 118 degrees centigrade for 75 minutes, or in the steamer for 2 hours. Filter and add to the filtrate 5% of the sterile pea extract and sterilize in the ordinary way. Use trip agar with 2% sterile serum. 3. Brain agar. Mince some ox or horse brains and weigh. To each 7 pounds of brain pulp, add 10 liters of distilled water and 0.4% sodium carbonate. Digest as for trypsin broth media. Add 3% powdered agar, autoclave, and titrate, and add sufficient 1 normal potassium hydroxide to give a +10 reaction to phenolphthalein. Tube and sterilize in the autoclave at 118 degrees centigrade for 1 hour. 4. Blood agar. It is best to secure blood from a large animal, for example, a horse. A Winchester bottle is fitted with a double-bored rubber stopper through which passes a long and short glass tube. The short tube is connected by rubber tubing to a siphon filter containing cotton wool. The long glass tube is connected by rubber tubing to a trocar and cannula by means of an adapter. The trocar and cannula is wrapped in cotton wool. The bottle contains 11 cc of 10% potassium oxalate for each liter of blood to be drawn off. The whole apparatus is sterilized in the autoclave, and thereafter 1 or 2 liters of blood drawn off aseptically into the bottle. The cannula and adapter are now removed from the rubber tubing and replaced by a tapering glass nozzle, which passes through a bored stopper. The stopper fits into a tube containing carbolic acid solution 1 in 20, into which the glass nozzle slips. Any desired amount of blood may be siphoned off from this apparatus into agar which has been melted and cooled to a temperature of about 50 degrees centigrade. Siphonage is easily brought about by attaching a hand bulb pump to the tube. When plain agar is used, 1 part of blood should be added to 2 parts of agar. When trip agar or brain agar is used, a much smaller amount of blood suffices. This is a most convenient and effective apparatus whereby blood may be collected and kept sterile in quantity without requiring the addition of preservatives such as chloroform. Small quantities of sterile blood may be secured by sterilizing the skin of the finger with spirit, soap, ether, and iodine, pricking the finger, and taking up the blood in a sterile capillary pipette. A few drops of such blood added to a tube of melted trip agar or brain agar provides a most rich and delicate culture medium. Agar is the most common solid medium used in ordinary work. It is not sufficiently rich, however, to grow the more delicate organisms found in wounds, for example, pathogenic streptococci, pneumococci, etc. For these, and also for the purpose of securing luxuriant growths of all the organisms for the preparation of vaccines, trip agar and brain agar are used. Both are good media. Trip agar has the advantage of being nearly transparent and of permitting greater differentiation of the characters of the colonies of various organisms. It is therefore useful for primary cultures from material suspected to contain more than one organism. It has the disadvantage of requiring the addition of sterile serum to secure the best results. Burroughs and Wellcome's normal horse serum No. 3 is quite good for this purpose and is usually readily obtained. Brain agar has the great advantage, in dusty climates and laboratories, of being sterilizable in the autoclave without impairment of properties. It has the disadvantage of being opaque and of giving poor differentiation of character of colonies. It is therefore particularly useful for subcultures of known organisms, although it may be employed also for general use. Blood agar media are desirable for the cultivation of the hemophilic bacteria, for example, B. influenzae. 5. Gelatin. Add 10% or 15% gelatin to plain broth. Melt by bringing slowly to the boil, titrate, filter, tube, and sterilize in the Koch sterilizer at 100 degrees centigrade on each of 3 successive days. In hot climates, it is advisable to use a mixture of agar and gelatin, 0.75% powdered agar and gelatin. This mixture melts at about 28 degrees. The chief use of gelatin media now is to test for the liquefaction of gelatin given by certain organisms. It is also used for special reactions, for example, bee tetani. 6. Loeffler's blood serum medium. 3 parts of calf's or lamb's blood serum are mixed with 1 part ordinary neutral peptone bouillon made from veal, with 1% of glucose added to it. The medium can be made from ox or sheep or horse serum and beef bouillon without its qualities being markedly impaired. The medium is distributed in quantities of 5 to 10 cc in test tubes, sloped in a serum inspissator at a temperature of 80 degrees centigrade for 4 hours on each of 2 successive days. This both coagulates and sterilizes the medium. This is a rich and conveniently prepared medium for organisms of feeble growth. Its disadvantages are that it is opaque and gives little differentiation of character of colonies. Minute colonies are not easily recognized on this medium. It is quite a suitable medium for Streptococcus pyogenes and diphtheroid bacilli, but is not so generally useful as trip agar or brain agar. 7. Dorset's egg medium. The contents of several eggs are well beaten, and 1/3 of the volume of normal saline is added and thoroughly mixed, the mixture being passed through muslin to remove air bills. The fluid is then filled into tubes, and these are heated for 4 hours in the slope position at 70 degrees centigrade. Before the inoculation of a tube, 2 drops of sterilized water are placed upon the surface. This is an excellent medium, suitable for all the organisms for which a rich protein medium is required. It has, however, the same disadvantages as Loeffler's blood serum medium. It is very well adapted for the cultivation of anaerobes, especially bee sporogenes, whose reaction on this medium is characteristic, namely digestion, liquefaction, and blackening of the entire medium within 3 or 4 days. Notes on some simple anaerobic cultural methods. In bacteriological laboratories in the field, it is essential to work with the minimum equipment consistent with efficiency, and hence cultural methods requiring simple or readily improvised apparatus are generally to be preferred. The following simple methods have given good results. 1. Paraffin seal for liquid media. Some soft paraffin is melted and filled into tubes, which are then plugged and sterilized in the autoclave. After inoculation of a liquid medium, for example milk or broth, the sterile paraffin is run on the top of the medium to a depth of 1 inch, and the tube plugged and incubated. If more stringent anaerobic conditions are required, culture media may be first heated to 100 degrees centigrade for half an hour to expel oxygen, and a liquid paraffin seal run on the top before cooling. Inoculation of the medium is performed through the soft paraffin by means of a sterile capillary pipette. The method is at best partially anaerobic. Its chief use is for anaerobic milk cultures, for which it is quite well adapted. The amount of gas formed from the medium can be roughly estimated by the amount of displacement of the paraffin seal up the tube. 2. Use of pyrogallate of potassium. Buchner's anaerobic tube may be employed for maintaining or for keeping free from oxygen a sloped culture tube which is being used for separating anaerobes from mixtures. When several sloped cultures are being incubated anaerobically, a wide-mouthed, well-stoppered bottle or jar may be used. Dry pyrogallic acid is placed in the jar and the culture tubes inserted. Potassium hydrate solution, 109 grams solid caustic potash to 145 cc's of water, is poured into the jar and its mouth quickly stoppered and made airtight by sealing the stopper with paraffin. The pyrogallate of potash solution so formed absorbs the oxygen in the air, and thus the cultures are kept in oxygen-free surroundings. A pyrogallol saturated plug may be used in a long culture tube for keeping a sloped culture partially anaerobic. The ordinary cotton wool plug is pushed down into the tube after inoculation of the medium. A little dry pyrogallic acid is placed on the top of the plug, a few drops of potassium hydrate solution are poured on, and a second plug is inserted into the mouth of the tube. This is pushed home and melted paraffin run on the top to prevent access of outside air. These methods are often not strictly anaerobic, but are always useful for maintaining surface growths of anaerobes in subculture. 3. Hydrogen atmosphere. A vacuum is first produced in the anaerobic jar. A wide-mouthed bottle with a tight-fitting rubber stopper, carrying a bent glass tube with stopcock, makes quite a good anaerobic chamber. Bullock's apparatus, bell jar on glass plate with double neck, board stoppers, and stopcocks, is somewhat large and requires considerable power to exhaust it of air. Any available pump may be used. If a water tap with good pressure is available, a Geischer water vacuum pump is very effective. A motor bicycle pump with leather washer reversed answers the purpose very well. Dry pyrogallic acid powder is first placed at the bottom of the jar. The jar is then exhausted of air as far as possible, and hydrogen gas is run in from a Kipps apparatus or Wolff's bottle for 15 to 20 minutes. Lastly, potassium hydrate solution is run in. The pyrogallate of potash so formed absorbs any oxygen remaining in the jar and turns black. When the air of the jar has previously been almost exhausted, as may occur when a Geischer pump is used, the pyrogallate solution may be barely darkened. This method is somewhat laborious, but provided an efficient pump be available, it gives an effective anaerobic chamber. It is recommended for the tube cultures. Anaerobic plates are best incubated by Henry's method, below. 4. Use of palladium chloride, Macintosh canister. This is a recent and excellent device for securing absolute anaerobiosis. It depends on the fact that when hydrogen gas comes in contact with palladium chloride, the oxygen of the air is immediately and completely fixed by the latter. The canister consists of a circular metal can with a flanged lid, which can be luted to the jar rim with plasticine, making an airtight chamber. From the center of the upper surface of the lid projects a metal nozzle with stopcock. From the center of the lower surface there hangs suspended into the interior of the jar a flat, square wire gauze containing asbestos wool saturated with palladium chloride. This latter piece of apparatus is so placed immediately beneath the nozzle of the jar that when any gas, such as hydrogen, is allowed to pass into the jar through the nozzle, the gas must come in contact with the wool contained in the wire gauze frame. When the canister is to be used, the culture tubes are placed inside the lid, firmly luted down. The air in the jar is partially exhausted by means of any convenient pump, and hydrogen gas is then passed into the jar. When the hydrogen comes in contact with the palladium chloride, the asbestos wool containing the latter glows with the intense oxidation which takes place, and all the remaining oxygen in the jar is thus fixed. Perfect anaerobic conditions can be secured by this device. The disadvantages of the method are that neither the reaction on which depends the production of anaerobic conditions nor the growth of the cultures can be observed, and there is nothing to indicate how the cultures progress short of opening the can. To obviate errors, it is well to test the palladium with hydrogen in the open from time to time. Further, for plate cultures in particular, the above disadvantages make the method in general inferior to that of Henry below. 5. Henry's method of anaerobic plate culture. This is a modification of the capsule devised by MacLeod for the incubation of each anaerobic culture plate separately. The principle is generally preferable to that of incubating plates in an anaerobic jar, since it is equally efficient. It permits of the colonies being readily observed during incubation. In any military hospital or medical store, there are found drugs in powder, for example, boric acid, contained in cardboard cylinders which are provided with metal tops and bottoms. The metal top consists of a circular disc or lid which, when pushed down, fits tightly into a supporting flange, the principle being one which is used extensively in trade for tins containing paints, enamels, etc. The combination of supporting flange and lid presents a circular groove or trench on both its upper and lower aspects, and so forms a suitable complying adjustment for the two halves of a petri dish of suitable size. A 3.5-inch petri dish exactly fits into the grooves in the metal top of a boric acid cylinder. Method of use. 1. The grooves on both the upper and lower surfaces of the flange and lid are filled with plasticine. 1 or 2 teaspoonfuls of pyrogallic acid in powder are placed in the lower half, A, of the petri dish, and the metal plate is pressed firmly down onto it so that the edge of the dish is securely embedded in the lower plasticine-containing trench. Extra plasticine is added all round up to the level of the dotted line shown in the diagram so as to make an absolutely airtight lute. The other half, B, of the petri dish is sterilized in a larger petri plate in the hot air oven, filled up with a suitable amount of agar or agar gelatin, and when cooled, is inoculated. 3. Saturated caustic soda solution, 10 cc, is poured through the hole C into the plate A, and then as quickly as possible the plate B in an inverted position is pressed firmly down into the upper trench and luted down with extra plasticine all round up to the dotted line shown in the figure. Organisms thus grow on agar surface in an airtight box from which most of the available oxygen is absorbed by the sodium pyrogallate. The smearing of the agar surface with alkaline egg medium at the time of incubation greatly facilitates growth. Where difficulty is experienced in getting growth by this method, the organisms may be coaxed into giving good surface colonies by a preliminary passage through several subcultures and alkaline meat under paraffin. We have found this method very efficient and very convenient. End of Chapter 4, Appendix.
Chapter 5 of War Surgery from Firing Line to Base by Basil HUGHES. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Reading by Matt Perard. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 5. Wound Infection. For wounds of war, as for wounds of civil life, there are both predisposing and exciting causes of infection. Predisposing causes. To realize fully the predisposing causes of wound infection, it is necessary to have lived amongst and under the same conditions as the men in the trenches. It is a unique existence, and the work of the regimental medical officer is perhaps as interesting as any. He has ever to remember that 1 ounce of prevention is better than many pounds of cure, and it is up to him to keep the men of his battalion medically fit, as far as lies in his power, under all conditions. What then are the predisposing causes of wound infection? They are the following. 1. Fatigue. 2. The conditions under which the soldier lives. 3. Climate. 4. The clothes the soldier is wearing. 5. Severe primary hemorrhage. 6. Whether or not active fighting is in progress. 7. Constitutional or other diseases. Each of the above-named causes calls for separate comment. Fatigue. Earlier in this war, when the manpower of the British Army was so different from what obtains today, the daily routine of the individual fighting man called for physical fitness and endurance of the highest quality. During the early months, when the enemy held superiority not only in numbers, but also in guns and ammunition, life as it then existed in the trenches often seemed well nigh unbearable. Each day saw fresh destructions wrought on the habitat of the soldier by the regular, methodical, and thorough work of the enemy's artillery. Necessary repairs had to be carried out by night, usually under heavy machine gun fire, as any breaches in the parapet were well marked down and sprayed intermittently with machine guns until dawn. Trenches, such as they were, contained a depth of liquid mud which would reach well to the knees of the average man, and in some places halfway up the thighs. It was quite common for a soldier wading through this mud to leave his gumboot behind, it being impossible for him to drag his leg out by any other means. The mud, though constantly cleared out, would reaccumulate in a very short time. Trench grids constantly needed removal in order to get rid of the fluid debris from beneath them. Drainage trenches were under repair by day and night, owing to the destructive effect on them of enemy fire, and nightly repairs on communication trenches were necessary for the same reason. Owing to the frequently inclement state of the weather, dugouts which had not been blown in would fall in, whilst those which still stood leaked so badly that they were usually inches deep in water and uninhabitable. Battalions or companies in the support line were constantly called upon to supply fatigue parties for ration carrying, or for carrying RE stores to the front line, whilst battalions which had left the trenches for a week's rest were often called upon to supply working parties at night for the repair of communication trenches or other necessary fatigues. The nights were often wet, and the men would return in the small hours of the morning soaked through. In addition to this, the men had always to be ready for an enemy attack or raid. Though such conditions were borne cheerfully by officers and men alike, yet it was not surprising to find that fatigue was an important factor to be dealt with. The following incidents impressed this point very strongly on the authors. They refer to the very rapid onset of rigor mortis in the case of men killed under these conditions. On one occasion, after an enemy gas attack, while proceeding along a certain road which was the shortest route after dark to the front line, a soldier was seen in the kneeling posture, apparently taking aim with his rifle. As it was dark, he was told to get up, but as he failed to obey this order, an NCO went up to him and pushed his shoulder. He fell over and proved to be dead. He was quite stiff, rigor mortis being well established. This man could have been in this place a short time only, as a platoon had passed the spot just half an hour previously. On the same night, another soldier was seen standing propped up against the side of a communication trench which ran parallel to the same road. He was spoken to, but did not answer. On going up to him, it was found that he was dead, and rigor mortis was well established. This man also could have been in this particular place for only a short time, or he would have been seen by a party of RAMC men who had an advanced dressing station but a few yards away, yet had not noticed him for 3/4 of an hour previously. Still one more remarkable incident. After the Battle of a number of wounded men had taken cover in a shell hole in no man's land. They had their first field dressing applied, and were to have been brought in on the same evening after dark. The Germans counter-attacked that afternoon and retook their lost trenches, leaving no man's land as it existed before the attack commenced. That night, owing to a heavy fusillade of rifle and machine gun fire, it was impossible, despite several attempts, to recover all the wounded. At dawn, this particular party of wounded men could still be seen in the shell hole alive. After dark, a stretcher party went out to recover them, but found they were dead, although before darkness set in some were still sitting erect and were undoubtedly alive. Their bodies had to be left in order to rescue men who were still living. So lifelike was the whole scene in this shell hole, even on the following dawn, that it was called the tea party. One man was still holding his water bottle, and appeared to be in the act of drinking. Lastly, to emphasize this point, it was most noticeable how rapidly rigor mortis set in the case of men killed outright in the trenches under the then existing conditions. There is no doubt that fatigue is a strong predisposing cause of trench ailments, e.g., trench pyrexias, myalgias, trench feet, and the like, which, by lowering the general vitality, are predisposing causes of wound infection. During the winter months, the condition of the trenches in certain parts of the line hardly allowed of men standing upright. Consequently, most of the day they had to crouch wherever they could get sufficient cover. Sleep under these conditions was impossible, as was rest of any kind, and with the necessary night work it is easy to understand the degree of fatigue that was bound to follow. Convincing proof was that the percentage of men parading sick in the trenches varied inversely as the strength of the unit. The work of a battalion, i.e., 1,000 men, must be carried on by whatever number remain. Consequently, the fewer the numbers, the greater the work per individual to be done, and therefore the greater the fatigue. Fatigue, as we at present know it, is due to an overcharging of the tissues with waste products of metabolism. The tissues so charged are temporarily toxemic, and their resistance to infection is thereby lowered. The toxin is an acid substance related to lactic acid, and has received the name of sarcolactic acid. It is probable, however, that there are in addition other toxic bodies present. Experimentally, these toxic bodies can be washed away with normal saline solution, for if the muscle nerve preparation of a frog be stimulated until no further contractions are obtainable, the muscle can again be made to respond by washing it with normal saline solution at a temperature of 37 degrees centigrade. For further information on the subject, the reader is referred to an interesting and instructive little work on fatigue, written by Professor Massa. The conditions under which the soldier lives. But few people outside those who have had actual experience realize the real conditions under which the soldier lives. The existence of the soldier resolves itself into periods of time spent in trenches and periods of time in rest billets. The trenches. The condition of the trenches is variable, and depends upon what part of the line a unit may be holding, and the time of the year. Certain parts of the line are notoriously bad, whilst others are good, and again, artillery action is far more active in certain parts than in others. With a continual breakage of the parapet, demolition of the dugouts, and trenches deep in mud, conditions are trying. It is here, however, that another more gruesome factor has to be reckoned with, namely, decomposing humanity. It was not at all uncommon to see the feet, head, or some other part of a corpse projecting out of the parados, or even to discover pieces of humanity in the mud of the trench bottom. In some places where a fatigue party would start to open up a new communication trench, the task had to be abandoned, owing to buried corpses, which rendered the proposed work impossible. In the name of the line, at a time when it was difficult to get water, sumps had to be sunk. It was noticed that the sumps were filling at the expense of a marshy piece of ground not far distant. The water later, despite the fact that it was boiled, began to taste, and it was then noticed that at the bottom of the marshes were numerous unburied bodies of men who had fallen 2 or 3 months previously. Again, the bodies of men who had been buried out of necessity near the line were continually being unearthed by the enemy's fire. Hence the mud both of the trenches and the ground about them was in one constant state of pollution. Trench latrines were frequently being hit, and by this means fecal material was added to the already polluted trench mud. Added to all this must be included weather conditions. During the winter months there was constant rain and inclement weather, and men were wet through. The advent of the long gum boots certainly, to some extent, saved the feet and legs, but they were not always efficient, as the mud would often get in over the tops, especially if the men slipped off the duckboards. Despite this difficult existence, it was a noteworthy fact that, whatever the conditions, the soldier most unfailingly received his rations, his letters from home, and his tot of rum at stand to in the morning. The rations were exceptional, and it was pleasing when doing an early round of the battered trenches to smell bacon cooking. Fresh meat, jam, and cigarettes were always forthcoming daily, along with other comforts, and these never failed despite the formidable barrages put up by the enemy's artillery. On the whole, therefore, life in the trenches was greatly compensated for by the way in which the necessary needs of the soldier were attended to. Rest in billets and reserve line. Periods of rest in the reserve line were usually spent in billets in small deserted villages behind the firing line. These villages were daily under shell fire, but the men who were not detailed for fatigues were able to sleep lying down at night, and the conditions were generally better. In brief, these billets were a happy contrast to the trenches. The trench rat. Rats of a large, coarse description are a constant pest in trenches, no man's land, and reserve billets. On the Somme they amounted to almost a plague. It was not uncommon to find one or two beneath the blanket when turning in for a sleep, and frequently they would run over men who were asleep. They fed on decomposing human remains, and on more than one occasion they have attacked a wounded man, especially if lying out, but the authors cannot record a case in which they have attacked a healthy man when asleep. One instance may be quoted of a man who was brought to the regimental aid post with a large thigh wound complicated by a fracture of the femur. While attending to him, an urgent message came for the medical officer to go to the front line. On returning to the regimental aid post to finish dressing the thigh wound, a large rat was found making a meal of the exposed tissues, and so loath was it to leave its prey that an orderly was able to kill it with a stick. These rats would often become infected with disease, for on more than one occasion collections of their dead bodies were found at a time when no rat virus was in use. It is quite possible that they were poisoned by the foul food on which they preyed. Constipation in trenches. Soldiers in trenches are notoriously constipated. This is probably a habit, because so many men have been hit while using the latrine. Many prefer to wait until they come out into rest billets, and then parade at the sick tent for an aperient. Psychical phenomena. Life in trenches is associated, in a fair percentage of cases, with mental strain. Psychical phenomena are always more prominent after a successful bombardment by the enemy from which casualties have resulted. It is not the actual bombardment that produces the effect so much as the event of a soldier seeing his next door neighbor mutilated. Some of our bravest men have shown these symptoms, and have required 4 or 5 weeks' rest to recover, while a small percentage never seem to recover at all. Climate. Where hostilities are in progress, in both Eastern and Western theaters, climate enters as a predisposing cause of wound infection. In the Western theater, rain and inclement weather have already been referred to, but in the Eastern theater different conditions obtain. Here there are tropical diseases in the form of malaria, dysentery, both amoebic and bacillary, sandfly fever, and the like, to deal with. besides the tropical heat. Men coming to these parts for the first time and under active service conditions tolerate these diseases badly until acclimatized, and there is not the slightest doubt that their intervention produces a most deleterious effect on wounds. The influence of these diseases on wounds is dealt with in Chapter 11 by Lieutenant Colonel L. F. Smith, C.M.G., R.A.M.C. The conditions of the clothes the soldier is wearing. The khaki outfit of the soldier is too well known to need description here. During a period of rest out of trenches, every provision is made for baths and a complete change of underclothing. This all takes place at the divisional baths, where a large stock of clean underclothing is kept. Each soldier, before entering the bath, strips and dumps his dirty underclothing. His trousers and tunic are taken and put through a thresh disinfector while he bathes. On entering the baths, he draws clean underclothing and socks. At the end of the day, all dirty underclothing is put through the thresh, sent to a laundry and washed, and again returned to the divisional baths. Blankets are similarly sterilized. During a week's rest, each soldier has probably 2 hot baths, with complete change of underclothing, and each time his outer clothes are sterilized. Body vermin. Despite this, within 24 hours of return to trenches, these men are again infested with body vermin, although greasing the seams of the trousers with vermicelli or Oxford grease, and powdering the shirt with NCI or Oxford powder, have been most conscientiously carried out under the supervision of the medical officer and the company officers. Besides carrying disease, these pests, by their irritable action on the skin, prevent sleep and cause the men to scratch until septic abrasions of the skin result, and so are a potent predisposing cause of wound infection. Again, in trenches, clean clothes become rapidly soiled. The act of walking up a communication trench or a short distance along the front line trench is quite sufficient to cake the outer clothes with mud, which, it should be remembered, is heavily polluted with decomposing humanity. In France and Flanders, where the farmers and peasants work the ground to the utmost extent, the soil is highly manured, not only with the excreta of cattle, but also with human excreta. The soldier's underclothing, at first clean, rapidly becomes soiled with fecal material. It is often a difficult task to impress on him the importance of wearing underpants. In the case of those men who do not wear them and escape observation, the khaki trousers become very fouled, and are consequently an important predisposing cause of wound infection, as it should always be borne in mind that a piece of clothing is invariably carried into the wound by the missile. It has been suggested that all men before going into trenches or into action should have their clothes steeped in some antiseptic. To anybody who has had front line experience, it is obvious that this would be quite inadequate to sterilize the depth of mud and infective material that in a very few minutes collects in considerable thickness on the clothes, to say nothing of the effect that such antiseptics would have upon the skin. Both for friend and foe alike, the very important problem of clothes during the present war, as a very serious predisposing cause of wound infection, is still unsolved. The skin. Closely allied to the problem of clothes is the condition of the skin. When once wet through with rain, the skin contains the same infection as the clothes, even after drying, and such infection remains in the dried sweat and hair. The man scratches himself owing to the presence of body vermin, and boils often result. Boils had of necessity to be treated in the line, unless a condition of cellulitis was established. Such a skin condition is a strong predisposing cause of wound infection. Again, other conditions such as scabies, entailing as it does scratching and abrasions of skin, predispose to wound infection. The hair. Another important item is the hair. Whenever a battalion is out at rest, every man should have his hair cut as short as possible. Long hair is a potent predisposing cause of infection in wounds of the head, as a portion of the hair is invariably carried in by the missile. The boots and feet. While out at rest, a foot inspection by the medical officer is most essential. Toenails should be cut short before the man goes to the divisional baths. Corns and callosities should be attended to by the battalion chiropodist. Deformities of the feet should be compensated by any simple device for altering the boots, and this can always be done by the battalion cobbler. Boots should be softened with neat's foot oil or dubbin, especially if sores on the heel be present. These latter remarks may seem trivial and unimportant, but it must be remembered that a deformity of the foot, which might easily be remedied by some simple alteration of the boot, or even a sore heel, may rapidly induce fatigue in men on the march, from rest billets to the trenches. Consequently, these men enter the trenches at a disadvantage. It is careful attention to such small details as these that makes all the difference between keeping a man fit or unfit to carry on, and giving him a better chance to resist infection when the time comes. Severe primary hemorrhage and shock. When severe primary hemorrhage occurs, the wounded man loses blood at a time when he can least afford it. His body is fatigued, and as a rule he is already suffering severely from shock. With hemorrhage superadded on shock, he has to commence the battle against infection in a heavily handicapped condition. It is too well known to require comment here that the main resisting force to infection lies in the blood. Hence, a severe primary hemorrhage is a serious early blow to the body defenses. Every ounce of blood saved in the first few minutes following a wound is of paramount importance to the subsequent welfare of the wounded man, and this point should be most strongly impressed upon the mind of every stretcher bearer. He should know the points of pressure for arrest of hemorrhage from the large arteries, for a knowledge of these has, time after time, been the saving of many lives. Whenever the hemorrhage is concealed, which may happen in penetrating wounds of the abdomen or thorax, but little can be done towards procuring hemostasis by pressure or other mechanical means. These latter cases are too often fatal, and if they do not die in the line, they rarely get beyond a casualty clearing station. Shock in the recently wounded man results from one or both of the following: 1. Hemorrhage. 2. Reflex nervous action set up by injurious afferent impulses from the damaged tissue. The central feature of shock is due to a shortage of blood in the peripheral circulation, a condition which is produced by either of the above-mentioned causes. However produced, the symptoms are the same, but there is this important difference, that in the first case, blood is irretrievably lost for some time to the individual, whereas, in the second case, the blood is still present in the body, but is stagnating in the distended veins of the abdomen and muscles. If these two conditions coexist to any considerable degree, the case is invariably fatal, and death takes place on the battlefield. A combination of both of these factors constitutes the condition of intensified shock. Another important difference between the above-mentioned two types of shock is that in the second case, patients rally from the condition and respond well to treatment. But if hemorrhage, whether visible or concealed, be the cause, response to treatment is exceedingly slow and infection is favored. It has been most striking how prolonged is the convalescence in the case of large infected wounds, when severe hemorrhage has occurred in the line. In these cases, we have to reckon with the fact that there is the element of superadded reflex shock from the wound itself. This is especially so in the case of the extremities, where amputation has of necessity been performed owing to hopeless mutilation of the limb. We have, therefore, in these cases, varying degrees of intensified shock. Another noteworthy fact is the difficulty experienced in sterilizing the wound of a patient who has suffered a severe primary hemorrhage. Open amputations which have followed upon a severe primary hemorrhage require the most active antiseptic treatment to combat infection, for if sepsis be allowed to exist in such amputation stumps, although the extent of such sepsis be small, secondary hemorrhage is almost certain to follow. Whether or not an action is in progress. During the period that is known as the quiet time in the trenches, a wounded man can receive more individual attention from the regimental medical officer than he could were he wounded during an attack. It is possible under the former conditions for him to have the wound more thoroughly attended to at the regimental aid post almost directly after he is wounded. He can be given hot drinks and a suitable dose of morphine, if necessary. He can be warmed and kept warm with plenty of blankets, and taken down by easy stages to the advanced dressing station or the field ambulance, where he again receives any further necessary treatment. Hemorrhage can be arrested at an early stage and the wound dressed with antiseptics. In short, shock and collapse can be greatly lessened just at a time when it is most urgent to deal with them. The journey to the casualty clearing station is not so hurried, and detention there can, if necessary, be longer. There is also no lying out after being wounded to be reckoned with. Another very important point is that the regimental medical officer can furnish a few notes on the case which are invaluable to the surgeon at the casualty clearing station. For instance, in the case of paraplegia due to a wound of the spine, if the regimental medical officer can definitely state that there was an interval, however brief, after the wound was received, in which the wounded man could move his limbs, or in which sensation was present in an area of skin below the lesion, this is an invaluable piece of information to the surgeon who finds a complete paraplegia by the time the patient reaches the casualty clearing station. The same remarks also apply to head wounds, for it is important to know whether or not an interval of consciousness existed for any period, however short, after the infliction of the wound, and, if possible, it is highly important to know the early state of the pulse, respiration, and pupils. As a rule, this is quite possible during quiet times in the trenches. When, however, an attack or an advance is in progress, a different state of affairs exists. A wounded man may have to lie some length of time, often hours, exposed to rain, cold, or heat, before he can be recovered. During this period he may be bleeding and suffering from severe shock and pain. He may not be able to get drink of any kind or food, and such has been the case for periods varying from a few hours to days. He may perchance crawl into a shell hole or a disused trench, for men with the most appalling wounds have been known to do this, and in this way many escape the notice of the stretcher parties or salvage corps. There are instances known to the authors where wounded men in such a plight have been forced to eat grass, and have even drunk their own urine. One particular instance worthy of note is that of a man in regiment, who was badly wounded in the chest and lay out for 8 days after the battle of . After the 3rd day he managed to crawl amongst the dead who were lying out near by him, and to procure some of the rations they had carried with them. He had collected 1 or 2 water bottles containing a little water, but when this was finished he had to resort to drinking his own urine. Eventually he was able to crawl back by stages and enter our trenches after dark. Such conditions as these must strongly aid infection in the wounds of those few who survive them. Again, when the number of wounded is large, the same initial individual attention cannot be given by the regimental medical officer. Men with wounds of the upper extremities, face, head, and chest who are not stunned can usually walk to the advanced dressing station, and on more than one occasion a man with his arm hanging on by only a few tendons has been seen walking down unaided to the advanced dressing station. Wounds of the lower extremities involving fracture and abdominal injuries must be got down to the advanced dressing station and evacuated thence with the least possible delay, for it must be remembered that during an advance the wounded are an encumbrance, and their rapid evacuation from the scene of battle is highly desirable. The journey to the advanced dressing station is not always a smooth one. It may be that this journey lies along a sinuous communication trench of considerable length, up which, on the one hand, are arriving reinforcements, and down which, on the other hand, are traveling the wounded who are able to walk. Under these conditions of congested traffic, it is often necessary to carry the wounded men who cannot walk over the open under heavy shell fire, and during this process the wounded man has often been hit again, to say nothing of the stretcher bearers. It can be well realized that this part of the journey is a rough one, both for the wounded man and for those responsible for his transit. Consequently, if the wound be severe and the limb imperfectly immobilized, further damage is suffered by the soft parts, shock is increased, and infection is thereby favored. On reaching the advanced dressing station, but little can be done for the more seriously wounded, owing to the number of other wounded requiring attention. They are put into motor ambulances, the more seriously wounded first, and are taken on at all speed to the casualty clearing station. This entails a journey of about 12 miles, often over rough roads, which involves more shaking. Hence, by the time the clearing station is reached, the shock in the case of the badly wounded is intense, and the consequent degree of infection is very advanced. Constitutional and other diseases. During a war of such magnitude as the present, many men were past fit for active service who would never have been accepted in the regular service in pre-war times. The passing of recruits has necessarily been a somewhat hurried affair, and many unfit men have slipped past the examining medical officer. Thus it has been a common experience to send men out of the line suffering from such diseases as tabes dorsalis, chronic interstitial nephritis, pulmonary tuberculosis, and other diseases, all of which must act as strong predisposing causes to wound infection. Chronic valvular disease of the heart and arteriosclerosis of varying degrees are not at all uncommon in men fighting in the line. Another disease common in the army is chronic ultorrhea. Although this may not incapacitate a man as a fighter, yet it is an ever-living danger to a man wounded in the head anywhere in the neighborhood of the ear. Chronic inflammatory diseases of the respiratory annexes are for the same reason a fruitful source of infection of wounds in their neighborhood, especially if the anterior basis cranii be involved. One of the commonest diseases of all in the present day soldier is dental caries. Our remarks on this subject are set down in the succeeding chapter. We need only state here that this is a potent cause of indigestion and malnutrition. All these conditions are predisposing causes to infection, and all require prompt attention and treatment in order to give a wounded man his best and quickest chance of recovery. There is one more point worthy of mention, though not strictly coming under this heading, and that is the case of the airman. Though it is not fully recognized, the life of the flying man in the present war is one which favors infection. One of the authors has treated many of these men for wounds, and has been struck by the fact that such wounds are remarkably prone to infection. A man flying in a rarefied atmosphere cannot rely on the normal atmospheric pressure directly after he is wounded. Hence, Wounds received whilst flying at a high altitude bleed far more freely than wounds received on terra firma. Again, if the aeronaut can, notwithstanding his wound and loss of blood, land his machine safely, he suddenly descends from a rarefied atmosphere to a normal atmospheric pressure. This latter fact, coupled with the loss of blood, produces shock of a very intense degree, and an early operation performed on these men may often prove fatal. Under such conditions these wounds are very apt to become grossly infected. It should especially be noted that this is the one branch of the service above all where it would be worth while to have a bath and put on sterilized clothes before starting a flight, for such gross infection as is seen in these cases can only come from the skin or the clothes. This point is referred to again in a later chapter. The nature of the tissue damage wrought by the missile. This has already been alluded to. Disrupted and stunned tissues, being in a very low condition of vitality, very soon die and form excellent pabulum for the microorganisms of disease. Severe bone comminution, damage done to one of the main arteries of a limb, resulting in extensive hemorrhage into the tissues of the part, and imperfectly immobilized fractures, are strong predisposing causes to infection. Penetrating wounds, followed by edema of the muscle of the part, with herniation of the same through the wound of entry, completely occluding it, form an ideal condition for the life and proliferation of anaerobes. Exciting causes of wound infection are certain of the pathogenic bacteria. These have been dealt with in the preceding chapter. Certain points call for consideration here regarding modes of implantation of these bacteria into the wound. These especially concern 1. Foreign bodies, 2. Flies. Foreign bodies may take the form of rifle bullets, shrapnel bullets, pieces of high explosive or trench mortar shells, or of hand grenades, rifle grenades, bombs dropped by airmen, and the like. On the other hand, the foreign body may not be a piece of missile, but dirt, pieces of flint, or pieces of stone. Whenever a piece of shell or other high explosive has penetrated the tissues in a clothed part, it has invariably carried in with it a piece of the soldier's clothing. The missile itself, after explosion of the shell, is probably sterilized by the heat generated. In the case of shrapnel, the shell bursts in the air, and wounds of the soft parts caused by shrapnel balls are amongst the least infected, if the shrapnel ball, prior to striking its victim, is not distorted. In the case of the universal shell used by the Germans, i.e., a combined shrapnel and high explosive, the shell casing also breaks up, and a very different type of wound results, both as regards extent and degree of infection. In the case of high explosive or percussion shells, the projectile strikes the ground prior to exploding. It may, indeed, if the ground be soft and muddy, penetrate a foot or more before exploding. Consequently, the fragments into which the shell breaks up are befouled with dirt prior to striking their victims. Wounds caused by rifle bullets or machine gun bullets fired at a considerable distance, 500 yards or over, are perhaps the least serious from the point of view of infection. When fired at point-blank range, or at a range of 100 to 300 yards, a rifle bullet wound can be as highly infected as also can a wound caused by a ricochet bullet. It must never be taken as a maxim that perforating rifle bullet wounds with a small hole of entry and exit, the so-called Seton wounds, are practically harmless from an infection point of view. This might have been so in the South African campaign, but it has not obtained in the present war. One of us was doing duty as surgeon at a field ambulance during May 1915, where all wounds were as a routine measure drained by means of rubber tubes. A great number of these wounds were caused by machine gun bullets, and after the Battle of Blank, almost all were highly infected by the time they reached the field ambulance. Without a doubt, the most important element in the case of infection is the piece of the man's clothing or other foreign bodies carried in by the missile, and not so much the missile itself. The missile brings about the necessary damage to the tissues, and the clothing, hair, dirty skin, or other foreign bodies, such as coins, pencils, paper, etc., that the soldier may be carrying with him, and which are driven into the tissues by the missile, are the main exciting cause of infection. From what has been said before, it is evident that the clothes, skin, and hair of the soldier, as he exists in the trenches, are teeming with most virulent bacteria, both aerobic and anaerobic, and these have been described in a previous chapter. Another point which strongly favors the theory that wound infection is directly brought about by the inclusion in the wound of pieces of clothing is the fact that in a number of airmen who have been wounded whilst flying, the wounds have shown most virulent infection, with the presence of gas gangrene. In every case, pieces of clothing have been removed from these wounds. Wounds caused by high explosive of any kind show a higher degree of infection, because the fragments are irregular and rough, and they therefore not only cause more damage and laceration of the tissues, but also carry in a bigger piece of infected clothing, that is, a larger dose of virulent organisms. The larger the piece of missile, the greater the damage to the tissues and the greater the piece of clothing carried in. Consequently, such wounds are more extensive both in degree and severity and infection. This has been most striking on more than one occasion where troops have been caught in a barrage of heavy shells. Flies. When flies gain access to open wounds, they may deposit thereon bacteria-infected material or larvae, or both. The bacteria are conveyed on the legs and wings and in their stomachs and intestines. From the habits and mode of feeding of flies, it is obvious that these bacteria are largely fecal in origin. It is well known that flies feed readily on fecal material, and this is always available in a battle area. From such material they convey the fecal bacteria directly to the wound in three ways. 1. Upon their legs and wings. 2. By regurgitation of infected food material from their stomachs onto the surface of the wound. And 3. By the deposition of their own excrement. Of these three methods of depositing bacteria upon the surface of a wound, it has been demonstrated that the deposit of the excrement of the fly is the most fruitful source of infection. In a well-fed fly, the act of defecation occurs every 4½ minutes. Flies further affect wounds by the deposition of their larvae in dead or dying tissue. Within a very short space of time, maggots make their appearance in the wound in large numbers. Not many cases of maggot infection in wounds were seen prior to the Somme offensive in 1916. But during this battle the condition became common, and quite a number of these cases arrived at the casualty clearing stations. This infection occurs chiefly in men who have been wounded and have been lying out in the open with their wounds uncovered. There appear to be two types of maggots, a large and a small variety. They exist in greater numbers in wounds, and often by the time the clearing station is reached, both blankets and stretcher contain many of them. Maggot-infected wounds are extremely offensive to smell, yet the presence of these creatures in a wound has proved to be a not unmixed evil, for there is not the slightest doubt that they do in some way exert a strong inhibitory action on the growth of the more virulent bacteria. It is a noteworthy fact that gas gangrene and maggots do not exist together in the same wound, and that maggots survive at the expense of gas gangrene. Of the many maggot-infected wounds seen during the Somme fighting, it was a most striking fact that these wounds did well. There was in these cases no gas gangrene, and no tendency for the infection to spread locally. Two cases particularly come to mind of extensive buttock wounds infected with gas gangrene, this type of wound then being of a notoriously fatal character. Both men were put out into the open air, the wounds being protected by a cradle covered with fine muslin. Despite this precaution, the wounds became fly-blown and were soon alive with maggots. From the date of the appearance of the maggots, both cases started to improve. Further infection was arrested, and they were transferred to the base, having picked up in a marvelous way, both locally and generally. It is probable that these maggots digest and get rid of dead and necrotic tissue at a rapid rate, and so remove the pabulum necessary for the existence and multiplication of the more virulent bacteria present in the wound. When all dead tissue has been removed, the maggots disappear, and from what could be judged it would seem that they do not elect to live in living healthy tissues. Two more instances were those of airmen who were hit while flying, and both had identical wounds, in that a large piece of the upper end of the tibia was completely blown away, leaving a large hole in the bone, which communicated in each case with the knee joint. Both had suffered severe primary hemorrhage. One case, Second Lieutenant W., was operated upon soon after his injury, and suffered severe postoperative shock. His wound was grossly infected, and contained B. perfringens and Streptococcus faecalis. The knee joint recovered, but he is still unable to walk, and sequestration is slow and going on 5 months after the injury. The second case, Second Lieutenant D., with an absolutely identical injury, had his wound full of maggots on admission. In 24 hours after admission the maggots had done their work, and were washed out of the wound with saline. The wound was sterilized by the Carroll-Dakin method, and sewn up over the hole in the bone. The wound healed, with the exception of a small piece of skin which gave way over the hole in the bone. The knee joint entirely recovered, and he was able to put his full weight on the limb and to walk 6 weeks after the injury. This is a striking contrast. Too many of such cases have been seen to be put down as coincidences, and it is, we think, not going too far to suggest that fly-blown wounds should be left until the maggots have removed all dead tissue present. Whether or not these creatures might not be useful as a means of treating extensive gangrenous wounds in the early stages is a point to be settled. For, horrible as the idea may at first seem, yet these maggot-infected wounds could not be any more offensive than similar wounds that were treated with the saltpack. End of chapter 5.
Chapter 6, Part 1 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Pamela Nagami, M.D. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 6. Wound Infection Continued, Part 1. The general pathological processes underlying the phenomena of infection in wounds have long been familiar to the surgeon. The source of wound infection is, of course, the activity of the bacteria which are introduced into wounds. The local effects, such as inflammation, suppuration, necrosis, autolysis, gangrene, and gas production, the general effects such as toxemia, septicemia, and pyemia, and the local and general bodily defenses exerted by means of phagocytosis and by the production of antibodies in the serum, all need no systematic description here. They are matters of common surgical knowledge, and have been described in standard textbooks many times. There are, however, certain special features in these phenomena of wound infection which have particular application to the wounds of this war, and these will form the subject matter of the present chapter. Many of the pathological processes already known have now acquired a new meaning and interest. The local infection and local tissue response. 1. Introduction of organisms into wounds. It has been shown elsewhere that the pathogenic microorganisms which gain access to wounds do so in 3 chief ways. 1. In the piece of clothing, which is invariably forced by the missile into every wound involving a clothed part of the body. 2. In particles of soil similarly carried in or subsequently introduced into the wound. And 3. From the skin at the orifice of the wound. Enough has already been said to make it clear that under the present conditions of warfare, these 3 sources of infection can hardly fail to be contaminated with fecal matter, and this is the reason that the bacteria of wounds are mainly fecal in origin. With regard to number 2, the soil of Belgium, France, and Serbia, as well as other areas of the war, is all more or less highly manured, and under the conditions of trench warfare, it receives constant additions in fecal organisms from the excreta of men and horses of the opposing armies, and from the decomposing human and animal remains of the killed. This fresh contamination, which goes on daily increasing, is at its greatest in the firing line, in the very soil which is constantly being churned up by shell fire, and it is the contaminated particles of this soil which gain access to wounds along with shell fragments. With regard to 3, it has been related how difficult it is for the men in the front-line trenches to maintain even a low standard of cleanliness, and it is evident from the conditions which exist that the skin of these soldiers, especially about the buttocks, thighs, and hands, must constantly be polluted with the bacteria of feces. So far, then, as these 2 modes of introduction of organisms into wounds are concerned, it is obvious that no measures which might be taken to reduce the danger of infection are at all likely to be efficient or even practicable under the conditions of front-line warfare. With regard to number 1, which is obviously by far the most important mode of conveyance of infective material, owing to the necessarily foul condition of the clothing of men in the trenches, it has been suggested that something might possibly be done to keep the clothing sterile by the application of disinfectants. The idea arose from certain bacteriological investigations, which seem to show that if pieces of ordinary clothing, containing numerous organisms as they do, were saturated with a 5% solution of cresol and allowed to dry, they would remain sufficiently impregnated with the antiseptic during a month of ordinary wear to prevent or inhibit the growth of any organisms which might survive in them. In spite of the obvious difficulty, and indeed impracticability, for the method was actually tried on a small scale without success, of carrying out this procedure in the case of frontline units, a few simple cultural experiments were made by one of us in order to test the bacteriological findings. The results of the first experiments were so entirely negative that no further series of experiments was carried out. These experiments were briefly as follows. Number 1, the test pieces of clothing were obtained from an ordinary khaki uniform, greatcoat, and tunic worn by a soldier. The strengths of cresol tested were 2% and 5% solutions. The culture media used were agar, milk, and broth, the first being put up aerobically and the others anaerobically. 2 procedures were used. A. 2 test pieces of clothing were taken. One was soaked in a 2% cresol solution and the other in a 5% cresol solution for 1 hour. They were allowed to drip dry and left lying about in a dusty place for 1 week. Aerobic and anaerobic cultures were then made. All these cultures yielded a copious growth of organisms. B. 2 test pieces of clothing were treated as above, but 24 hours before inoculation of the media, they were smeared lightly with a thin fecal emulsion, allowed to dry, and to lie about until the cultures were made. All these cultures yielded profuse growths of organisms, and also abundant gas production in the agar shake and the milk cultures. Number 2. The test piece of clothing was a piece of the underclothing, pants, of an officer. The garment was washed in 5% cresol and worn for 7 days. Cultures were then made as above. All these cultures yielded copious growths of organisms, and there was, in addition, gas production in milk. In these experiments, the 5% cresol series yielded much less copious growths than the 2% cresol series. But nevertheless, even in the former, the cloth remained very far from sterile. The following table shows the results. Experiment number 1. A. Greatcoat and tunic. Treatment. Greatcoat, 2% cresol solution. Cultures. Agar shake, numerous colonies, no gas. Milk, anaerobic, acid and clot. Broth, anaerobic, many sporing and non-sporing organisms. Tunic, 5% cresol solution. Agar shake, numerous colonies, no gas. Milk, anaerobic, acid and clot. Broth, anaerobic, cocci-grown, no anaerobic bacilli present. Experiment 1B. Greatcoat, 2% cresol solution followed by fecal contamination. Agar shake, abundant gas. Milk, anaerobic, perfringens reaction. Broth, anaerobic, numerous sporing and non-sporing anaerobic bacilli. Tunic, 5% cresol solution, followed by fecal contamination. Agar shake, abundant gas. Milk, anaerobic, perfringens reaction. Broth, anaerobic, numerous sporing and non-sporing anaerobic bacilli. Experiment number 2. Officers' underclothing, washed in 5% cresol and worn 7 days. Agar shake, numerous colonies. Milk, anaerobic, acid clot and gas. Broth, anaerobic, numerous organisms. These results are so unfavorable that this particular method is an undoubted failure. Further, from both bacteriological and administrative aspects, there does not appear to be much prospect of reaching any practicable method of diminishing the grossness of primary infection of wounds by such means. The only possible exception is in the case of flying men. We must therefore be prepared for gross infection of war wounds in almost all cases, and all our efforts must be directed toward the elimination of this infection by appropriate methods of treatment of the wound itself. 2. Initiation of local infection. The essential facts relative to the start of the infective process in wounds are: 1. Introduction of a mass of organisms along with a foreign body. 2. Local tissue injury, usually of a gross character. And 3. Lack of vigorous general defensive reaction. These have been considered in part elsewhere, and little need be added here. 1. The foreign body, piece of clothing, etc., has masses of organisms scattered throughout its substance. Many of these organisms are not in actual contact with the tissues and are consequently sheltered from direct attack by the defensive agents of the body contained in phagocytes and serum. The foreign body acts, therefore, as a nidus in which the organisms are able to maintain their existence almost without molestation. They have thus every opportunity of establishing themselves firmly in the wound before their growth can be checked. Number 2, the gross tissue injury produced by a modern high-velocity missile has a very profound effect in favoring the onset not only of inflammation and its sequelae, but of gas production. See page 146. A constant feature of the damage produced in the tissue bordering the wound is a direct lethal or sublethal effect on the tissue cells, including damage to the endothelium of the capillary blood vessels. There follows from this a very rapid outpouring of lymph in the tissue lining the wound and extending for some distance from it. This reactionary edema, as it has been called, appears within an hour or two of the injury. It is a reactive phenomenon designed to aid defense against infection by means of the serum and leukocytes which it brings into the wound, and also to aid repair by acting after coagulation as a scaffolding for the growth of the tissue which will eventually bridge the gaps. In many wounds, however, this reaction by its very vigor becomes inimical. It is accompanied by great swelling of the tissues, causing them, for example muscle, to herniate out of the wound in many instances. This may close up the wound of entry altogether and cut off the deeper parts of the wound from access to the oxygen of the air. The lymph fills all the tissue spaces and accumulates under such pressure as to interfere with the circulation of the part. It also rapidly coagulates and so forms a mass which is readily changed into inert pabulum for bacteria. At this stage, therefore, shortly after the production of the wound, we have present in the wound the following ideal conditions for the establishment of infection. A rich variety of fecal and other bacteria in a nidus protecting them from the bodily defenses. B, dead and devitalized tissue in which these bacteria, including even saprophytes, can readily flourish without much opposition. C, a mass of coagulated lymph, which partially blocks the blood supply to the part, and which also may be changed into inert pabulum for the bacteria. D, partial or complete anaerobic conditions in the depths of the wound, whereby the growth of the gas-producing organisms is rendered possible. Number 3, lack of a vigorous general defensive reaction. This is the one remaining condition which, if added to the above list, makes the onset of a virulent and rapidly spreading septic process in the wound inevitable. The position could yet be saved in only one way, by a vigorous and healthy resistance on the part of the soldier's bodily defensive mechanism. While such resistance would be unable to prevent the actual initiation of infection under the conditions present, it would tend to check effectively the spread of the process, and having localized it, would be able in time to render it harmless. This, however, is precisely what cannot be brought about in a great many cases, owing to the conditions of fatigue, shock, hemorrhage, etc., which are so often associated with the wounds of this war, and which handicap the soldier so much in his struggle with wound infection. It is constantly observed, for example, that gas gangrene occurs in any severe degree only in fatigued or shocked men, and that men wounded in quiet times, who are initially less fatigued and who rapidly receive attention, are much less prone to incur gas gangrene. Diminished resistance owing to fatigue, etc., thus plays a most important part in the initiation of septic processes in wounds. When organisms begin to grow, they produce either by metabolism from their own protoplasm or from the protein which happens to be their pabulum at the time, certain complex poisonous bodies called toxins. Their exact chemical nature is unknown, but they have been proved to be products of the disintegration of protein, not uncommonly allied to albumoses. They are of two kinds. 1, endotoxins, or insoluble toxins which remain within the bodies of the bacteria when the latter are grown in an artificial fluid medium. 2, exotoxins, or soluble toxins which diffuse out into the fluid in which the bacteria are growing. These toxins produce local and general effects. Locally, they attack tissue cells and may produce any degree of damage in them, up to complete necrosis. The tissue cells, unless killed at once, retaliate by producing antitoxins. The toxins also become absorbed into the bloodstream, and by action on nervous centers give rise to the general symptoms of toxemia, rise of temperature, rapid pulse, malaise, etc. The amount and the potency of the toxins formed depend upon such factors as A, the number and kind of bacteria introduced into the wound, B, the virulence of these bacteria, C, the degree of reaction on the part of the patient's tissues, both local and general. In the case of war wounds, as has been already explained, it is the factor C which is the most variable and which in most cases determines the extent of the infection. 3. The reaction to infection. The bodily defenses. Whenever infection is initiated, the body reacts to the best of its ability by pouring into the wound a fluid consisting of serum and phagocytes. These are the two elements of the bodily defense. A, the serum or lymph, which exudes into infected wounds, is a colloid containing antibacterial substances of various kinds. These substances are rapidly produced by the tissue cells in response to the action upon these cells of toxins derived from the growing bacteria in the wound. Without entering into the theory of toxic action, we may briefly state here that when toxins act upon cells, they not only damage the cell, but also stimulate it to produce certain antibodies which have a specific neutralizing effect upon the toxins which have caused the damage. These antitoxic and antibacterial substances are rapidly absorbed into the blood and remain in fine suspension in the serum, whence they appear in the wound, in the lymph, which becomes exuded as the infective process progresses. The study in vitro of serum which has been so immunized shows that it is capable of reproducing various distinctive reactions, and it is not certain whether these reactions are manifestations of the activity of different kinds of antibodies or are merely different phases of the activity of one kind of antibody. Whichever view be taken, it has been proved that the antibodies in the serum are capable of exerting their action in one or more of the following ways. 1. As antitoxins, or bodies which directly neutralize and render harmless the toxin produced by bacteria. 2. As bacteriolysins, or bodies which attack bacteria directly and cause their lysis or destruction. 3. As agglutinins, or bodies which cause the bacteria to be agglutinated or aggregated into clumps, and so rendered to some extent inert. 4. As precipitins, or bodies which precipitate the specific toxins which stimulated their production. And 5. As opsonins, or bodies which sauce up the bacteria and render them into a condition whereby they are readily available for phagocytosis. Whether the anti-substances in the serum, which are demonstrably increased after infection has begun, actually exert these various actions on the bacteria within the wound and the toxins derived from them is not known. But it is well known that fresh serum has a marked inhibitory effect upon the growth of organisms in artificial culture, and it is certain that so long as it is fresh, it inhibits the growth of organisms in wounds also. Further, in the case of wounded men suffering from infection, it can be shown by agglutination and opsonic index estimations that the inhibitory effect of their serum upon the growth of organisms which have been isolated from the wound, lymphatics, or bloodstream is increased. The activity of these antibodies is part of the general vital activity of the body, and it must obviously be diminished whenever that vital activity is low, as in the case of fatigued or diseased men. When serum coagulates, as it may do when it leaves the circulation and lies in contact with damaged tissue, especially in the presence of infection, or if it encounters an infection which is too strong for its antibacterial powers, it undergoes a tryptic change, which causes it to lose its inhibitory power on the growth of microorganisms, and indeed renders it into an inert mass of pabulum for these bacteria. So long, however, as the lymph circulation between the bloodstream and the tissue of the wound remains active, the serum has bactericidal powers and should be utilized in all schemes of treatment. And, in passing, it may be observed that this is a fundamental of the Carrel method of treatment of wounds, and that drainage, in the old sense of removing healthy serum and phagocytes from contact with the infected surface, is a practice to be deprecated. B. The phagocytes constitute the second element in the bodily defensive mechanism. They consist of 1. Polymorphonuclear leukocytes of the blood, 2. Large mononuclear leukocytes, and 3. Large endothelial cells from the lining of lymph glands, tracts, and spaces. These various cells are attracted by a process of chemiotaxis to the spot where bacteria are endeavoring to establish their growth. The process of phagocytosis, whereby these cells attack, envelop, ingest, and destroy the bacteria, or are themselves destroyed, is a very familiar one. It can be easily demonstrated under the microscope in connection with any sufficiently infected wound exudate. There is, however, more in it than meets the eye. There is the subtle influence which guides the phagocyte towards its prey. There is the means by which the organism is, so to speak, paralyzed and rendered into suitable prey, opsonins. And there is the means, the perfect organic antiseptic, by which the organism is killed before or after the phagocyte enfolds it. The final lysis of the bacterial substance within the cytoplasm of the phagocyte is probably accomplished by the action of ferments. In the primary stages of wound infection, the polynuclear leukocytes are the predominant phagocytes, possibly because they are more mobile. In the later stages, the very actively phagocytic mononuclears and endothelial cells, the macrophages as they are called, become relatively increased, and in the last stages may outnumber the other. In the case of infection in serous membranes, however, such as the peritoneum, the pleurae, and the synovial membrane of joints, the macrophages, which are normal inhabitants of these structures, are relatively numerous from the beginning, and large numbers of them in a healthy condition are of good prognosis. These two elements of the bodily defensive mechanism, the serum and the phagocytes, are interdependent in their action. They are each practically functionless in the absence of the other, and the assault which they make is always a combined one. There are other cellular elements which appear in wounds, namely lymphocytes and tissue cells, the small mononuclears, and it is probable that they too play a minor part in phagocytosis, or at least in immunity. They seem to be capable of forming antitoxins and other antibacterial substances, but their further action, if any, is quite unknown. They are present in relatively large numbers in the wound exudate in the earlier stages of infection, when the lymphocytes probably play some unknown subsidiary part in phagocytosis, and the tissue cells are doing their best to repair the damaged structures, and are at first separated off in the process. In the later stages, no lymphocytes are seen, and the tissue cells too are scanty, since they remain attached to the growing granulation tissue. 4. The progress of infection. The local infection in a wound may progress in one or more of three directions. 1. Localized suppuration. 2. Spreading inflammation and suppuration in special structures, for example, bone, tendon, and cellular tissue. 3. Gas gangrene, localized or spreading. The macroscopic appearances associated with localized and spreading inflammation and suppuration are too well known to require description here, and the naked eye pathology of gas gangrene in wounds is considered in another chapter. The microscopic history of wounds is, however, a recently developed branch of surgical pathology, and on account of the valuable information which it yields to the surgeon, it will be dealt with here in some detail. It is convenient to take as a model a large flesh wound showing localized gas gangrene, for that is perhaps the most typical of all war wounds, and its microscopic history, while undergoing sterilization by the Carroll-Dakin method, will be sketched. This can be studied only at the casualty clearing station and the base hospital. Methods of investigation. The chief method is the examination of daily or 2-day successive direct films from various prominent and distinctive features in the wound, including always the part where the power of the cells may be tested by Colonel Bond's iodophil reaction or by the staining reactions of the cells. Valuable information is also obtained by making cultures, but this method is much more laborious. It is necessary to state that a wound during the progress of the infection consists of various quite distinctive features, such as dry hyperemic tissue, suppurating tissue, gangrenous tissue, sloughs of granulation tissue, and of muscle, ligament, and tendon, necrosed bone, sequestered bone, cavities containing gravitated wound exudate, sinuses, undermined areas, healthy granulations, etc. Some of these are characteristic of the earlier and some of the later stages of infection, but many of them may be present in a wound at the same time. It is necessary, therefore, in representing the state of infection of a wound by figures and symbols descriptive of the number of organisms and the type of cells present, to specify the part of the wound from which the exudate has been taken. In this way, by means of a series of films made at daily or 2-day intervals during the sterilization of the wound, the progress and the pathological history not only of the wound as a whole, but of each part in particular can be watched. In practice, bacterial charts have been constructed by Carroll and others to represent graphically the progress of the wound infection. Daily films are made from the dirtiest part of the wound. The number of organisms in 20 microscopic fields is counted and the average taken. The number of organisms per field thus obtained is the figure for the day. The variations in this figure from day to day and the gradual or ultimate downward tendency can easily be represented by a colored line on the temperature chart or on a separate chart. In a series of about 150 wounds which the authors investigated in this way, special forms were used representing the state of the wound infection more completely than by a single figure. The information noted on these forms after examination of the smears embraced not only the average number of organisms per field in various situations in the wound, but their apparent nature, the relative proportion of bacilli and cocci, the percentage of organisms intracellular, the relative proportion of healthy and degenerate cells, the relative proportions of polynuclears, small round cells, and macrophages present, and, in a number of cases, the organisms isolated on culture. These forms, when completed up to the time of secondary suture, gave a fairly complete representation of the microscopical history of the wound, and it is on the information so gained that we base most of the findings described in this chapter. Technique of direct film examination. The apparatus required is shown in the illustration, Figure 24, viz. A platinum wire, a spirit lamp, a box of clean slides, a pencil for writing on glass, and some forms on which to write the report. These materials are taken to the bedside of the patient when the daily or 2-day dressing is being done, and the smears are made by means of the platinum wire as shown in the illustration, Figure 25. The platinum wire is sterilized in the flame of the spirit lamp, and a loopful of wound exudate is removed from the various parts of the wound which it is desired to test. In most cases, 1 or 2 smears suffice, and these should always include the dirtiest part of the wound. A loopful of wound exudate is taken directly after removal of the dressing and before any of the discharge has been removed by irrigation with the hypochlorite solution. As far as possible, the exudate is taken unmixed with the antiseptic fluid, and in the case of granulation tissue, it is particularly important to avoid taking up a loopful of blood. The smears are made by spreading out the loopful of exudate in circular fashion to form a smear which varies in size from a shilling to a florin, according to the amount and thickness of the material. If 2 or 3 smears are made from one wound, or one person's wounds, they can be made on the same slide. The smears are ringed on the back of the slide by means of the grease pencil, as shown in the illustration, and appropriate abbreviations are written under each ring to indicate the position or nature of the part of the wound from which the smear was made. For example, smears may be labeled right thigh ant for anterior wound of right thigh, sin post for sinus posteriorly, surf lat for lateral surface, etc. If preferred, each smear can be denoted by letters A, B, C, etc., and corresponding letters with a description of the part to which they refer written on the report form. We have, however, found it more convenient to write even copious notes on the back of the slide by means of the grease pencil. A number is now written on the back of the slide, and a corresponding number written on a report form, together with the other particulars desired, such as name, ward, date, character, and position of wounds, date of infliction of wound, etc. The slides are then dried over the flame, fixed by passing through the flame, and finally rolled up in the appropriate report form and taken to the laboratory. The smears are stained with Kühne carbol methylene blue, footnote, Kühne's methylene blue, 1.5 grams, absolute alcohol 10 cc's, carbolic acid solution 1 in 20, 100 cc's, end footnote. For 3 minutes, and where duplicate smears have been made, these are stained by Graham's method in order to identify certain groups of organisms present. Carbol methylene blue is the stain which we have come to rely upon as the best for routine work. The following are among its advantages. 1. It gives a beautifully clear picture, the nuclei of the cells being well differentiated from the cytoplasm, the former being stained deep blue and the latter light blue. 2. Organisms take the stain very readily, and they can be easily picked out. 3. When blood corpuscles are present in the film, they are stained green, thus differentiating them at once from lymphocytes and tissue cells, which may sometimes be confused with them when a single simple stain is used. 4. It clearly shows up any trace of degeneration of the phagocytes, as the nucleus, instead of staining deep blue, in such a condition tends to a purple shade. Moreover, fragmentation of the nucleus is easily seen, and the cytoplasm is very lightly stained. The iodophil reaction method. This method has been introduced by Colonel Bond in order to determine the degree of phagocytic power possessed by any leukocytes. The essential element of the test can be studied as follows. Obtain a film of perfectly healthy leukocytes from normal blood, either from the leukocytic layer between the serum and the red blood corpuscles after the blood has been centrifuged, or by incubating blood in a plasticine cell for 1 hour at 37 degrees C until the leukocytes emigrate from the clot and form a layer adhering to cover glass and slide. Mount these healthy leukocytes in normal saline and allow 1% watery iodine to run in under the cover glass. At once, there is seen in a considerable proportion of the leukocytes in a field a mauve-colored exudation which collects within the cell and is quickly extruded until it forms a little mauve spherical colloidal mass of iodophil substance adhering to the outside of the cell which has expelled it. Ultimately, these colloidal masses break away from the cells and float free in the fluid. The reaction is seen best in a certain zone of the cover slip preparation where the iodine reaches a certain concentration. The amount of this mauve-colored substance varies with the phagocytic power of the cells, and in any film of leukocytes in which it is not seen or seen in very slight degree, the leukocytes are incapable of active phagocytosis. In the case of wound exudate, the reaction is said to be present in cells which have free egress from the wound, such as those on the surface, where the cells are shut in and have no free flow, as in a sinus the reaction is absent. The authors have applied this method to wounds undergoing sterilization by the Carroll-Dakin treatment, and have found that except in the earliest stages, that is, during the first 3 or 4 days in the case of a gangrenous wound, the cells of the wound exudate generally give the reaction in large measure. The reaction is readily obtained in the case of the cells of sump wounds and even of sinuses, provided that hypochlorite solution is regularly instilled into the sinus. We have not found that the reaction yields any more information than can be obtained by inspection of films of wound exudate well stained by carbamethylene blue. By using this stain, it is easy to pick out at once the healthy cells by the intense blue staining of the nuclei and the distinct light blue cytoplasm. The cells which are less healthy stain less intensely and show some fragmentation of the nucleus, while those which have performed phagocytosis and are rather the worst for the struggle have nuclei which are deficient in chromatin and tend to stain purple. This purple staining of the nuclei is often seen also in those pale staining cells which are obviously degenerate and those which are frankly breaking up. An additional advantage in gauging the functional activity of the cells of wound exudate by means of staining reactions in dry films is that phagocytosis can actually be observed. The proportion of organisms intracellular can be roughly estimated, and the condition in particular of the cells which have ingested organisms can be noted. These points, which can be taken in almost at a glance, provide important additional evidence on the question of the degree of phagocytic power possessed by the cells as a whole. Description of microscopic drawings. Figures 26 through 30 represent the microscopic history of a heavily infected gas gangrenous flesh wound treated by the Carroll-Dakin method. The smears were made from the dirtiest part of the wound at intervals of 2 days. The drawings represent a small part only of a typical field, magnification 800 times, stain Kuehne's carbamethylene blue. Figure 26, gangrenous stage. Gangrenous wound, 3rd day. Wound excised 2 days previously. Recurrence of gangrene in fresh wound surfaces. Smear made from black gangrenous tissue. Note the large number of sporing, non-sporing, and filamentous anaerobic bacilli. Absence of cocci, and the smaller aerobic bacilli. Cells are practically absent. No polynuclears at all. Numerous fragments of necrotic tissue and tissue debris, and minute globules of oil from the disintegrated tissue. Figure 27, sloughing stage. Localization of the gangrenous process has occurred, and the affected tissue is sloughing. Smear made from a separated slough. Cells are now present, but stain faintly and show little detail of structure. Polynuclears degenerate. In many are crammed with organisms. Degenerate tissue cells and elements and tissue debris still present in quantity. The large anaerobic bacilli are now relatively few, and great masses of cocci and small bacilli have taken their place. Figure 28, early granulating stage. Smear made from thick exudate on granulating surface. Polynuclears numerous, and still stain rather faintly. Actophagocytosis in progress. A microscopic slough is represented, consisting of a degenerate mass of tissue cells mixed up with organisms, and more or less surrounded by a zone of polynuclears. Organisms are very numerous, and consist entirely of cocci and small aerobic bacilli. Anaerobes have completely disappeared. Figure 29, late granulating stage. Smear made from wound exudate, which is now much less copious. Cells stain well and have a healthy appearance. They are mainly polynuclears, but occasional tissue cells and macrophages are seen. Some of the older or more exhausted cells show a purplish staining, large meshed nuclear chromatin. Organisms much less numerous, and most of them are intracellular, streptococci in diplococcal form predominate. Figure 30. Stage of surgical sterility for secondary suture. Smear made from thin mucoid wound exudate. Cells are almost all healthy and are relatively less numerous. Polynuclears predominate, but the proportion of macrophages is greatly increased. Tissue cells are common. An old polynuclear with purple staining nucleus is shown. No organisms are shown in this part of the field, but a few cocci are present in the smear, averaging not more than 0.4 per field. This wound was sutured and healed by first intention on 11th day. Figure 31. Early granulating stage in a compound fracture. Corresponds to Figure 28. Cells stain deeply, a typical feature in bone cases. Polynuclears predominate and active phagocytosis is in progress. Tissue cells are very common. A microscopic bone slough is represented, consisting of a fragment of bone showing canaliculi and accompanied by a degenerate mass of tissue cells and a zone of polynuclears. Fat globules and pigment from bone marrow are represented. Organisms are numerous and consist of cocci and small bacilli, no anaerobes seen. The succeeding stages in a compound fracture are similar to those shown above. Figure 32. Left half represents a smear from a wound in the late granulating stage. The organisms are almost all in the form of long-chain streptococci. This never occurs where sterilization is proceeding satisfactorily. The smear suggests A. Presence of a foreign body or necrosed bone and retained pus, or B. Insufficient access of fluid to all parts of the wound. Possible lines of treatment are 1. Correction of the surgical defects where this can be safely done, and 2. Autogenous streptococcal vaccine. Right half represents a smear from a wound which has passed the stage of surgical sterility and become dried up and covered with a thick layer of granulation tissue. Polynuclears are few, macrophages, tissue cells, and fibers and other tissue elements predominate, and there is a fair sprinkling of red blood corpuscles stained green. Sterilization has here proceeded too far, and the object of secondary suture is largely defeated owing to the thickness of the cicatricial tissue produced. The microscopic history of wounds. We may now trace the various stages through which an infected wound passes during sterilization, according to evidence derived from successive daily microscopic examinations of the wound exudate. A very typical war wound is selected as a model, viz., a large localized gangrenous flesh wound, say of the buttock, or a compound fracture of the femur. When such a wound is treated by the Carroll-Dakin method, the following stages may be noted. 1. Hyperemic and edematous stage. Smears of the wound taken at the casualty clearing station during the first day show degenerate tissue cells, lymphocytes, endothelial cells, scanty polynuclear leukocytes, and few organisms. The organisms are chiefly large gram-positive bacilli, Bacillus perfringens group, hereafter B. perfringens group, and there may be a few diplococci, Streptococcus faecalis. The infection has but begun, and neither have the organisms multiplied greatly, nor have the tissues yet put forth their defensive power. In a wound which is becoming gangrenous, however, the large anaerobic bacilli develop with amazing rapidity. 2. Gangrenous stage. This may be seen at the casualty clearing station. A gangrenous, foul-smelling pellicle lines the wound track, and there may or may not be gas extending into the tissues. Smears from the gangrenous area at this stage show a mass of organisms, almost all bacilli, and relatively few cocci. The predominant organisms are B. perfringens, coliform bacteria, and Vincent's bacillus. The cells are very scanty and very degenerate, and consist of scattered tissue cells, lymphocytes, and endothelial cells. Polynuclears are absent, for they cannot penetrate into gangrenous tissue. At this stage or before it, the wound is usually excised, and as complete excision is impossible in the majority of cases, there remain to be sterilized the freshly infected cut surfaces. This process is commenced by inserting a sufficient number of Carroll's tubes into the excised wound, and the case is sent to the base hospital, usually on an ambulance train. During the journey on the train, the hypochlorite solution is instilled hourly or 2-hourly through the Carroll's tubes. When the base hospital is reached, the condition of the wound depends entirely upon the thoroughness of the preliminary surgical excision, the technique of the insertion of the Carroll's tubes, and the diligence and regularity with which the hypochlorite installation has been carried out. If all these conditions are favorable, the wound will usually arrive at the base hospital comparatively clean, the infection having been checked and further gangrene and suppuration prevented. The wound can then be secondarily sutured within a day or two of the arrival at the base hospital. If, however, the conditions are unfavorable, for example, by reason of incomplete excision, inefficient application of tubes, unfavorable general condition, fatigue, shock, hemorrhage, etc., unfavorable local condition, severe comminution of bone, etc., insufficient hypochlorite installation, etc., the reinfection of the excised wound spreads and gangrene reappears. Thus, the wound may arrive at the base hospital still in the gangrenous stage, and smears will then show the features which have been already mentioned. There is nothing for it but to see that the Carroll tubes are properly inserted, and to introduce the hypochlorite solution regularly and without fail every hour. The gangrenous tissue will then rapidly disappear, more quickly in some parts than in others. Exudation becomes poured into the wound, and the process of separation of the sloughs begins. As this goes on, the film picture changes. The cells, which were scanty and degenerate, rapidly increase in numbers, and polynuclears reappear. The character of the bacterial flora also undergoes a change. 3. Sloughing stage. Around the masses of gangrenous tissue, yellow purulent exudate appears within a day or two, and this exudate increases until the whole wound may be almost bathed in it. Gradually, as a result of the ferment and phagocytic action of the leukocytes and of the solvent action of the antiseptic, Dakin's solution or Eusol, the gangrenous tissue separates, mainly as microscopic but sometimes as macroscopic sloughs. Smears from the purulent exudate in this stage show an abundance of polynuclear cells, moderately healthy, numerous tissue cells, mostly in the form of little separated masses of degenerate cells, microscopic sloughs, a few lymphocytes, and very scanty macrophages. The organisms are very numerous, usually upwards of 100 per field. The relative proportion of bacilli and cocci has changed, and we now find that the bulk of the organisms are gram-positive cocci, Streptococcus and Staphylococcus, and small bacilli, coliform and diphtheroid organisms, etc., while the large, stout, gram-positive bacilli, B. perfringens, and all large sporing bacilli are greatly diminished in numbers. The saprophytic element in the wound infection is being gradually eliminated, and the more resistant parasitic flora are in the ascendant. 4. Granulating stage. Within 2 or 3 days more, there begin to appear at various points in the wound surfaces little red islets of granulation tissue raising their heads from out of the pool of purulent exudate. These appear first in the parts of the wound occupied by superficial fascia and by muscle. Dense, deep fascia, for example, fascia lata, ligament, tendon, and bone are much more resistant to sterilization, and the sloughs of these structures take much longer to separate. Gradually, the islets of granulation tissue unite and form a layer which, in spite of repeated partial destruction and sloughing, repairs itself and spreads until it covers the whole wound. This process takes a very few days, unless there be some specially resistant slough present, for example, dense fascia or ligament or bone, when it is delayed for a week or two until the slough separates. The rest of the wound becomes meanwhile covered with granulation tissue. Smears from the granulation tissue exudate show abundant, healthy, intensely stained polymorphs, as well as tissue cells, which are discrete and in little masses surrounded by a zone of leukocytes. The central cells of the masses are degenerate, microscopic sloughs, but the discrete tissue cells, as well as those at the periphery of the masses, are usually moderately healthy. Macrophages may be present in rather greater numbers, but are still relatively few. They stain well and can often be seen actively ingesting organisms and even the more degenerate polynuclears. The organisms are much diminished in numbers, and the cocci are now much more numerous than the bacilli. As long as sloughs remain in the wound, occasional large gram-positive bacilli, usually B. perfringens, can be seen. But in most wounds these disappear altogether when sloughs are dissolved away, and commonly rather earlier than this. Coliform bacilli usually disappear about the same time. When sloughs have been removed, the organisms which are commonly cultivated from the wound are Streptococcus, Staphylococcus, and diphtheroid bacilli. Bacillus pyocyaneus appears very rarely in a wound treated by the Carroll-Dakin method, and on those rare occasions in which it does appear, strong suspicion should be entertained of an error in technique. It disappears quickly when a wound is efficiently and vigorously watered with hypochlorite solution. During the granulating stage, the bacterial count falls rapidly to an average of 3 or 4 per field. If the rule be followed of taking smears only from the dirtiest part of the wound, the bacterial count remains high until all sloughs have disappeared, and then a sudden fall occurs to 3 or 4 per field, or even less. In the case of compound fractures, certain slight differences are observed during the sloughing and granulating stages. Microscopic sloughs are much more common and characteristic. They have an intensely staining, undifferentiated granular mass in the center, which seems to consist of a minute piece of necrosed bone with bone cells. Around this central mass is grouped a zone of large, deeply staining tissue cells with cytoplasm somewhat square in form and a relatively small, round, dark nucleus. There are numerous polynuclear cells infiltrating this zone, and these cells also form another distinct zone around the tissue cells. In the latter part of the granulating stage, the necrosed centers of these masses no longer appear in the exudate, but grouped tissue cells of large size can still be seen, as well as the ordinary discrete connective tissue corpuscles. In these groups of tissue cells, there are commonly seen certain large cells with relatively large, deeply staining nucleus. These cells have all the appearance of healthy osteoblasts, and if such be the case, would appear to indicate that bone repair is proceeding at these stages actively. 5. Dry stage. A change in the granulating stage takes place soon after all sloughs have been removed. Healthy granulations now line the entire wound surface, except in the case of certain severe compound fractures in which the process is considerably delayed. Discharge diminishes, and the wound enters once more upon a dry stage. Smears show that polymorphs are absolutely and relatively diminished and are almost all active and healthy. Purple staining of nuclei is practically absent. Connective tissue cells are much fewer and are isolated cells in the discharge, and no masses of them can now be seen. The most characteristic feature of the cytology is the largely increased number of the macrophages. They are very large cells at this stage, each with a large round meshed nucleus, and often 1 or 2 nucleoli. They are actively phagocytic and can often be seen ingesting organisms and also the older polymorphs. The organisms diminish rapidly during this stage. They usually consist entirely of cocci and diplococcal form, but sometimes include small diphtheroid bacilli. 6. Stage of clinical sterility. This stage follows rapidly upon the dry stage, except in a few unfavorable cases. The cells as a whole diminish in number still more, and polymorphs may become very greatly decreased. Endothelial and isolated granulation tissue cells being seen in abundance. The organisms diminish within a few days to the figure which stands for clinical sterility, which is the maximum which usually allows of secondary suture being performed without fear of the wound breaking down. This standard is usually fixed in France at 1 per field, but the authors prefer a rather lower standard, viz. 0.4 per field, or an average of 2 organisms per 5 fields. This was found to give the best results in a series of over 600 secondary sutures of all kinds. In a large number of cases, the sterility obtained was almost absolute, no organisms being seen in 20 to 40 fields of a film preparation. The essential film characteristics in the stage of clinical sterility then are as follows: A maximum bacterial count of 0.4 organisms per field, the average being taken over 20 fields. B, polynuclears comparatively few. C, macrophages numerous. Time required for sterilization of wounds. The above description of the successive film pictures during the sterilization of a wound by the Carroll-Dakin method refers to a severely infected flesh or ordinary compound fracture showing localized gangrene after excision. Such are very typical wounds. In the case of less severely infected wounds with good excision, the whole course of sterilization may be very short and suppuration very slight. But even in such wounds, there are many cases in which, though the earlier stages are short or absent, the suppuration stage may be fairly persistent. When this occurs, the granulation tissue lining the wound can often be seen to be full of little crypts in which the bacteria of the wound flourish and which are very difficult to sterilize. In such wounds, the bacteria invade the granulation tissue wall to some depth from the surface. This indolent condition of the granulation tissue undoubtedly occurs in many cases as a result of insufficient flushing of the wound with hypochlorite solution in the early stages. A certain proportion, however, of such indolent infections of wounds on the Salonika front seem to be due to malaria. The time required for sterilization in the first series of 200 secondary sutures performed at this hospital was 10 to 15 days for flesh wounds and 17 to 28 days for compound fractures. Our later series of 400 cases yielded much better results, possibly owing to a more complete excision at the casualty clearing station, as well as to increased experience on the part of the medical and nursing staff. Flesh wounds in this series were sutured in from 4 to 12 days and compound fractures in from 6 to 28 days. Delayed sterilization of wounds. In any large series of wounds, however, there are a number of departures from the ordinary routine. Special difficulties are created by the presence of severe comminution of bone, large gaps in bone, sequestrating bone, unremoved foreign bodies, wounds generally which do not lend themselves to complete or almost complete excision, spread of infection to neighboring structures such as joints, or the onset of spreading cellulitis, osteomyelitis, and septicemia. In such cases, it is essential that the technique of the Carroll treatment be very strictly carried out, and that each part of the wound receives a liberal supply of the antiseptic. We have very often found over a large series of cases that undue delay in sterilization is accounted for by want of attention to the details of the technique of the dressing and of the irrigation. In no system of surgical treatment does so much depend upon the medical officer or sister who does the daily dressings. The dressings and irrigations do not merely set free discharge and relieve pain and pressure as in the older methods, but they play an active part in diminishing the sepsis. The offensive measures against the organisms of the wound are not entirely confined to the serum and phagocytes of the body as heretofore, but a definite part in the offensive is taken by the antiseptic. The success of this part of the offensive depends, therefore, entirely upon the technique employed, and it is of the utmost importance to give each detail of technique the most strict attention. In those cases in which the efficient practice of the details of technique is above suspicion and delay in sterilization yet occurs, it may be necessary to consider the question of further surgical measures. In the bone cases, if there be sufficient access to all infected parts, sterilization should be persisted in, and if possible, more Carroll tubes inserted into the wound and irrigation carried out at more frequent intervals, for example, hourly. The most gross suppurations in bone can often be sterilized in 4 to 6 weeks in this way, as, for example, in the case of astragalectomies with severe suppuration of the tarsal bones. Where access to the bone or base of the wound is not readily obtained and there is undue delay in sterilization, as shown by successive smears, it is well to subject the wound to a further and more complete surgical exposure and preparation. The risk of septicemia is not unduly great if care be taken in handling the tissues, and hypochlorite irrigation recommenced vigorously immediately after the operation. Effect of other methods of treatment on the sterilization of wounds. The older methods of wound treatment, such as daily dressings with irritating antiseptics of the beniodide of mercury, carbolic acid, and methylated spirit types, daily dressings with usol and hypertonic saline treatment, have deservedly fallen into disuse in routine work. If either of the two latter methods is employed as subsidiary to the Carroll-Dakin treatment in the course of the sterilization of a wound, a contingency which occasionally arises, the wound is very apt to become reinfected, the organisms present rapidly multiplying and invading the wound in large numbers. Time is lost, and some days of active Carroll treatment are required to bring the wound again to its former condition as regards degree of infection. The group of antiseptics introduced by Browning and his co-workers for the treatment of gunshot wounds, viz. the flavine compounds and brilliant green, are in a different category. Their action and uses are discussed in the chapter on antiseptics, page 223, and the information obtained by the study of successive smears of the wound exudate when these antibiotics are used is also set down. It is shown that when flavine is employed on severely infected wounds, the number of cells and of organisms in the exudate diminishes markedly for the first 3 to 5 days, but that after that time the number of organisms increases and does not show the tendency to gradual and rapid fall which is seen in the case of wounds treated by the Carroll-Dakin method. The organisms which reappear in the discharge are not mainly cocci, as in the later stages of the latter method, but include a goodly proportion of spore-bearing anaerobes and of coliform bacilli. Thus the effect of flavine on the organisms in the wound, as judged by smears, is quite different from that of the hypochlorite solutions, and hence, by the use of a combination of antiseptics in the sterilization of a wound, it is possible sometimes to break up the symbiosis, vide page 46, of the organisms, and so produce a more rapid sterilization. It has already been shown elsewhere that the symbiosis of organisms is a most important factor in maintaining their virulence and power of growth. In a number of cases, this method has been used with success, flavine or brilliant green being employed in the form of gauze dressings for the first few days, and after that the Carroll-Dakin method being substituted. This, however, complicates the procedure, and we prefer the Carroll-Dakin method from the commencement, except in non-gangrenous wounds in which complete or almost complete excision appears to be possible. It has been frequently observed that if a wound has been almost completely excised at the primary operation, and either flavine or brilliant green then applied, clinical sterilization becomes complete in a considerable proportion of cases. In such successful cases, it is of course unnecessary to substitute the Carroll-Dakin method at a later date, but in the less favorable cases, it is well to substitute that treatment after 3 to 5 days. This method has been successful in our hands with the smaller flesh wounds and a few cases of compound fracture. It has not given good results in wounds already gangrenous, or in those which have become so through incomplete excision. In these, the solvent action of the hypochlorite solutions has been invaluable in removing sloughs and producing comparatively rapid sterilization, as has been already fully described. End of Chapter 6, Part 1. Recording by Pamela Nagami. Chapter 6, Wound Infections Continued, Part 2, of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Pamela Nagami, MD. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 6, Wound Infections Continued, Part 2. Section 5. The End Results of Local Infection. Primary and Secondary Suture of Wounds. In the modern treatment of all war wounds, except the very smallest, there are only two methods of final closure of the wound which deserve consideration at all. These are primary suture and secondary suture. The older method of allowing the wounds to heal by second intention is far too slow, uneconomical, and unsatisfactory for application to the wounds of this war. Surgical excision of war wounds is now universally recognized to be the correct preliminary procedure in the great majority of cases in order to reduce the dangers consequent on infection. Excision leaves large gaping wounds which, if left to heal naturally by granulation from the bottom, would keep men in hospital for many months, would entail enormous expenditure on dressings, and would result in broad, painful scars easily chafed and ulcerated by a soldier's equipment, and rendering the wounded man in most cases unfit for further active service. Primary suture. When excision of a wound has been performed at the casualty clearing station as a rule, the question arises as to whether the surgeon should suture the wound primarily, or whether he should leave the excised wound surfaces open to be treated by some antibacterial method until infection has been sufficiently subdued to permit of secondary suture being performed. Primary suture is undoubtedly the best from every point of view if it can be safely performed. The criteria for primary suture of wounds are so far mainly clinical. The bacteriological aspect of wound infection at this stage has not yet been sufficiently worked out to permit of a bacteriological criterion being formulated. In this respect, primary suture differs markedly from secondary suture, and hence the results of the former are much less uniform and uncertain. The essentials of primary suture are as follows. Number 1. Excision of the wound should have been performed preferably within 12 hours and in no case later than 24 hours after the infliction of the wound. When infection spreads in a wound tract, the bacteria at first lie on the wound surfaces. As infection progresses, however, they find their way into the deeper tissue layers, where they are much more difficult of removal. After 24 hours, the chances of removing the complete infection by ablation of the wound tract are much diminished. Number 2. The wound should be as far as possible completely excised. This is a purely surgical matter. It is difficult, if not impossible, in some wounds. It can, however, be accomplished in some apparently hopeless cases by the method of piecemeal excision. The method of preliminary staining of the wound tract with brilliant green, as used by Hay, appears to give valuable information as to the extent of the tract and therefore of the surgical procedures required. Footnote: British Medical Journal, October 6, 1917. End footnote. Number 3. An antiseptic should be used in the wound, which is non-injurious to the tissues, acts well in the presence of serum, and has a prolonged action. Such an antiseptic we now have in flavine, and to a slightly lesser extent in brilliant green. Number 4. The presence of gas gangrene is a contraindication. Number 5. A surgeon thoroughly experienced in war surgery is essential. A small series of wounds in which these conditions were satisfied, and including even compound fractures, did extraordinarily well with primary suture and avoided all the dangers and complications associated with open septic wounds. such wounds resulted in little more disturbance than a clean surgical operation. There is always infection in such wounds, for no matter how complete the excision, it is next to impossible to secure that the new wound surfaces remain absolutely uncontaminated. The infection which remains, however, is mostly superficial and is easily disposed of, while in that condition, by the application of flavine or brilliant green to the wound before suture. The flavine should be applied freely to the wound surfaces. The suture is then performed over the antiseptic, and in most cases a Carroll's tube is left in the wound and fixed at one corner by the sutured edges. Through such a tube, flavine can be liberally applied to the wound surfaces on the operation table, and subsequently at 6-hourly or 8-hourly intervals for 2 days. The other method of application of antiseptics in the form of pastes in cases of primary suture is referred to elsewhere, page 235. If in any case of primary suture, sepsis of any considerable degree appears in the wound within a few days, the wound should be reopened and the Carroll-Dakin treatment applied. Secondary suture. At the present stage of war surgery, this is the more common and more convenient of the two methods of closure of wounds. It is an essential part of the Carroll-Dakin treatment, which has been designed to obviate the risk which, except in the most capable and experienced of hands, are associated with primary suture, and at the same time to produce an end result which is almost as good as that obtained by primary suture. After the wound has been excised as far as possible, vigorous and continuous sterilization of the reinfected surfaces is carried out by means of Dakin's solution or Usol applied through Carroll's tubes. The wound, having passed through the stages of infection which have been above described, is ready for secondary suture when it reaches the stage of clinical sterility. The bacteriological standard of clinical sterility is usually estimated at an average of 1 organism per field, but the authors have, as already stated, obtained better results by using the lower standard maximum of 0.4 per field or 2 organisms per 5 fields. The personal factor enters into the estimation to some extent and may account for some of the difference. In most cases, however, we have found 1 per field too high for perfect primary union. Bacteriology and secondary suture. In a series of some 600 secondary sutures performed at a base hospital, it was clearly proved that clinical tests alone for secondary suture were unreliable, and that the only sure way of avoiding failures was to rely upon the bacteriological control. For example, not a few cases occurred in which the wounds looked clean enough clinically for suture, and yet films showed the bacterial count to be from 20 to 50 organisms per field. Any attempts that were made to suture such wounds ended in disaster. The wounds never healed by first intention. Some gaped in great part and healed slowly. Most of them broke down completely and required re-sterilization. Again, in a small number of early cases in which a bacterial standard of 2 per field was adopted, the sutures yielded results much inferior to the later ones. The more nearly the wound approaches to bacteriological sterility, the more certain is a good result with primary union, and in many of our suture films taken just before suture showed no organisms visible in 20 or 30 fields. These cases never failed to result in absolute primary union. Standards for secondary suture. 1. Clinical. The clinical site must not be neglected. The wound must be free from conditions surgically contraindicating closure, such as presence of dead bone, spread of infection to unexposed parts of bone, joints, etc. It must be remembered that smear counts show only the extent of infection in the part or parts of the wound from which the smears were made, and while there is seldom any fallacy, if the rule be followed, of taking smears always from the parts of the wound that appear most dirty, yet in a number of cases unskilled smear taking may give erroneous results. This is most likely to be the case when a large amount of blood is taken up with the wound exudate, and it is important to take the smear from the most suspicious part of the wound, seat of fracture, base of sinus, bottom or depression, or whatever it may be, without making the granulation tissue bleed more than is unavoidable. If smears are spoilt in this way, they should be taken again at the next dressing. In nearly all cases, when the bacteriological criterion is satisfied, the wound looks clean, although the converse is not nearly so true and cannot be quite relied upon even after a long experience. Number 2, bacteriological. The procedure is as follows. When the wound presents a healthy red and dry granulating surface, or in other respects has every appearance of being clean enough for suture as judged by experience, a smear is made in the manner described, page 104, from the most suspicious part of the wound and stained with carbol-methylene blue. The film is made immediately after the dressings are removed from the wound and before any of the exudate is washed away from the wound. If the result be satisfactory, the examination is repeated on the following day, and if still satisfactory, the wound is passed for secondary suture. An unsatisfactory result after a reasonable time for sterilization may suggest to the surgeon a possible hidden focus of infection, for example, sequestrum, foreign body, or some fault in the surgery of the wound or technique of the dressing. In these cases, the bacteriological examination should be repeated after a few days. The bacteriological standard which we have found satisfactory is the presence in 2 successive daily films, prepared as above, of the following features. A. The average number of organisms not exceeding 0.4 per field, that is, 2 per 5 fields, and in no case including large, stout, gram-positive bacilli, which are likely to be Bacillus perfringens. The presence of this organism is an absolute contraindication even in the absence of clinical signs of gas infection. B. The polynuclear leukocytes healthy and preferably not too abundant. C. The macrophages relatively numerous. When these criteria are satisfied, the healing of the secondary suture by primary union is almost a mathematically certain result. In our series of 600 secondary sutures, including a large proportion of fractures and also a certain number of experimental cases, there were just over 90% of primary unions. In the remaining 10%, various degrees of gaping occurred from 1/2 inch to 3 inches in width. Complete breakdown of the wound occurred in not more than 8 cases. Resuture was performed in 4 cases. Reactions following secondary suture. Where sterilization of wounds has proceeded uninterruptedly and has been completed, according to the above standards, within 2 or 3 weeks, the local and general reactions following upon the operation of secondary suture are very slight or absent altogether. In the larger wounds, there may be slight redness and swelling around the wound, and the temperature may be raised a degree or 2 for 1 or 2 days. In most cases, there is no reaction at all. In cases of delayed sterilization, however, it has been very constantly observed that more severe local and general reactions follow the operation, and not infrequently the sutured wound may appear to be on the point of breaking down 2 or 3 days after the operation. There may be local redness, tenderness, swelling, and exudation, and the temperature may reach 102 degrees Fahrenheit on the evening following operation. In most cases, the whole inflammatory disturbance settles within 4 to 6 days, and the temperature is rarely elevated for more than 2 or 3 days. Suppuration hardly ever occurs, provided the wound be not reopened. In these cases of delayed sterilization, there is a considerable thickness of granulation tissue in the opposed wound surfaces. In the rapidly sterilized wounds, the amount of granulation tissue formed is minimal. We believe that it is the thickness of granulation tissue in the wound rather than true sepsis which gives rise to the reactions. When the 2 granulating surfaces are brought together, enclosing a small number of organisms, some of which are, however, deeply embedded in the walls, a free exudation of lymph and leukocytes naturally occurs from this large amount of highly vascularized tissue. The infection is, however, practically never sufficient to cause death of the leukocytes and pus formation, but it usually becomes rapidly subdued. Diapedesis of the leukocytes back into the circulation takes place, and the reaction subsides. The important practical point, therefore, to be learned from such cases is that these reactions should be expected in the case of wounds in which sterilization has been delayed, that the stitches should not be removed unless with very good reason, and that the reaction should be aided by the application of heat. We have found these measures adequate in the majority of these rather troublesome cases, and gaping of any considerable extent rarely occurs. The resulting scar, however, is never so neat and associated with so little loss of function as in the case of rapidly sterilized wounds. Secondary suture over bone. Compound fractures and amputation stumps are no less suitable for secondary suture than flesh wounds. Especial care must be taken that the requisite degree of sterilization has been reached before suture is attempted. The clinical and bacteriological standards are the same in all cases. In a series of 600 secondary sutures, more than 200 were sutures over bone, and primary union was obtained in almost 90% of these sutures. It is astonishing how well these bone cases can be sutured after sterilization by the Carroll-Dakin method. The end results are hardly less favorable than those obtained with flesh wounds. Partial suture. This is a convenient operation in certain types of wound in which there is a large fleshy portion which is easily sterilized, together with a bony or ligamentous portion which is more resistant to sterilization. In such cases, it is often desirable to suture the fleshy portion as soon as it reaches the condition of clinical sterility, in order to avoid excessive granulation tissue formation and subsequent scarring in a large wound. The bony or ligamentous part is not, however, at that time sufficiently sterilized for secondary suture, and it becomes a question whether the wound should be left until the whole is sterilized, or whether the fleshy portion should be sutured at once and the other portion left open. The latter procedure can safely be followed in a large number of cases. After the suture of the fleshy part of the wound, sterilization of the other part is continued until it in turn is ready for suture. A typical example is the following. Patient H was wounded in the shoulder and upper arm by a piece of shrapnel on May 8, 1917. Parts of the head of the humerus and acromioclavicular articulation were blown away, exposing the shoulder joint and cancellous bone of the head of the humerus. The missile had passed along the length of the upper arm, producing a long, narrow flesh wound in deltoid, biceps, and triceps almost as far as the elbow. The wound was excised and treated with Carroll tubes. The fleshy part was found to be clinically sterile on the 14th day, while the bony part of the wound still gave a smear count of 20 per field. The fleshy part was sutured, and Carroll tubes were left in the upper bony part, which became ready for suture in its turn on the 24th day. The suture was then completed over the bone. Both sutures resulted in primary union. The preliminary partial suture did not in any way interfere with the sterilization of the bony portion, nor was it itself affected by that sterilization. Section 6. The local infection in wounds of serous cavities. Wounds involving the serous membranes, the peritoneum, the pleurae, meninges, and synovial membrane of joints are fully considered in the chapters on these special regions. It is only necessary here to indicate in a general way how the local infection in serous membranes differs from that in the less highly specialized tissues such as muscle and fascia. The serous membranes, bathed in fluid and forming layers which line potential spaces, offer a much diminished mechanical resistance to the spread of well-established infection in virtue of the ease with which infected fluid may pass along their surface. The mechanical resistance to the passage of fluid in serous cavities is much less than that in the denser tissue structures, and even considerably less than that in the areolar tissue spaces or the space between muscle fiber and sheath. If the spread of infection in any tissue is conveyed from point to point in the fluid which surrounds an inflammatory focus, and this seems to be the usual rule and to hold even in the case of spreading gas gangrene, page 156, there is little wonder that infection may sometimes spread through serous membranes with great rapidity, since the mechanical resistance offered to the passage of the fluid is overcome by a pressure little greater than zero. That such mechanical considerations largely determine the path of spread of infection is shown in the case of the knee joint, where the spread from anterior to posterior pouches takes place under the influence of gravity, not between the ends of the bones, but by a path of lesser resistance around the sides of the joint between the layers of synovial membrane. From the mechanical point of view, therefore, these serous membranes are handicapped in dealing with infection. On the other hand, the vital resistance of these membranes to infection is of a very highly specialized kind. They are all rich in the two chief elements of the bodily defense, serum and phagocytes. They are, even under normal conditions, large lymphatic spaces, and at the slightest approach of infection may become flooded with the protective lymph. This is well known in the case of appendix abscess just prior to rupture, where the peritoneum becomes flooded with a protective non-infected fluid. We have observed the same phenomenon in the case of large sloughing dysenteric ulcers, where colotomy has been performed when the ulcers appeared to be almost on the point of rupturing. The serous membranes have then the advantage of an immediate rally of normal agglutinins and other antibodies whenever the slightest infection appears. Further, the phagocytes in these serous fluids are especially numerous and active. The membranes are lined with endothelium, whose cells readily become separated off as the well-known actively phagocytic macrophages. There is thus a much greater preliminary supply of macrophages in this than in any other tissue, and the vital resistance to infection is correspondingly higher. Intraperitoneal injection of organisms into animals is usually less dangerous than subcutaneous or intravenous injection, unless the organisms be so virulent or the animal so susceptible that the channel of entry makes no difference. Peritoneal fluid removed soon after intraperitoneal injection of organisms shows a very active phagocytosis on the part of the macrophages. The phagocytic power of the serous membranes is therefore considerably higher than that of most of the other tissues. A further element in the specialized defense of these membranes is the power of gluing themselves together, which they all possess in common. This element of defense is more concerned with well-established infection and is a later phenomenon designed to counteract or limit the mechanical ease of the spread of infected fluid which is associated with the anatomical structure of the membranes. The lymph, which is poured out in quantity, coagulates after some time, forming a plastic exudate which firmly binds for a time the two membranes together at the points of apposition. This coagulated exudate may later be dissolved if the infection be sufficiently virulent, and it is then that the mechanical factor enters and the infected fluid spreads widely and rapidly throughout the membrane. In many cases, however, the coagulated lymph forms a sufficiently strong barrier, and it becomes the basis of still stronger fibrous adhesions which completely wall off the infection, which may thus end in abscess formation or may be overcome without such result. The evidence derived from penetrating and perforating gunshot wounds of the serous cavities supports the theory that the serous membranes are all highly resistant to commencing infection. In abdominal wounds with perforation of the gut, the prognosis is remarkably good if the continuous supply of infecting organisms is stopped by early suture of the perforations. The peritoneum is well known to be capable of dealing with a large amount of fecal infection, provided the source of supply be cut off. The pleural membranes also are resistant, but here the problem is usually complicated by the presence of a large amount of altered blood, which provides pabulum for the organisms and prevents ready access of the macrophages and lymph to them. In spite of this disadvantage, however, the majority of these hemothorax cases remain sterile. The meninges are resistant to pyogenic organisms in gunshot wounds of the brain. If the foreign body be removed and the dura mater sutured, the meninges can be trusted in most cases to overcome the infection which has been left behind. Even in suppurating encephalitis, although the path of entry has been through the meninges, there is often nothing more than a hyperemia of the meninges without actual pus formation. When purulent meningitis does occur, it is usually long delayed, often after days or weeks of purulent encephalitis, provided that the effects of intracerebral pressure have been counteracted by operation. Joint and bursal synovial membranes reveal the same power of resisting commencing infection when they are put under favorable conditions. If absolute fixation of the knee joint in the position of slight flexion be carried out, with suture of the hole in the synovial membrane and application of pressure pads to prevent spread of infected fluid to dead spaces in the posterior pouches, the synovial membrane can deal with any of the ordinary bacteria of wounds, with the possible exception of Streptococcus pyogenes. The truth of this is borne out by the statistics of a large series of penetrating wounds of the knee joint, which we have treated, pages 375 and 380. Lastly, the incidence of gas gangrene in the serous membranes throws further light on their resistant nature. Its incidence in gunshot wounds of these structures, except in the case of the pleuri, is so rare as to be almost negligible. That the infection is there is beyond doubt, for Bacillus perfringens and other anaerobes are not uncommonly cultivated from the exudates in penetrating wounds of serous cavities. The pleural cavity is a special case on account of the blood which is present. Even here, gas infection is often localized, and its commencement can be traced to the mass of altered blood. The subsequent progress of infection in serous cavities, where the infection has not been left to be dealt with entirely by the membrane, but where the cavity has been opened, does not differ materially from that in the tissues generally. The Carroll-Dakin method has been successfully applied to all the joints and to at least the pleural cavity. The microscopic history of these wounds follows fairly closely the lines of the type description. Sloughing, granulating, dry, and sterile stages succeed one another, but there may be great variation in the length of these stages, owing to the difficulty of obtaining free access of the hypochlorite solution to every part. Secondary suture, both of joints and pleuri, have been successfully performed according to the principles already discussed. The general infection and bodily response, toxemia. Every inflammatory focus is associated with some degree of toxic absorption, causing general systemic poisoning or toxemia. Toxemia arising from infected wounds varies greatly in severity. The slighter forms may give rise to nothing more than slight general discomfort, or to mild symptoms such as loss of appetite and constipation. The temperature may not be raised more than 0.5 degrees. On the other hand, toxemia may assume extremely grave forms, simulating closely the various septicemias. The two chief varieties of toxemia following infected wounds are 1. Toxemia due to pyogenic organisms. 2. Gas gangrene toxemia. 1. Toxemia due to pyogenic organisms occurs in all cases during the stage of inflammation and during the stage of suppuration, when pus is confined under pressure. In the case of an excised wound undergoing treatment by the Carroll-Dakin method, the temperature is not infrequently raised during the earliest stage of the sterilization process, and malaise, weakness, wasting, and other well-known symptoms of toxemia may be present in greater or lesser degree. This is due, in most cases, to incomplete excision of the wound, leaving minute diverticula in the walls. Into these diverticula the hypochlorite solution does not penetrate, and small quantities of pus therefore become confined within them under some pressure. The toxins produced in these spaces are not washed away from contact with the tissues, and absorption into the general circulation occurs. The more complete the excision of the wound, the less is the toxic absorption, and the converse holds equally. In the ordinary cases, the minute diverticula become obliterated by granulation tissue in the course of a few days, and the temperature falls and toxic symptoms cease. In exceptional cases, however, the mouth of a diverticulum may become closed, leaving pus confined within the tissue. Tracking of this pus between the tissue planes is then liable to occur, and localized collections of pus of varying extent may be formed in the neighborhood of or remote from the wound. Such tracking pus and collections of pus not uncommonly take many days or even some weeks to localize themselves, and during all this time toxic absorption proceeds steadily. In such cases, severe and prolonged toxemia may be produced, and the temperature chart and general condition may closely resemble that of streptococcal or other septicemia. In the earlier stages, it is often very difficult to discriminate between the two conditions, but as time goes on, the difference becomes more apparent. In severe toxemia, there is a swinging temperature, pallor, weakness, wasting, and there may be loss of appetite, constipation, etc. If the condition is prolonged, amyloid changes may occur in liver, spleen, kidneys, and intestine, with resulting hepatic or splenic enlargement, polyuria, or diarrhea. Seldom are there seen, however, the more severe and characteristic symptoms of septicemia, such as rigors, sweating, and rapid pulse, etc., and the most important of all, the syndrome mentioned in connection with streptococcal septicemia, namely, number 1, dry furred tongue, number 2, tremor, number 3, tetanoid spasms. In the early stages, however, say during the first week of the condition, it is often impossible to tell whether a case is one of toxemia or of septicemia, and in all such cases, in view of the importance therapeutically of an exact diagnosis, it is desirable to have a blood culture performed. See septicemia. One case with accompanying chart may be quoted to illustrate these points. Patient R, toxemic temperature from retained pus. Patient R, RFC, was wounded by HE in the left leg and foot and left buttock on November 28, 1917. He sustained a compound fracture of left tibia and fibula. The wounds were excised and treated with Carroll's tubes. 12 days after infliction of the wounds, the temperature, which had been just above normal, became high and intermittent. The chart was not altogether like that of a streptococcal septicemia, in which the temperature is usually high and remittent with occasional intermissions. However, his tongue was clean, his pulse good, and there was no tremor. A blood culture performed on 2 occasions, December 15th and 22nd, was in each case sterile. As he appeared to be going rapidly downhill, the foot was amputated on January 6, 1918. Dissection of the foot and ankle after amputation showed that the ankle joint contained pus and had become ulcerated, and the inferior tibiofibular articulation was sloughing. The astragalocalcanean joint was also filled with pus. It is possible that early astragalectomy in this case would have saved the limb. After amputation, the intermittent character of the temperature chart, toxemia from retained pus, completely changed, and the temperature gradually fell. Its rather slow fall was due to an ulcerative fasciitis, which occurred just after the operation. The latter part of the chart, showing high intermittent temperature and gradual fall to normal after the operation, is appended. Another way in which severe toxemia may arise is from the retention of pus within cavities such as joints. The knee joint, on account of the multiplicity of its pouches, is the most likely of all to give rise to this condition. In most cases of penetrating wounds of the knee joint, the synovial membrane may be relied upon to subdue the infection if it be put under the proper conditions, page 372. But in certain cases, especially where Streptococcus pyogenes is present, the inflammatory process proceeds to pus formation, and unless each infected pouch be opened and freely irrigated, pus will be retained under pressure and a severe toxemia will occur. Such toxemia is very apt to be followed by actual streptococcal septicemia. 2. Gas gangrene toxemia, in its severer form, is a very grave condition associated with the spreading type of gas gangrene in wounds. There is extreme prostration, an ashen pallor, jaundice, vomiting, and very rapid feeble pulse. Hemolysis of the blood may occur. The condition and its treatment are fully described in the chapter on gas gangrene, page 164. It is apparently due to the absorption of powerful poisons formed by the disintegration of the protein molecule of tissue cells through the activity of the gas-forming bacilli. In certain cases, it is followed by gas gangrene septicemia and pyemia. General bodily response in toxemia. The nature of the toxins produced by bacteria growing in the tissues has already been considered, page 99. They are substances allied to albumoses, formed either from the bacterial protein or the tissue protein. They attack tissue cells either before or after absorption into the circulation, and the cells respond by producing specific antitoxins which antagonize both bacteria and toxins, and this they do apparently in a considerable variety of ways, page 100. The production of these antibodies, which is one of the main elements of the bodily defense, is dependent, on the one hand, on the stimulation of the tissue cells produced by autoinoculations of toxin, and, on the other hand, on the vital activity or healthy character of these cells. The other element in the general bodily defense, the overproduction of phagocytes, seems to depend upon chemiotactic influences from the septic focus, which are practically automatic, and the degree of this reaction is therefore most closely related to the degree of vital activity of the patient. In order, then, to raise the level of a patient's general resistance to infection, it is possible to work along two distinct lines. 1. Increase of the antitoxins through regulation of the toxin supply, and 2. Increase in number and potency of the antitoxins and of the phagocytes through improvement of the patient's physical condition. Of these, number 1 is concerned with vaccine and surgical therapy, and number 2 with general treatment. The importance of the latter has been already frequently noted, and a few words on the subject will suffice here. It is obvious that conditions such as fatigue, shock, hemorrhage, and chronic diseases like malaria, which are all common accompaniments of present-day war wounds, must have a deleterious effect on the vital activity of the patient's cells, on which is dependent antitoxin and phagocyte production. The prevention and treatment of these conditions is considered in the chapter on general treatment of wounds, page 238 and elsewhere. The influence of malaria in producing a chronic indolent granulating condition in the wounds of certain of those who suffer from the disease, as well as its influence in favoring certain more acute types of sepsis, such as erysipelas and cellulitis, is also indicated, pages 215 and 216. The harmful effects of a prolonged period in bed, with consequent interference with digestion and nutrition, must also be emphasized, and it should be noted that soldiers as a class are generally benefited by getting out of bed earlier in convalescence than may be applicable to the general public. Thus, in the case of compound fracture of the femur, the patient is now, in the normal course of events, kept in bed not longer than 3 weeks, and is then made to move about on a walking splint until firm union and healing are obtained. The effect of such early ambulatory treatment is most marked in producing rapid elimination of toxemia and infection, as well as rapid healing. Patients whose evening temperature has been constantly 99 to 100 degrees F often show a permanent fall to normal within 1 or 2 days of getting up onto the walking splint. In the same way, The early application of massage should be ordered, and early facilities for exercise and getting out into the open air given wherever possible in order to improve general nutrition. By attention to all these details and by carrying out appropriate measures, much can be done to raise the general bodily resistance, and by so increasing the vital activity of the tissue cells to bring about an increase in the number and power of the defensive elements. With regard to number 1 above, the regulation of the toxin supply from an infected wound may be brought about by surgical and bacteriological means. The surgical measures are the general ones of excision of wounds, removal of foreign bodies, immobilization, and antiseptic treatment. All of those measures are directed toward removing sources of gross toxin production. Immobilization is very potent, especially in the case of compound fractures and joints, in cutting down excessive and irregular autoinoculations. Such autoinoculations of toxin do the patient harm. The doses are unregulated, and they are not timed to act upon the antitoxin producing cells in such a way as to obtain the maximum response. When an animal is inoculated with a dose of toxin, there is, as Wright showed many years ago, a negative phase of variable duration during which the tissue cells are under the influence of the toxin and the amount of antitoxin in the blood is minimal. This is quickly succeeded by the positive phase, during which there is overproduction of antitoxins and the bodily defenses are at a high point. A second inoculation during the negative phase is very harmful to the animal and may do lasting or permanent injury. A second inoculation during the positive phase, however, produces no harmful symptoms, provided the dose be not too great, for excess toxin is quickly neutralized by the abundant antitoxin. Moreover, the end result is a further increase in the available amount of antitoxin. It follows that ill-timed or excessive autoinoculations are harmful in their immediate and remote effects on the patient's general condition and reaction, and prejudice greatly his recovery from the infection. Nowhere, perhaps, in the range of medicine or surgery is the clinical evidence for the above pathological considerations so striking as in cases of active pulmonary tuberculosis. But they hold also in the case of infected gunshot wounds, and although autoinoculations are in most wounds controlled by surgical means, there are certain wounds in which autogenous vaccines are helpful in producing the desired effect. Vaccine therapy in wounds. Autogenous vaccines may be used with good effect in the treatment of an infected wound. In the vast majority, however, they are now unnecessary because of the rapid sterilization that is effected by the Carroll-Dakin method of treatment. In wounds of the body generally, the infected surfaces can be more or less completely exposed, and their sterilization is then readily brought about through the agency of direct intermittent irrigation with hypochlorite, combined with the normal serological and phagocytic agencies. In most cases, it is inconvenient and unnecessary as a routine measure to stimulate these agencies by employing autogenous vaccines. The method is too laborious for application to large numbers, and there is no evidence that it results in a more speedy average sterilization of flesh wounds or of compound fractures than that which we obtained over a large series of cases without them. That is, 8 to 10 days for the former and 2 to 4 weeks for the latter. We have learned gradually that the more efficient the surgical technique, the less is the need for vaccines. There still remain, however, certain types of wound in which the employment of autogenous vaccines is indicated as a useful adjunct to surgical measures. Such types include the following. Number 1, wounds in which the progress of sterilization is unduly delayed. 2, wounds in which access of the antiseptic to all infected parts is difficult or impossible. And 3, wounds complicated by septicemia and pyemia. In the first 2 of these types, toxemic as contrasted with septicemic types, autogenous vaccines, while undoubtedly helpful, are often insufficient in themselves without further surgical intervention to bring about the required rapid completion of the sterilization process. Autogenous vaccines are clearly indicated and constitute often the only treatment which is of any avail. Number 1. Wounds in which the progress of sterilization is unduly delayed. Delayed sterilization of wounds has been already considered, page 114, and it has been emphasized that often this condition is due to inadequate surgical measures. There are cases, however, for example in compound fracture of the femur, in which further surgical interference may be attended by risks of spread of infection to bone or to the general circulation. In such cases, autogenous vaccines are helpful and may be sufficient to achieve what is wanted. Foreign bodies. If a foreign body be suspected to be the cause of the trouble, the wound should be opened up and an effort made to remove it. Pieces of necrosed bone are generally best left until they sequestrate, and in such cases, vaccines may aid the process. Compound fractures. Where a compound fracture is excessively comminuted, there is often considerable difficulty in sterilizing the wound. Vaccines are then useful, especially at the stage when the chief organism present in smears is Streptococcus pyogenes. This is the organism which is almost always predominant in these resistant cases after the first week or so. Where there is much loss of bone substance with some necrosis of bone and delay in sterilization, vaccines are sometimes of value. But these are obstinate cases, and reinfection of the wound occurs very readily. If vaccines are given, they should be administered in large doses, since the acquired immunity of the patient against the offending organisms is of a high order, and he is usually entirely unaffected by small or even moderate doses of vaccine. In all such cases, the commencing dose of Streptococcus vaccine should not be less than 1/4 slope, or approximately 1,000 million organisms. Flesh wounds. Simple flesh wounds occasionally give rise to difficulty in sterilization for various reasons. Sometimes spread of infection occurs to joints, tendons, etc., and tracking of pus between the muscle planes. General surgical principles must be followed here, and if these fail, vaccines sometimes help to subdue the infection. At times, the difficulty is due to sloughing of tough fascial structures, such as the fascia lata, aponeurosis over erector spinae, etc. It takes a considerable time for such sloughs to dissolve and separate, but they come away well in the end, say 2 weeks or rather more, and it is very doubtful whether autogenous vaccines have any accelerating effect on the process. Technique. Again, as sometimes happens, the trouble may be found to be due to careless or inefficient application of the tubes or of the solution. The wound may then fail to become sterile and may fall into a chronic indolent condition with exuberant granulations containing little crypts and irregularities difficult to sterilize. Vaccines are not very suitable here, as there is often a considerable variety of organisms present. The best treatment is to apply tubes and solution earnestly for a few days, and then to secondarily suture the wound, even though the bacterial standard be somewhat high. There may be a marked local reaction in such cases for a few days, but these wounds usually heal fairly well after suture. General reaction. Sometimes the general reaction is poor, as in badly wounded and shocked men, or men suffering from malaria or other chronic disease. Vaccines are then of very doubtful value, for their whole therapeutic effect depends on the ability of the tissue cells to respond to stimulation, and in these cases this is precisely what is lacking. It is better here first to treat the underlying condition as vigorously as possible, and later, if the general condition improves, to resort to vaccines. Type of infection. Of all the various kinds of wounds which come under this heading, it is those in which the routine smears detect a long-chained Streptococcus as the most abundant organism present, and in which some resistance is displayed to the ordinary rapid sterilization by the Carroll-Dakin method, that are the most likely to be benefited by the exhibition of autogenous vaccines. This we have found to apply both to flesh wounds and to compound fractures. The immediate results are often striking, and the wounds may become very rapidly sterilized. In nearly all cases, however, if the delay in sterilization proves to be due to gross fault in surgical technique, the vaccine is not sufficiently powerful to make up for such a defect, and the wound lapses back into its old state after some days. With increasing experience, we have seen that the more efficient the surgery of the wound, the more likely is the infection to be subdued by the direct antiseptic treatment, and consequently, the less is the need for vaccines. In this type of case, vaccine treatment is always strictly the handmaid of surgery. End of Chapter 6, Part 2. Recording by Pamela Nagami. Chapter 6, Part 3 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Pamela Nagami, M.D. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 6, Wound Infections Continued, Part 3. Wounds in which access of the antiseptic to all infected parts is difficult or impossible. Under this heading is included infected foci in such tissues or organs as the brain, neck, chest, abdomen, and joints, where sufficiently wide excision to permit of thorough application of Carroll's tubes to the infected area is inapplicable. Brain. Where removal of the foreign body from the brain is unsuccessful or impossible, and also in certain other cases, the brain substance may become septic or gangrenous. The Carroll procedure is not applicable here, and as no vigorous direct antiseptic measures can be carried out, treatment by autogenous vaccines is strongly indicated. The organisms required for the preparation of the vaccine may be isolated either from the wound discharge or, better, from the cerebrospinal fluid, if the latter be infected. These are all most serious cases, and we have not had any conspicuous success with vaccines. Neck. Wounds in close proximity to the important structures in the neck cannot in some cases be adequately irrigated, and in some cases, in view of the importance of securing rapid sterilization, owing to the danger of secondary hemorrhage, etc., autogenous vaccines should be administered. This principle is applicable also to cases other than gunshot wounds. For example, in a severe case of Ludwig's angina with much inflammatory edema, after incision and evacuation of the pus, the toxemic symptoms as well as the severe and dangerous character of the local infection will give rise to anxiety. An autogenous vaccine made from the pus contained Bacillus coli, Streptococcus, and Staphylococcus aureus. The first dose of the vaccine was followed by a considerable local and general reaction, after which a very rapid and striking improvement took place. The infection became subdued almost immediately, and the wound was healed 5 days after the vaccine was given. Chest. In infected hemothorax cases, with thoracostomy performed, and in purulent mediastinitis and pericarditis, it is difficult or impossible to secure irrigation of the whole infected surface, even if the Carroll procedure be applicable at all. An autogenous vaccine is then strongly indicated. In most infected hemothorax cases with thoracostomy, the outlook is good, provided that gas be rapidly overcome. But nevertheless, vaccine should be employed in addition to local irrigation. In a number of these cases, in which they were used by the authors, a more rapid elimination of the infection seemed to be achieved. Where, however, collections of pus or infected foreign bodies are shut in, vaccines are useless without surgical intervention, and this general rule has a wide application. Abdomen. Vaccine therapy is frequently indicated in gunshot wounds of the abdomen. The number of possible applications is very varied indeed. One example may be given, viz. a penetrating abdominal wound with subsequent development of cystitis. Patient T, 9th Border Regiment, was wounded by H.E. on August 30th, 1917. He sustained a penetrating abdominal wound, the wound of entry being in the right loin above the iliac crest. Laparotomy was performed next day at the casualty clearing station. No rupture of the gut was found, but surgical emphysema was present around the cecum and ascending colon up to the hepatic flexure. No foreign body was found in the abdomen. A drainage tube was put through the loin wound down to the cecum, the laparotomy incision being stitched up. On September 10th, purulent cystitis commenced. No catheter had been passed prior to this. On admission to the base hospital on September 20th, the laparotomy wound was gaping superficially and was closed by secondary suture on September 23rd. The urine contained a large amount of pus and had an acid reaction. Micturition was painful, and at the end of the act, pure pus escaped from the urethra. The bladder was washed out daily with potassium permanganate solution and a mixture of urotropin and acid sodium phosphate given by the mouth. Treatment on these lines for a fortnight yielded absolutely negative results. On October 5th, the urine contained as much pus as ever, and the pain was in no way improved. A catheter specimen on October 3rd yielded abundant Bacillus coli and Staphylococcus aureus on culture, and a vaccine prepared from these organisms was given on October 5th. The first dose of the vaccine, 1 cc, contained 1/15th slope Bacillus coli and 1/15th slope Staphylococcus aureus. Its injection was followed by slight local reaction and by distinct improvement in his symptoms. The washing out of the bladder was entirely stopped from October 5th. On October 8th, 2 cc of the vaccine was injected, and this was followed by a slight local and general reaction. He had malaise for a day and his temperature rose to 99.2 degrees Fahrenheit. Micturition was now painless and the urine clear. A third injection of the vaccine, 3 cc, was given on October 11th, followed by slight local and slight general reaction. Temperature rose to 99 degrees F and he vomited. Examination of the urine on October 13th showed it to be quite free from pus and in every way normal. All urinary symptoms had by this time subsided, and the patient was up and very well. He was dismissed to the convalescent depot on October 24th. In the above case, the result of autogenous vaccine treatment on an established chronic purulent cystitis was very striking. Joints. When penetrated joints are treated by the dry method, page 369, the fluid aspirated from the joint may be utilized for the preparation of a vaccine. The knee joint is the most important of this class. In most cases in which the infection is other than Streptococcus pyogenes, the infection in the knee joint is subdued within a few days by the proper application of the dry method. Some infections, however, are more persistent, and it is desirable that the help afforded by autogenous vaccines should be utilized. When joints are opened and treated by the Carroll-Dakin method, it is always advisable to aid the treatment by the use of vaccines, owing to the difficulty of securing that each and every part of the joint surfaces receive the antiseptic irrigations. In all cases in which Streptococcus pyogenes is the predominant organism, vaccines should be used, for in general, the results obtained with vaccines prepared from this organism are remarkably good. 3. Wounds complicated by septicemia and pyemia. These are the cases par excellence for the exhibition of autogenous vaccines. They constitute valuable specific treatment of these diseases, some forms of which are usually otherwise hopeless. The theory underlying the practice of vaccine therapy in septicemia is still somewhat obscure. Vaccines were at first believed to be suitable only for chronic and localized infections, where, owing to infected foci being shut off to some extent, an insufficient amount of toxin became available for stimulation of antitoxin production, which was consequently less abundant than was necessary. It was easy then to see that an extra subnoxious amount of toxin introduced artificially in a vaccine might be the means of stimulating an increased production of antitoxin, which would be absorbed into the blood with consequent beneficial effect upon the infected focus. In toxemic cases with irregular autoinoculations, it was thought possible to regularize and increase the production of antitoxin by the use of vaccines, and such proved to be the case. It was difficult to conceive, however, how vaccine therapy could be applied to acute cases of septicemia, where the organisms and their toxins were constantly in the bloodstream. More recently, it has become recognized that antitoxin is produced mainly by the fixed tissue cells, and in the case of vaccine inoculation, by the cells which surround the site of infection. Thus, it has been shown that if a dose of vaccine be split up into a number of parts, which are injected separately at different sites, the effect produced is very much greater than where the whole dose is injected in one place. It becomes clear, therefore, that the amount of toxin absorbed is not the all-important factor in the production of antitoxins, but that the direct access of the toxin to the largest number of tissue cells is the predominating consideration. It seems then probable that in septicemia, the access of the toxins to the tissues is not sufficiently prolonged or complete to stimulate the production of sufficient antitoxins, and this may serve as a working hypothesis for the vaccine treatment of these conditions. Whatever the rationale of the treatment may be, its value in practice has now been abundantly proved, and there need be no hesitation in adopting it. Moreover, in certain cases where it is desired to produce the effect of a very large dose of vaccine, it is useful to divide the dose and inject it in a number of places. The vaccine should, if possible, be sensitized by the addition to it or the simultaneous injection with it of an antiserum of high specific potency against the organism in question. It is not possible usually to obtain an antiserum immunized against the particular strain of the organism producing the disease. A stock antiserum must in most cases be used. In the case of streptococcal septicemia, a supply of polyvalent anti-streptococcal serum is usually available and should be injected in large doses, 20 cc to 40 cc, just before each dose of vaccine. A larger dose of vaccine can then be tolerated, and in addition, the dissolution of the organisms and liberation of the endotoxin is believed to be more speedy. In serious cases like those of streptococcal septicemia and pyemia, sensitized autogenous vaccines should always be used if possible. The various forms of septicemia or basilemia complicating wounds which the authors have met with are described below, page 189. In the streptococcal type, which is very serious and often fatal, good results have been obtained in some cases. In one case, where the Streptococcus pyogenes was found in the blood and where every symptom and sign pointed to a fatal issue, the patient was saved and cured by sensitized autogenous vaccine. In the same patient, a large pyemic abscess in the lung was similarly cured by a second autogenous vaccine. In septicemia, due to Streptococcus faecalis, which is a much rarer condition, sensitized autogenous vaccines are also indicated. In the very acute virulent form of streptococcal septicemia, death usually occurs before autogenous vaccine treatment can be instituted, and these are hopeless cases. One such case is described with chart, page 193. In the lasting form of streptococcal septicemia, which is fortunately much the more common, there's plenty of time allowed both for the diagnosis of the condition and for vaccine treatment. These are the cases which may be expected to yield good results. The dose of vaccine should be a large one and should be judged by its capacity to give a fair degree of local reaction, redness and swelling. A dose short of this is generally not fully efficient. A tentative commencing dose may be given of 1/4 tripagar or brain auger slope, a dose which usually works out at 750 to 1,000 million organisms. In septicemia or basilemia due to coliform organisms, the clinical course has, in our experience, been comparatively mild and short, averaging 7 to 9 days fever, and in all such cases, specific treatment has not been required. In septicemia, due to gas-forming anaerobes, that is, Bacillus perfringens, the outlook is very bad and vaccines are inapplicable, since the bacilli, being spore formers, cannot be killed at a low temperature or by a low concentration of antiseptics. In one such case, which occurred in our experience, the infection in the bloodstream was double, Bacillus perfringens and Streptococcus pyogenes. In this case, a vaccine made from the latter organism yielded almost magical results for a time, but was unable in the end to prevent the fatal issue. page 204. A case of septicemia due to a diphtheroid organism has been reported to us as having run a severe and prolonged course and having been cured within a few days after treatment by 2 doses of an autogenous vaccine. We have not met with this form of septicemia. Preparation of autogenous vaccines. The technique of the preparation of autogenous vaccines is given in full in textbooks on bacteriology. The laboratories in the field, however, are often scantily equipped, and improvisation of all kinds of material must constantly be made. Electric power is seldom available, and the more elaborate laboratory contrivances often cannot be obtained. Further, the laboratories themselves are usually tents or huts or rooms in houses, and are anything but dust-proof and windproof. Under such conditions, it is often impossible to carry out the elaborate technique described in textbooks, and simple methods are welcomed. The steps in the preparation of autogenous vaccines are as follows. Number 1, obtain primary growths from the infected material, time 24 to 48 hours. 2, obtain subcultures of all the possible pathogenic organisms if necessary. 3, emulsify the subcultures. 4, enumerate, if necessary, and sterilize the emulsions. 5, test for sterility. 6, transfer appropriate amounts of each emulsion to vaccine bottles or vials and label. Steps 3 to 6 should be accomplished within 24 hours. Autogenous vaccines are prepared in 2, 3, or rarely 4 days, according to the conditions. If one organism only be obtained and primary growths are obtained on solid media, the vaccine can be ready for use within 48 hours. If several organisms are obtained and subcultures must be made to separate them, the vaccine takes 3 days to prepare. In cases where the primary growths are obtained in fluid media, for example, blood cultures, the vaccine is ready in 3 days if one organism be found, and in 4 days if 2 or more organisms be found. The latter is a rare event in the case of blood cultures. In all cases, if there be particular urgency, the sterility test may without much risk be omitted, and the periods given can then be shortened by 24 hours. 1 and 2. Primary growths and subcultures, culture media. It is essential to have a rich nutrient medium on which copious growths may be obtained. Ordinary agar is not suitable for the delicately growing organisms such as Streptococcus and Pneumococcus. Enriched protein media have usually been obtained by the addition of blood, serum, or acidic fluid to agar. It is difficult, however, in dusty laboratories to keep such albuminous fluids in quantity sterile, and they are somewhat inconvenient to work with, since the fluids must be added directly before use, and it is not possible to autoclave and store the completed media in a form immediately available for use. In place of such media, we have used for routine vaccine work a medium composed of equal parts of trypsinized brain tissue and nutrient agar. This gives an opaque mixture, but it has powerful nutrient qualities. It is easily prepared, and it can be autoclaved and stored in its completed form. This medium usually supports the growths of such organisms as Pneumococcus, Meningococcus, and Gonococcus. It gives very copious growths of Staphylococcus, Streptococcus, diphtheroid, and coliform bacilli, and most of the other organisms which are met with in routine vaccine work on wounds. Vaccines prepared from this medium should be filtered through 1 layer of lint in order to remove particles of medium from the emulsion. The other medium which we use for the preparation of vaccines is Gordon's trip agar, page 75. This is a more difficult medium to prepare, but it is well within range of accomplishment of even the smaller laboratories in the field. We have used horses' hearts in the preparation in place of bullocks' hearts, which are not obtainable. The serum which we have usually found it convenient to add to the medium before use is Burroughs and Wellcome's normal horse serum. Number 3, sterile vials of which are always readily obtainable. There is no preservative added to this serum. On this medium, luxuriant growths of streptococci, pneumococci, etc. are also obtained, and an additional advantage is that the medium is transparent and colonies of the various organisms take on a more distinctive character and are more readily recognized than those on brain agar. The fact that serum has to be added to the medium before use makes it rather less convenient to use than brain agar. We have been accustomed to use trip agar for obtaining primary growths, especially where a considerable number of organisms are likely to be isolated, as in vaccines from sputum or highly infected pus. In such cases, plates are preferably employed in the first instances, but as an alternative, 5 or 6 slopes may be used. Subcultures are conveniently made on brain agar slopes. Emulsification of subcultures. The diluting fluid is carbosaline solution, 0.5% carbolic acid in normal saline. Varying amounts from 2 to 5 cc's are transferred by means of a sterile pipette to 1 or 2 of the brain agar sloped growths of each organism. The amount varies according to the strength of the vaccine desired. The emulsion is made by rubbing up the growth with a platinum loop and mixing well with the diluting fluid. The emulsion of each organism is then filtered through lint, if the brain agar medium be used, into a sterile test tube containing small particles of broken glass. The latter are made by breaking up a test tube into small pieces in a mortar. Each of these test tubes is then sealed off by drawing out the neck in a flame. A convenient flame for laboratory glass blowing in the field is a painter's blow lamp. This gives a flame hot enough for ordinary work. If such cannot be obtained, a spirit Bunsen burner or even a Primus stove may be used. The emulsion is then shaken by hand for 10 minutes or put in an electric shaker if this apparatus be available. Number 4. Enumeration and sterilization of the emulsions. The enumeration of vaccines is unnecessary as a routine measure in wound work. It is sufficiently established that the effect produced by a vaccine, ceteris paribus, is proportional to the dose. The number of killed organisms, however, which is necessary to produce any appreciable alteration in the reaction is immense in the case of the common organisms of wounds. The enumeration method is therefore unnecessarily delicate in routine work. Since large doses of vaccine are given, such as produce appreciable local reactions, it is found to be sufficiently accurate to estimate the dose as a fraction of a sloped culture. Thus the commencing dose may be spoken of as 1/4 slope or 1/20th slope, and this means that the dose is equivalent to the 4th or 20th part, respectively, of all the organisms in a 24 hours sloped agar or brain agar culture, the latter being made in a uniform way and providing a fairly accurate uniform standard. This method is quite sufficiently accurate for practical purposes, for the dosage of vaccines in wound therapy is tentative and dependent on the individual local reaction. It does not admit of exact standardization, since the other factors, the type and virulence of the organism, are so variable. In routine work, the emulsions in their sealed test tubes are sterilized without enumeration. Sterilization is best carried on by heat at a temperature of 60 degrees C for 1 hour, and this is sufficient in the majority of cases. If a vaccine water bath regulated to 60 degrees C is not available, it can be readily improvised by using 2 or 3 tins, one inside the other, each inner one being supported so that its bottom does not touch that of the outer. In this way, a single or double water-jacketed chamber is formed. If a lid covered with felt be made for the apparatus, the latter can be readily kept at a uniform temperature by the occasional application and withdrawal of heat. In sterilizing the tubes of emulsion, the whole tube should be kept completely immersed in the water, which should be maintained at a temperature of 60 degrees C for an hour. If it be inconvenient to sterilize vaccines by heat, antiseptics may be used instead. The usual antiseptics employed are carbolic acid and formalin. In the former case, the diluent employed is 1% carbolic acid in normal saline, and in the latter case, 1.2% formalin in normal saline. The sterility test is applied after the antiseptics have been allowed to act for an hour or 2. Number 5. Sterility test. This is made by breaking off the sealed ends of the tubes containing the emulsions and inoculating an agar slope with a drop from each tube. No growth after 24 hours incubation at 37 degrees C is sufficient evidence of sterility for practical purposes. Even if a growth is obtained after the above sterilization, the organism is so attenuated that its injection is not followed by growth in the tissues. 6. Transference of vaccine to bottles or vials. The former method is more convenient in military practice. It is convenient to have a number of sterilized small rubber-capped bottles each containing 5 cc carbol saline solution. The bottles containing the diluent and having cotton wool stoppers are sterilized in the autoclave. The rubber caps are boiled in Lysol and slipped on to the neck of the bottles after removal of the temporary cotton wool stoppers. This maneuver is accomplished by means of 2 pairs of sterilized forceps. The rubber caps are wired tightly to keep them in firm position and finally covered over with a thin layer of paraffin wax. The transference of the emulsion from the sealed tubes to the bottles is accomplished by means of a sterile syringe. The amount taken from each tube depends upon the strength of vaccine required. Thus, if a tube contains 4 cc emulsion, representing 1 slope of Streptococcus, and if half of the emulsion, 2 cc, be transferred to a bottle containing 5 cc diluent, the vaccine then contains 1/2 slope of Streptococcus in 7 cc. That is, 1 cc vaccine equals 1/7 slope Streptococcus. The bottle is labeled, the strength of the vaccine being written in such terms as the above, and the amount recommended for the first dose is stated. Dosage of autogenous vaccines. It has been already stated that for practical purposes in vaccine therapy in wounds, it is sufficient to state the dose of vaccines in terms of fractions of an agar or brain agar sloped culture instead of in numbers of organisms. In our own vaccines, we have observed that approximately the average number of organisms in a 24 hours brain agar sloped culture is as follows. 1 brain agar sloped Staphylococcus, 10,000 to 15,000 million organisms. 1 brain agar sloped Streptococcus faecalis, 3,000 to 4,000 million organisms. 1 brain agar slope Streptococcus pyogenes, 2 to 3,000 million organisms. 1 brain agar slope Bacillus pyocyanus, 15,000 to 18,000 million organisms. 1 brain agar slope Bacillus coli, 12,000 to 15,000 million organisms. These enumerations were made by the direct method of counting the organisms in various dilutions of the emulsion tinged with gentian violet in a Thoma Zeiss hemocytometer. We consider this method much more accurate than that of comparative enumeration with red blood corpuscles in a blood film. The figures given above are not, however, standards and must vary according to the individual technique of each worker. The dose of the vaccine should be large enough to produce a fair degree of local reaction with or without a mild general reaction. When no local reaction is produced, the dose is unnecessarily small and time is being wasted. The determination of the first dose is a matter of experience. The correctness of a dose may be gauged by the amount of local and general reaction produced. After the first injection, the doses are regulated according to the reactions produced by the previous one. Since for every dose of toxin there is a proportionate overproduction of antitoxins, the general scheme of increase of doses should roughly correspond to a geometrical progression. The common factors most generally useful are 3/2 and 2. In the former case, with a commencing dose of 1 cc, the scale of doses would be 1 cc, 3/2 cc, 9/4 cc, 27/8 cc, and etc. And in the latter case, 1 cc, 2 cc, 4 cc, 8 cc, etc. If more than 3 or 4 doses are given, a more concentrated vaccine must be made up from the stock cultures and the appropriate doses calculated. The commencing doses, which we have found most usually applicable in local infections with the following organisms, are Staphylococcus 1/12 slope, Streptococcus 1/10 slope, Bacillus coli 1/15 slope. In general infections with Streptococcus, a dose of 1/4 to 1/2 slope may be given with impunity, especially if the vaccines be sensitized by the simultaneous injection of anti-streptococcal serum. Stock vaccines cannot be recommended for wound work owing to the number and variety of organisms and strains dealt with. It is desirable in connection with infections of special structures such as joints, chest, brain, blood, etc., to make complete aerobic cultivations, at least from the exudates or fluids, in order to determine the type of infection. In all these cases, the cultures may be utilized for the preparation of vaccines, if necessary. In cases of delayed sterilization in ordinary wounds, the required cultures can be specially made with very little trouble. Stock vaccines are generally held to be of considerable use in superficial pyogenic skin affections, for example, furunculosis, acne, boils, etc. Even in such cases, however, we have had vastly superior results with autogenous vaccines. When vaccines are used, they should be autogenous in every case, unless where their preparation is absolutely impossible. Even a crudely made autogenous vaccine is to be preferred to a stock one, and the injection of such is justified in serious conditions where vaccine therapy is indicated. End of Chapter 6, Part 3. Recording by Pamela Nagami, M.D.